This group of friends has also written several very prestigious review articles which essentially paved the way for these novel kidney tumor entities to be included in the last WHO classification. The so far last iteration of Kidney Tumor Friends took place last summer. It was organized to honor the memory of Ondra, who tragically passed away in the summer of 2022. If you would like to read more about Ondra and his contributions, not only to pathology, but also about his numerous other activities, including nature protection and conservation, which is a topic I'll circle back to at the end of my talk, I refer you to these obituary articles in Modern Pathology and Workuff's archive. Also, those of you who are sitting in this auditorium, you can read more about Ondra on all these posters around this room. So while we hope Ondra's GU colleagues will be able to organize further Kidney Tumor Friends meetings, we thought that there is really no reason this format should be limited only to GU pathology. Therefore, we have invited all these amazing speakers for almost a week in an attempt to find out whether Ondra's magic formula will work in bone and soft tissue as well. Well, so far it seems to be working pretty well. We met with most of the speakers already on Monday and have made joint trips to Prague and Carlsbad and had a couple of nice dinners together. And although all this included a lot of walking in a very cold, freezing temperatures on slippery and icy roads sometimes, I hope most people had a good time. I definitely had a great time. But now it is time to see whether the meeting will be also successful in promoting its second pillar, that is the scientific part. Before we proceed with this, let me also briefly introduce the main sponsor of this event, which is also the facility where this meeting venue is situated. So the name of this facility is Bioptical Laboratories. Again, in English, this means Bioptical Laboratory, basically. It is a private surgical pathology and molecular laboratory, which provides histological, cytological, and genetic analysis for all types of hospitals and private practices. It was founded in 1993 in Pilsen by my father, Michal, and two of his colleagues, and today is fully owned by Michal. Today it is one of the largest laboratories of its kind in Europe. We have around 300 employees, of which 43 are pathologists and 19 are molecular biologists, and we operate on an area of over 11,000 square meters. This lab also owns significant equity shares in two other labs, one in Slovakia, which is called Cytopathos, and the other called CSD Healthcare in Kiev in Ukraine. This network collectively analyzes over 450,000 surgical specimens a year. We also closely cooperate with the local Pilsner Department of Pathology at the Pilsner Medical Faculty. So what do? We are obviously a surgical pathology lab covering all aspects of the field. So we provide histopathological examinations of all types of surgical specimens. Last year we did close to 170,000 samples a year here in Pilsen. We have a large IHC lab with over 500 primary antibodies, and we do about 80,000 IHC stainings per year. Since a year ago, we've been implementing AI in the analysis of the samples, so we now use AI for prostate biopsies and GYN cytologies for over a year. Our main clients are private physicians and regional hospitals, but also faculty hospitals. We also work as a consultation center for other pathologists from Czech Republic, Slovakia, and other foreign countries. And especially our molecular lab works for pharmaceutical companies, especially with regard to finding a target for their targeted therapies. A very important part of our lab is our cytological department, where we analyze mainly gynecological cytologies, both conventional pap smears as well as liquid-based cytologies, which are then accompanied by AI analysis. And last year we were close to beating the magic 1 million samples per year, which didn't work eventually, but hopefully this year we will do it. We have also a pretty large molecular lab. Primary aim of this lab is obviously the molecular analysis of tumor samples for diagnostic, prognostic, and predictive purposes. We do a lot of NGS sequencing, methylation analysis, still a lot of traditional sequencing or cytogenetics and so on. Also, we perform analysis of non-tumor tissue, such as prenatal testing, microbiological testing, paternity testing, and so on and so forth. Last year, it did over 85,000 molecular tests per year, including 5,000 NGS tests. A very important part for this lab is research. Actually, when my father started this lab in 1993, he did it for two reasons. To improve the diagnostic accuracy of Czech labs, and second, to fund his own research, because It was after the Velvet Revolution, a few years after that. There were no money for research. That was not the priority. So he had a lot of ideas, a lot of material, but he didn't have money for it. So he thought this could be the way to fund it. It took a few years, but eventually it started to work out very well. So our main research focus today are neoplastic processes, especially rare tumors. We don't do basically any basic science. All we do is basically applied research, where we are studying morphological, immunohistochemical, and molecular markers of tumors in order to find novel entities or novel subtypes of tumors or provide novel ways how to accurately diagnose the existing ones. Almost all this research is done jointly with the local Department of Pathology at the medical faculty. We share a tumor registry which currently stores 160,000 cases of mostly rare tumors. The routine archive is separate. There are millions of cases, but the registry includes only rare tumors. About half of these tumors are digitalized, so we can easily obtain the WSI slide. So most analysis for joint research projects are performed at and almost exclusively financed by Bioptical laboratory. We almost don't use any grants for multiple reasons. So this is the physical appearance of the Pilsner tumor registry. Those of you who would like to see the lab around, there will be multiple occasions where you can take a part on a tour through the lab. Today, after the program is done, you can join my father or me on the tours through this lab. So this physical part of the registry comes with this very old, very simple, but very effective database. Basically, each case that is sent to the registry is assigned as special keywords by the submitting pathologist, which should help to obtain these cases very quickly. You can also add another criteria like the number of paraffin blocks or scan slides availability and so on. Then you can, if there is a scan slide, you can immediately see it. So this very much facilitates the research. So in the last 10 to 15 years, we've been publishing some 50 to 70 papers with impact factor per year, including papers in the most prestigious journals. We are very proud that we have a chance to cooperate with dozens of foreign institutions, including labs at institutions like Mayo Clinic or Memorial Sloan Kettering Cancer Center or Cleveland Clinic. Historically, 6 pathologists from our lab have co-authored WHO Blue Books of multiple organ systems. And we every year host dozens of Czech and foreign visitors, mainly pathologists, who come to train with us. I'm very pleased to see many of them here in the audience. Our lab also organizes numerous pathology seminars and other educational meetings, including large international meetings such as this one. We've been talking already about Kidney Tumor Friends, and I would like to also invite you in June this year to AMR Arcadium Rivlin Slide Seminar, which we will be organizing in June this year. So you are greatly welcome to go online on our site and register if you are interested. Also, every Tuesday we are doing a slide seminar at the Multi-At Microscope, where we are showing the most interesting cases from the last week. It's also available online. We are streaming it. It's in English. It's for free. So also, if you are interested, join us on our website. We have many plans for the future, but some plans that might be relevant to this meeting are shown here. We have recently acquired 2 additional houses located right next to our current premises here. And within some 4 or 5 years, we plan to build there additional laboratory spaces as well as a large auditorium for some 400, 500 participants, so that more of us can meet there in person instead of online. Maybe some of you have wondered why there are around the lab so many pictures of nature depicting beavers and wetlands and whatnot. To explain this, we have to circle back to Ondra Hess and the other passion he had besides kidney tumors, namely nature and its protection. In 2021, after a lifelong effort in nature protection, Ondra persuaded his colleagues to establish a special endowment fund for nature protection. And the money donated to this fund, largely by Bioptical laboratory, were eventually used to buy an agricultural land in ecologically valuable areas in order to protect it and conserve it. The largest obtained area has now over 25 hectares. It is some 40 minutes away from Pilsen, near the German border, at the Kateřinsky Creek. It is a favorite habitat for many kinds of animals, most notably beavers, which build their little dams on the creek and help the surrounding wetlands to prosper. After Ondra's passing away, a monument was placed at this site, along with information board about his life, and you can basically come there with a cell phone, which you can use to read a barcode, and this will lead you to a YouTube video, which is 4-year-old, and there is Ondra standing at this place and basically talking about his dream coming true. So this is the end of my introductory talk. Just last few information. In case anybody from the audience has a question, please always wait for the microphone, otherwise the people online will not hear you. Please also try, if possible, to be visible for this camera right here. If you're standing behind a column, maybe step a little bit to the right so they can see you a bit. We will be also trying to stay on time, but I expect it will not always work 100%. So if we go over time, the upcoming break will be shorter, but the next session starts in the scheduled time, because we want the online participants to be able to rely on the schedule. So let's see what's on the schedule first. We will start with a slide seminar where our two stellar speakers, Dr. Abbas Agaimy and Dr. Cristina Antonescu, will show us some really tricky cases. And now it's my great pleasure to invite the first speaker, Dr. Abbas Agaimy, from the University in Erlangen in Germany. As probably everybody knows, Abbas is an expert in multiple areas, including most notably pathology of soft tissue, head and neck, gynecological and urological tract. And his set of cases kind of reflects his varied interests, this huge scope he covers. So please, Abbas, have a seat.
Thank you, Michal, very much for the kind introduction. Indeed, I keep my love to the kidney tumor friends, so I have the kidney tumor box of the German division of the IAP to put my soft tissue slide in, which is very normal for me. Anyway, I have two talks in this conference. One will be about phenotype concepts in soft tissue pathology, and later on mesenchymal head and neck neoplasm. And I just put together a couple of cases to show some, maybe not really deeply thought of, but collected them from what at hand to show some tricky features that we encounter. And indeed, I think our best name would be mesenchymal, better than soft tissue pathology, because we are doing everything in every organ that is mesenchymal mostly. So this is the first case. I have, unfortunately, no PowerPoint not to lose much time, but I will give you the brief history. This first case concerns a 53-year-old male with a 4.1 centimeter mass in the parotid gland. This case is indeed from almost 13 years ago. And you see here at low power, we have some original, serous salivary gland tissue at the periphery. This is a classical pattern of most of parotid gland tumors. We have well circumscribed nodule, not really encapsulated, but not infiltrative looking. At the same time, contradictory, we see a lot of salivary tissue inside. So you see here a lot of bluish stained acini. We then have more cellular areas, some myxoid degeneration of the stroma, as well as more cellular areas. As we see here, we have some thick-walled gabbing vessels in the background, and then very peculiar hyalinized areas or nodule like this, well demarcated, but very huge in some areas, as you see here, either as a connective tissue or containing microcystic entrapped salivary ducts or some glands. And again here, we go to the outside area, we see exactly the same. So some lymphoid aggregates are seen in the surrounding around these sclerose areas. And this is one of the distinctive patterns that really we see in this entity in the head and neck specifically. It is not that very common, but also not that really rare for those seeing a lot of head and neck specimen. And then we have a problem. The problem starts with that we have the most frequent 80% of parotid gland nodules are pleomorphic adenomas, and we know that pleomorphic adenoma is an admixture of epithelial, ductal, and mesenchymal myoepithelial components. So I think anyone not experienced in soft tissue, we rush to call this some type of pleomorphic adenoma, maybe myoepithelial. Rich, however, if we look exactly to the cytology, and this is one of the very important issues that we have to address, the cytology, the architecture, the stromal background, characteristic, the vascular pattern. We see a lot of neoplastic cells that are relatively medium-sized, not really very differentiating to any type of certain cells. No plasmacytoid cells. We have a lot of small capillaries in the background. You see here just like small aggregates of pink-stained erythrocytes. And then the cells have a patternless pattern. We don't have a specific fascicular growth. And I think for many of us, the diagnosis out of this context is not very difficult. The tumor was positive for CD34 at that time because indeed the new marker was not available yet. It was stained later, and this is a case of solitary fibrous tumor. Very unusual. We see this mostly in the head and neck, not only in the parotid gland, but also in other areas. If you look at the literature, you will see a lot of case reports about SFT with entrapment of salivary or lacrimal glands and so on. And these tumors in the head and neck tend to have some unusual looking morphology. When I see something like this nowadays, really I go just for one marker. I don't stand for any of the old-fashioned markers. I will not check for S100 or keratin, but go immediately for STAT6. And the case indeed was a confirmed SFT with these very unusual salivary inclusions. We have to think of this always. Then I give you another case that came in 2 weeks ago from a 32-year-old female with an infraorbital mass. The first case indeed was an in-house case. This case is a consultation case from 2 weeks ago. Again, we see here well circumscribed nodule with some thin fibrous capsule. Again, a lot of inclusion of glands that are microcystic. Then we have very extensive myxoid, fibromyxoid, very much capillarized proliferation in between. Again, at the periphery, we see a somewhat comparable overall pattern as we just have seen. Again, here you see this periductal sclerosis, as we see sometimes in certain salivary gland pathologies as well. And here it looks really like very angiomyxoid, fibromyxoid. We have arborizing vascular channels in the background. We have microcystic stromal changes. And when you are aware or you become aware with this pattern, really you recognize it relatively quickly as being another example of head and neck, in this case intraorbital SFT as well. So everything looking, as I always say, SFT can do everything, even music, it remains an SFT. So really, we don't need to do a lot of immune stains. If you have molecular possibility and you like to see why it looks very strange, you can check for the fusion. But usually you get exactly the same STAT6 NAP2 fusion. So really there is nothing special. Maybe there might be different types of fusion breakpoints, but if you see here, really this is one of the challenging cases for those not seeing a lot of soft tissue or not a lot of head and neck. And when you see both, you recognize these cases without a huge problem. We know that myxoid SFT is uncommon. It is mostly abdominopelvic in location, and it seems to be more aggressive than the classical one. Also, at least many cases I have seen, they recur in the abdominal cavity or in the peritoneum. You can go for risking according to the available schemes, but at the end, I always look really just for two features, if it is de-differentiated or showing high-grade sarcomatous transformation. Otherwise, it is not really very informative to look for any specific features otherwise. This is the STAT6. You see here, it is a distinctly nuclear staining. And the stroma is clear. And we see this pattern, which is the distinctive pattern of the fusion. we later on will see another pattern which is related to amplification. This is a very important point, at least in my experience. I don't know what is the experience of others, but I can recognize that 6 fusion versus amplification just based on the immune stain pattern. So this is an example of classical fusion in myxoid SFT from the head and neck, and showing again extensive entrapment, in this case of lacrimal glands units. This is another example of a sinonasal tumor from a patient, 50-year-old male. Indeed, this is a case from Sudan, given to me by one friend. And it looks like, as you see here in sinonasal specimen, usually like those doing urinary bladder pathology, you see just a lot of fragments, polypoid tissue. You don't have oriented specimen. And most of these areas really looks very bizarre. But we have discrepancy between the pleomorphism of the nuclei, at the same time, the very low cellularity, as you see here. We have very hyperchromatic cells. Even sometimes we have multinucleated cell, as you see here, just like giant cells. Difficult to assess the vascularization, but it is relatively vascular in these areas. We have a lot of connective tissue, some erythrocyte extravasation, as you see, and most of the specimen really look like this. But we have another area, as you see here. And again, this is the name-giving, indeed, area, or the inspiring to recognize the entity. Again, very monomorphic spindle cell, mesenchymal neoplasm with some story forming, with some irregular fascicular pattern. We have a lot of gapping vessels, as you see here. And in the sinonasal tract, when I see something like this, I just think of 2 possibilities. Number 1, maybe to number 9 is SFT, and number 10 is P phenotypic sinonasal spindle cell sarcoma. And again, this is a molecularly or immune phenotypically confirmed case of sinonasal SFT, showing this combined morphology of classical, in addition to something like a giant cell or angio, maybe fibroma-like component, very sclerotic indeed, very paucicellular. I don't think this is prognostically relevant because these cells are almost not proliferating, so no mitotic activity, so this seems like some degenerative phenomenon or something like that. The next case I'm going to show you is a 66-year-old female with a recurrent 3.2 centimeter mass in the temporal fossa. I don't have access to the previous biopsy. This tumor was diffusely positive for S100, and then different terminological suggestions have been given to it with uncertainty, and then I got it for second opinion. You see here, we have skeletal muscle. We have, again, a well-delineated, very cellular neoplasm, moderately pale eosinophilic stain. It looks very monotonous. And then we go to the high power, and we start to see very extensive whorling, as we see here. Meningioma-like whorling seen almost in every area in this lesion. You see here as well. Any suggestion? Diffusely S100 positive, CD34 positive, PAX8 positive very strongly. Any suggestions? Again, SFT. Then a very interesting example case, originally from Russia. Then the patient came to Germany and resected. Then they sent me the specimen for second opinion. 37-year-old male. and the nodule was in the mouth floor. So again, it is head and neck, and extensively positive for CD34 and S100 as well. Unfortunately, I don't have the immuno to illustrate, and again, you see here in this nodule, very monotonous nesting in a very sparse stroma in the background, not too much vessels really, and when we go exactly closer to it, we see very extensive paraganglioma-like or meningioma-like whorling or nesting. The cells are more epithelioid looking. They have pale chromatin, not really prominent nucleoli. We have some eccentric eosinophilic cytoplasmas we see here. Indeed, this case came with a suggestion of myoepithelial carcinoma. And as the previous case, it was CD34 and S100 intensely positive. I stand, of course, for STAT6 as well, it is negative. Then this is one of the clear indication for molecular testing. You can't give any diagnosis. Of course, you can give any imaginary or descriptive diagnosis, a whorling tumor, you can't tell what it is. And indeed, very interestingly, it came back as having a red fusion, red NCOA4. So this is unclassified epithelioid and spindle cell, mesenchymal neoplasm with a red fusion. We can't tell more than this. So these few cases show how the morphology can be overlapping, and really some of the features, especially in SFT. SFT can do everything. Like we tell about melanoma in high-grade lesions, SFT really can do everything. We have to think about it. And even I tend sometimes to abuse the STAT6 immunohistochemistry when I don't know what it is. So I have 1-2 markers that I usually include, and they are very helpful in many cases. The next case is very interesting. 57-year-old female with a sinonasal mass. And the most interesting aspect here, this case is a recurrence. And the primary has been seen by a well-known soft tissue pathologist from a country I don't disclose any, and was called myofibroblastoma. And I assume this is not negative, what I am telling, but it shows the problem of phenotyping. And I'm sure the person who has seen the case looked for some immunomarkers that are very misleading, maybe has not included the most appropriate ones. And you see here, it is a very cellular invading into the bone with entrapment of bone trabeculae, and it looks relatively pink, very cellular, spindle cell, pleomorphic. And again now, when we see something like this in the sinonasal tract, really the best thing in Germany, usually we have problem when we speak about high suspicion index. They can't understand what we mean. And the high suspicion index, when I see something like this, I have 2 differentials, not more than that. One of them is sarcomatoid carcinoma, and the other one is a specific, not easy, but also easy diagnosis if you are aware of it. So it looks very pleomorphic, fascicular growth, hyperchromatic nuclei, sometimes bizarre looking, and the cytoplasm is moderately eosinophilic, but with indistinct cell borders. It very frequently, not always, look like this. So we have this condensation alternating with some hyalinization, but the cellularity is high and the pleomorphism is high, which is a very exceptional feature in this context, as you see here. Of course, here it looks very spindled, very fascicular. Some people will find maybe some myogenic markers. They will go for myogenic or smooth muscle neoplasm, but the cytology is really not that of smooth muscle neoplasm. So this is most likely, for the first suggestion, of course, sarcomatoid carcinoma. So we have to look for keratins. We know that sarcomatoid carcinoma frequently, especially in the head and neck, is keratin positive in contrast to some other sites. And if we look here exactly, you see there is too much keratin. So this is consistent with spindle cell pleomorphic sarcomatoid carcinoma. However, we know that we have a very important differential in this context of a high-grade pleomorphic spindle cell neoplasm, yes, with too much keratin. If you are unsure about something like this, always go for P53. It will be wild type. This means this is not a sarcomatoid malignancy driven by B53 mutation, which is a very helpful feature in many things. When I think about any underlying fusion, I'm not sure, I go for P53 immuno to see it is a wild type pattern, and indeed it is in this case. And you know that we have a second marker that is almost confirmatory for the diagnosis in this morphological context, in this location with this keratin. And this second marker is ALK. So cytokeratin, pankeratin, I use AE13, which is the best, in contrast to the earlier assumption in soft tissue was that you use MNF116. Why? Because it was considered more specific for epithelial. Now we need a more sensitive marker for certain entities. So I do not use MMN or MNF116, but AE13, which is the best marker for many entities in mesenchymal pathology. Even sometimes we use these keratins to tell this is not epithelial, this is a mesenchymal neoplasm. And we see here a lot of ALK positivity, of course. And the third marker, and I have to admit I do not rely on more than these three markers. The third one, of course, is desmin, which is almost equal to keratin expression against cytoplasmic. Then for me, and based on the current concept, it doesn't matter if I see MyoD1 or myogenin. And believe me, we create sometimes artifacts. Most of these tumors do not express myogenin or desmin or MyoD1, but we try always to find a focal weak staining. Some of them indeed do that, but not all of them. So this is a problem in nosology of this neoplasm. I think MyoD1 in this case had at least a more clear expression than myogenin was negative, but this is MyoD1, so it is weak, but it is clearly positive in many of these areas. As you see here, some of the nuclei are more stronger staining than most others, which are very weak or negative, but still it is not negative. So this is a case of rhabdomyosarcoma with TFCP2 EWSR1 fusion. So this is really very interesting issue, and I have to admit I missed definitely no less than 4 or 5 cases earlier based on the pleomorphic cytology, because we said if it is a very bizarre looking lesion, this is not fusion associated. But this is one of the very exception, which is a frequent event. We have more frequent bizarre looking pleomorphic cytology in this entity than in all other fusion associated neoplasm, for example, synovial sarcoma, etc. Anaplastic or pleomorphic morphology is very rare and very exceptional, but in this entity, this is a very normal finding. So any candidate for sarcomatoid carcinoma in the head and neck, especially in the craniofacial bone, soft tissue as well, of course, always think of keratin and ALK and desmin, and if the three are positive, I would go immediately for this diagnosis. I do not await the molecular testing, so you can call it like this, but in all ways, of course, in all cases, we look for the fusion testing. What is your diagnosis? This is a sinonasal mass. Any suggestion at low power? 26-year-old male, sinonasal mass. This case came from Pakistan. So we have a post-stromal neoplasm, very monotonous round cells, extensive hemangioperocytoma-like vascular pattern, really no connective tissue stroma, So it looks, of course, in the sinonasal tract, we have to think of olfactory neuroblastoma as one of the differential neuroendocrine carcinoma as well, because it has this very unusual nesting, and the cytology is not really fitting any specific entity. So this is one of the situation where you have to go for the very basic. You stand for an epithelial marker, an neuroendocrine marker, and an urogenic or melanocytic marker, and then you go on. When you verify this is epithelial or not, or neurogenic or not, melanocytic, and so on, because you don't have really very clear clue to diagnosis, but you have clue markers that you can use. You see here at high power, it looks really very anaplastic round cell morphology, epithelioid cell with moderate cytoplasm, very prominent nucleoli, and so on. And some people might think, those doing head and neck, this can be SNAC or sinonasal undifferentiated carcinoma. We don't see this pattern in the SNAC. Usually we have very extensive lobulation in a fibrous stromal background, but this look like just a piece of meat. There is no any stroma in the background. So it looks very large cell endocrine-like, but the cells do not show the odd cell morphology or the elongated ovoid nuclei. They are very monotonous round cell. And for this situation, we have very few markers that really might help. And I will show you one of the important markers in head and neck, especially in sinonasal tract, is P63. Some people use P40. P40 is more specific, but is less sensitive than P63, so it is completely negative. So this is not showing any squamous immunophenotype. Then we have pan-keratin, or it is not a pan-keratin, but a low molecular weight keratin, E13, and this shows a very variable expression. You see here, really, it looks like neuroendocrine with dot-like paranuclear or perinuclear staining pattern. Very few cells are even very weak, as you see here. So they have very few cytoskeleton or keratin component, as you see, just like artifacts looking. So at this level, you have two options. Either you have some surrogate molecular markers that you can use, or you go immediately for molecular testing. The problem is always when you go for molecular testing, you have to choose your most appropriate panel. If I am thinking of SNAC, I like to see IDH2 mutations. If I am thinking of neuroendocrine carcinoma, then might be HBV associated. You like to look for RB1B53. Both are not abnormal in this case. If you are thinking of something fusion associated, of course, you can go immediately for RNA sequencing. And indeed, I got this case by immunohistochemistry initially, because I have to use this marker at this location or at this anatomic location. And you see here, we have a marker that is very positive in almost every nucleus. And if you look exactly at the staining pattern, it is punctate. It is very granular, not diffuse nuclear, but very distinct granular. What is the diagnosis? Yeah. This is a nut carcinoma, keratin poor, P63 negative. So earlier we used to depend on P63 or P40. If it is negative, you exclude the nut carcinoma. It is not. We have at least a subset of cases that are keratin poor, are P63, P40 negative. So this case came as a possible round cell sarcoma for fusion testing, but you can get it with immunohistochemistry. And this case is very unusual in that it shows a very rare fusion partner, which is ZNF532. So this is a very rare category. We know that nut carcinoma has the BRD fusion. BRD4 is the most common. BRD3 is less common. Then we have NSD3 subset, and zinc finger protein subset is the least common, with maybe 15, 20 cases in the literature. I have in my file 4 cases of this type. So this is one of the not carcinomas that mimicked a mesenchymal undifferentiated neoplasm or around cell sarcoma. So really immunohistochemistry, context dependent, is very, very helpful. The next case is again very tricky case, 53-year-old male with a nodule on the epiglottic fold. And you see here, this is the mucosa with some keratinization indicating chronic irritation due to the lesion. We have some salivary lobules beneath that. And then we have this ulcerated neoplasm occupying the whole specimen with fibrinous exudation on top of it. And at low power, you go around, you see a lot of blood vessels, but really you don't see very distinctive patterns that can give you impression as to the differential diagnosis. You have to go to the high power to look at the cytology. So these are very large cells showing vesicular chromatin, variably recognizable nucleoli, cytoplasm is pale stained, sometimes more copious. We have a lot of mitosis, and we see the sprinkling of lymphocytes. So we have something that looks large cell, solid pattern, undifferentiated, with a lot of lymphocyte in between. The fairest, of course, suggestion or possibility in such a case, you have to think of aggressive B non-Hodgkin lymphomas, anaplastic lymphomas, follicular dendritic cell sarcomas because of this lymphocyte sprinkling, and then sometimes they can be large cell epithelioid looking, not always showing that classical pattern. And then you have initially to have some orienting immunohistochemistry, of course. This can be an HBV-associated lymphoepithelial-like carcinoma as well. So the morphology is really very misleading, is not fitting any specific entity. And this is one of the unusual pattern I have seen in this entity. Again, you can get the diagnosis just using immunohistochemistry. So I will show you. It is a head and neck lymphoepithelioma-like undifferentiated malignancy. This is B16. So it is block type or block-like expression. So if this were a keratin-positive neoplasm, it would be HBV-associated carcinoma with lymphoepithelial morphology, which we see occasionally in the head and neck, in non-oropharyngeal location as well, of course. In this case, it is laryngeal or supraglottic. And this is B53. It looks like mutated. At least most of the cells are diffusely positive, so very likely we have a P53 mutation. So we have to look for more. This is low molecular weight keratin, so it is negative. Of course, still it can be a keratin-poor carcinoma, but we know that sarcomatoid carcinoma, if looking lymphoepithelial or undifferentiated, if looking lymphoepithelial like this, they always retain all of their keratins. They lose keratin only if they are spindle cell or granulation tissue-like and so on. So this is unlikely to be epithelial in origin. I will show you first another marker, which is really very interesting to see. This is the pattern. Of course, we have to be familiar with the staining pattern of any antibody. Some are cytoplasmic, some are nuclear, some are nucleocytoplasmic, some are punctate nuclear, and so on. Some are membranous, and this is a very interesting staining. In my experience, this is STAT6. So it is not only nuclear, it is not only cytoplasmic. The background, the vessels, the stroma, everything is negative. So when I see this pattern, I know immediately the diagnosis. It depends, of course, on the morphology as well, but we have only one molecular possibility and two phenotypic consideration. This is a STAT6 amplified neoplasm, showing this nucleocytoplasmic pattern. I never have seen a clean nuclear pattern in amplified cases. I don't know if this is related to the antibody or to the extensive amplification or not, but as said, I can't distinguish between STAT6 fusion and amplification just based on the immuno pattern, and this is, of course, CDK4, diffusely positive. Again, you see that it has some cytoplasmic component because the high-level amplification will result in spilling of the antigen into the cytoplasm, and this is when we see this morphology, epithelioid, lymphoepithelial in this case, definitely not a liposarcoma. And with this amplification of at least 2 genes on 12q, this is a GLI1 amplified case confirmed by Cristina and included in the series, by the way. So this is one of the very difficult cases I have seen, but you see the immune is really very helpful. So when we think of GLI1 altered, I just add these 3 markers, MDM2, CDK4, STAT6. If 2 of them are positive or 1 clearly positive, this is indication of amplification. And if all are negative, I go for fusion. So this is one of the situations that you can indeed abuse to that. I think time is still. Okay. The next case is a 69 male nodule on the lower aspect of the tongue, so an oral cavity lesion. And again, we see skeletal muscle of the tongue, and we have this nodule that looks well circumscribed, but focally infiltrating and not encapsulated, moderately cellular, in some areas vaguely lobulated and fibromyxoid looking. I think there is some dust maybe on it. And then, usually the fairest point in our practice of soft tissue is you look at it and you immediately either know the diagnosis or a suspicion, or you see it does not fit anything. And in that situation, really, you don't need a lot of work to tell it is not fitting anything. This is usually the first impression when I see something like this. It really does not fit anything. It is not typical SFT. It is not typically smooth or myofibroblastic. It does not fit anything. These are monomorphic ovoid cells loosely arranged in a fibromyxoid or fibrous stroma. There are very few also lymphocytes in the background, but it does not show any classical pattern of anything. And indeed, we see here some fasciculation. The cells are very monotonous. They are elongated. They have some smooth muscle-like nuclei, but the cytoplasm is not fitting smooth muscle, and came with a lot of immunostains done CD34 focally positive, but very patchy. So here there is really no big chance to do a lot of work to tell what it is. You have to limit yourself to very few stains. I think low molecular weight keratin, difficult to find, was very positive in very few scattered cells. Most what you see here, yes, are artifact. So it is not really keratin positive. And again, there is a key marker that was stained during the initial evaluation. And at the beginning, I was not really able to believe it because the morphology does not fit. The immunostaining is positive, but it is not very strong. But any degree of staining with this antibody, you have to take it serious. You see here the nuclei are positive with very heterogeneous degree of expression or staining intensity. Any suggestion? You see? So this is staining I have seen twice, and I comment always in the report, there is some degree of staining that is not the very impressive one that we look at for this genetic defect, but it is also not to be ignored, and I send it for fusion testing. This is again the not immunohistochemistry. And this came back as a not M1 fusion with a very peculiar fusion partner, GLI1. Yeah. Of course, such cases, don't think that you are going to solve them by molecular. You are not going to solve them. You are going just to give a commentary on the molecular background of the lesion. But you can't tell what it is. This is a fibromyxoid unclassified mesenchymal neoplasm, not GLI1 rearranged. What does that mean? I don't know. So this is, you haven't seen this fusion partner before. This is the only case. Negative, negative. They don't have any amplification features. And of course, I might have not believed in this fusion, but the immune was positive, and indeed it was the triggering to expect a not alteration. So this is one of these cases really that we don't know how to explain them. Then I like to shift to a completely different category. This is a young male, 31-year-old, in the year 2014, diagnosed with a huge gluteal mass in the soft tissue. And of course, you can imagine after I tell you the story why it was called like this. So this is a large, monotonous lesion showing very distinctive vague lobulation, but also nesting, so hierarchical nesting. So the lobules are again composed of smaller aggregates, sometimes very organoid, as you see here. They have very prominent stromal dysplasia. Round cells that look like sometimes a little bit plasmacytoid or myoepithelial maybe like, but not really fitting anything. Very monotonous cytology. And we have these aggregates that are sometimes cell balance-like. You see here eccentric small nuclei with dense chromatin, no nucleoli. The cytoplasm is moderately eosinophilic and eccentric in location. So really it does not fit any specific entity that we know. It can be something of myoepithelial origin, but this could not be confirmed by any immunostains. And this lesion resulted in death of the patient after 4.5 years, extensive metastases in the lung and in multiple other sites. And the original diagnosis was paraganglioma because it was very positive for synaptophysin and some other markers. I noted some indeed was positive for synaptophysin and PAX8. So it may be the nephrogenic type of paraganglioma. So this is really one of the illustrations how the phenotypes can be misleading. And we send it initially, or we revise it for our oncologists. This is a small round cell epithelioid mesenchymal neoplasm. Are no paragangliomas in the soft tissue, or especially not in the gluteal area. It looks really in some other, this is another block from the same resection specimen. It looks really like a well-differentiated neuroendocrine neoplasm, or maybe like GLI1 altered or pseudoendocrine, etc. As you see here, very monotonous cells, very sparse stroma, very vascularized in the background. And we said this is unclassified, and this case has an EWS-R1 creme fusion. So this is unclassified sarcoma with neuroendocrine-like morphology and even immunophenotype. keratin negative in this case, but ALK positive as well, and not fitting any. And we see sometimes some aneurysmal-like changes or angiomatoid. This is one of the problems that people over-depending on genotyping, they may think to call this angiomatoid fibrous histiocytoma just because of the fusion, but angiomatoid fibrous histiocytoma indeed until now has killed one single possible patient. If you go to the literature, there is a one probable case of death without verified histology of the metastases. So this is really something completely different, and I'm going to speak about this in my talk. This is one case, then I will show you another case from the head and neck or the orbiter of a 29-year-old female. Again, this case came from another center in Germany. They did everything, even fusion testing, but they don't know how to call it, and that was right, because even me, I don't know how to call it. I will give a descriptive name, and you see here, monotonous clear cells with pale stain cytoplasm, very rounded isomorphic nuclei. We have this fine reticular hyalinization in the background. Even in some areas, it looks like pseudoalveolar, as we see here. And sometimes you have to keep with very difficult dogmas and misconceptions. We published recently these cases in a series, and when reviewer asked it, how can you reliably distinguish this from hyalinizing clear cell carcinoma of the head and neck? And I always comment this is either a head and neck pathologist who has no idea about soft tissue, or a soft tissue pathologist who has no idea about both. Yeah. And you see here, this is not an epithelial. Cytology, growth pattern, this is never epithelial. We have to distinguish. We don't look just, we see nesting, we see hyalinization, and a pale cytoplasm. This does not mean this is a hyalinizing clear cell carcinoma. That is an epithelial neoplasm with desmosomes, with cell cohesion, with very specific features and squamous immunophenotype. So when we see something like this, of course you may think this might be an odd variant of sclerosing epithelioid fibrosarcoma. Sometimes you see areas like this in them, but really this is not classified, and this case again has an EWSR1 CREM fusion, and the immune was ALK positive, other markers were negative, CD99 variably positive, but usually I don't stain it in most of them, and just I show you here the ALK immunohistochemistry to see how non-specific ALK is becoming now. You see here, all cells are really very strongly positive. If you see here again. So this is one of unclassified epithelioid around cell neoplasm with clear cell morphology and some similarity to sclerosing epithelioid fibrosarcoma may be good. The next case was a routine case. We got a needle biopsy and then resection, 23-year-old female with constitutional symptoms. And we became aware of that clinical presentation in retrospect. And even I put the hypothetical diagnosis based on that and the morphology, because the biopsy was not very conclusive except for the odd immunophenotype. And then I commented if there is any CRP elevation. They said, yes, it is increasing every 2 weeks to double the original level. I said, okay, this is a specific sarcoma with a specific fusion. And then they resected, and you see the patient is very young, 23-year-old. And indeed, she came into the clinic just because of these constitutional symptoms. And you see here, it is the colonic mesentery. You see here the colon wall is okay. Then we have very extensive inflammation in the muscularis propria, in the submucosa, sometimes with Crohn-like quality. And then we have the nodule here outside, and if you go inside, we see a lot of morphologies. And this is very important because I will show you later on some comment on this in my talk. This is something that the GYN people are going to very quickly call it nested and inflammatory sex cord tumor, because they are GU people, not because it is that entity indeed. A lot of inflammation inside the lesion, some nesting, very irregular nesting as you see here. And then if you go around, I brought only one of the slides. You see here, for example, a more epithelioid, a round cell pattern, really nondescript. It does not really fit anything specific. Then we have some areas like here. Again, it starts to show this clefting of the aggregates or pseudo-alveolar, very subtle areas as we have seen in the orbital one just before. And if you go around, you see a lot of necrosis, of course, as well. And all these features are, which we have seen in the prior two cases can be at least focally seen here. You see, again, this very prominent inflammation. And the patient also has some paraneoplastic encephalitis-like symptoms. After resection, everything went back. You see here again, this pseudo-alveolar-like clefting. The slide, unfortunately, is a little bit thick or not the best quality. You see here again as well. And this tumor has a lot of immunomarker expression, ALK positive, keratin positive, MAC4 positive, CD30 positive. Of course, we stand this to tell it is not lymphoma, it is not mesothelioma, it is not carcinoma, it is not ALK fusion associated, but it is a FUS-CREM fusion sarcoma. So this is one of the cases. In this case, we have FUS as a fusion partner and has multiple lymph node metastases as well. So really, it shows all of the features that we see in this group of neoplasms that we don't have really a name for them. I just show you the immunohistochemistry for pankeratin to see how strong these tumors are, sometimes keratin positive. You see here, all of them are staining, highlighting the nesting and the inflammation in between. And this is one of tumors that have been initially described by Cristina Antonescu and Pete Argani, then by the Japanese group. Then we showed also some series on extra-abdominal and also intra-abdominal cases I will show you later. This is the last case in this category given to me recently by a colleague from the Turkey. And you see this is a testicular mass, 57-year-old male. You see exactly the inflammation and the epithelioid cells or round cells, very heterogeneous. Here they are more pale stained. Then you go inside, you see again this clefting and this pseudo-alveolar arrangement. All these patterns really, when you have a resection, you see almost all these patterns in the same case. And very unfortunately, these tumors in the testes are very aggressive, and they have been called sex-core tumors because they do express some transcriptional factors, but they can do that even if they are mediastinal. So this is really just the cultural influence of the subspecialty. So if you are a Jew, you will look for inhibin, calretinin, you tell this is a sex-core tumor, but it is not. All these tumors also frequently are keratin positive, EMA positive, ALK positive, MAC4 positive. So this is just an odd phenotype that is triggered by many of these tumors. And I think also the influence of the subspecialty was very clear in these cases because most of them were historically in the files called seminoma or unusual seminoma. You have round cells, you have extensive nesting with a lot of mononuclear inflammation. This is, of course, one of the features seen in seminomas. If you look at the cytology, it is not a seminoma cytology, but it's still, they called it sex-core tumor, and they are very, very aggressive. This tumor was negative for inhibin and calretinin. Indeed, sorry, this is calretinin is negative, and I show you just an inhibin as well. You can see here at the periphery, the Sertoli cells in the tubules are very positive. The tumor is completely negative. So really, they don't show a complete immunophenotype of sex-core tumors, and this is EMA. So showing the nesting and sparing the inflammation in between. And this case has EWS-R1 ATF1 fusion. So most of the testicular cases, surprisingly, they don't have other CREP component but ATF1. So it's very interesting to see, and they are very, very aggressive. How much time still I have? 2 minutes. Okay, so just to close up with the final, again, going up, sinonasal. This is a patient, 53-year-old female with a sinonasal mass. And this also highlights that in the prototypical case, really you can recognize some difficult diagnoses based on morphology alone. And when you have something with a polyphenotypic immune profile, either use it to abuse it or do not use it. Yeah, but don't use single markers to tell this is rhabdo, this is neurogenic, this is epithelial. And this tumor has a very primitive looking, in some ways suggestive or reminiscent of some BCOR sarcomas, so primitive looking cells, myxoid, angiomyxoid background, very significant mitotic activity you see here, but the hallmark are these very blue stained nest of pseudo-cohesive cells in the background. Sometimes, of course, you see something like this in the GYN, in carcinosarcomas, etc., something that is undifferentiated. But in the sinonasal tract, you see this histology. It is very suggestive of a recently described sarcoma subtype you see here as well. And in this case, this is the only case I just have suggested from morphology and was confirmed then by immuno. Sometimes you are surprised just by the molecular results, and this is a case with first PAU3 or COLCA2. I like the easier name, fusion sarcoma of the sinonasal tract, which is a very recently described aggressive entity. Really, it looks very polyphenotypic. If sometimes I have seen few cases, I talked to Michael yesterday, where these epithelioid areas were very extensive. So it seems that they may be like synovial sarcoma. They can be very dramatically epithelial differentiated. I have seen 2 cases that were really initially called carcinomas, adenocarcinoma or adenoid cystic carcinoma-like, but again, they have exactly the same fusion. So thank you very much. If there are any questions.
So thank you very much, Abbas, for these scary cases. And we have time for maybe 1 or 2 questions, but please wait for the microphone. Anybody wants to ask a question?
Abbas, thank you for the... Can you hear me? Is it working?
I think it is not.
Abbas, thank you very much for the wonderful journey here. Do you have any advice on a better term for the EWS CREB, the malignant epithelioid neoplasm with EWS CREB type fusions? Since you showed cases that are outside the peritoneal or mesothelial cavity that are keratin negative, than the original series we put together. So do you have any thoughts on how to put this together as a bigger entity?
I think the best thing, this is one of the categories that we have to terminologically define by molecular, because if you remove the molecular, so FET, CREB, fusion, sarcomas unclassified or something like that, or others, then you don't have a terminology at all. And I know that Peter Gania and you mentioned mesenchymal line cavities because this was the first description and they are keratin positive. So to avoid any confusion with mesotheliomas, that may have also rarely these fusions. But now we know that they occur predominantly in the abdominal cavity and the pelvis, but they can occur in any soft tissue and head and neck sites. So I think we need now a descriptive terminology to avoid any histogenetic commitment because they will not show any cell type. And really we struggled, Dr. Eki and me, to the recently published series with reviewers because one of them said these are brachyangiomatoid fibrous histiocytomas. Okay, maybe as a not soft tissue pathologist. The other point, a discussion about round cell versus epithelioid. You can't call them round cell, but you can't call them only epithelioid. They have all these spectrums. And the problem is that I have seen really many cases where I see all these patterns in the same. So they are epithelioid, sometimes SEF-like, sometimes they are round cell, really very round cell. and sometimes they are clear cell-looking, paraganglioma-like. I don't think we can have a more beautiful name than a descriptive terminology. We have to use the adoption of, now you have the EWSR Ewing category, the none, and then others. We have to put them as others, unclassified. But really what I very much advocate, we have to use the term sarcoma. They are more aggressive than any other sarcoma type. The mortality and morbidity rate, I looked exactly at all published cases, almost now 80 or 90 cases, is more than 50%. So this is a horrible disease, and they metastasize, they do not respond to any treatment, so we have to recognize them. I very much hope that the WHO will understand this, because otherwise we have to wait another 8 or 10 years to tell people, this is fine. But I would use a terminology that is really descriptive. Yeah.
Thank you very much. Maybe time for one short question? Nobody? So thank you, Abbas.
Thank you.
I'm very happy to invite here Dr. Cristina Antonescu, who is the chief of the Bone and Soft Tissue Department at Memorial Sloan Kettering Cancer Center. Thanks to her achievements, we know much more about bone and especially soft tissue tumors. Sometimes she goes under the nickname Fusion Lady, which is definitely deserved and fitting. So please, Dr. Antonescu.
So good morning, everyone, and thank you, Michael and Michal and everyone here for organizing this outstanding meeting and meeting new friends and seeing the new generation of academic sarcoma pathologists is really inspiring for me to be here and maybe raise the enthusiasm level a notch. So for today's slide seminar, I thought I'm going to show you mostly round cell, small blue round cell tumors. And the goal of this hour is mainly to discuss the value of morphology in this setting, in this very, very challenging area of pathology, to discuss limitations, and of course, like Abbas, when we really need to go to molecular. So my talk will be a little bit more structured and basic. So the first part I will show cases covering the small blue round cell tumors, including in WHO, as you may know, Ewing sarcoma, the round cell sarcoma with EWS non-EDS fusion, Czech sarcomas, B-core sarcomas, and then as much as I can at the end to show you other round cell tumors that you have to include in the differential diagnosis. And of course, in most of these cases, the molecular will play a role, but I also want to emphasize that we can still do quite a bit with morphology. And I think we can, in fact, do more now with morphology than before, since we learned so much about the molecular subsets and then go back to morphology and learn more about the microscopic features in the context of molecular confirmation. So I'm going to start with very basics. As I said, we cannot talk about round cell sarcomas if we don't know the features of Ewing's, right? So we'll start easy, and then hopefully we'll go fast and a little bit more challenging. Okay. I don't see anything. Oh, sorry. Something happened. Okay. Okay, so this is the first case. Let me go medium power, medium high, anywhere. Yeah, for Ewing sarcoma, everywhere I go is the same, so that's very important. There is this perfect monotonous cytomorphology. Every single cell looks exactly the same like its neighbor. Round cells with ill-defined cell border, as you can see here. We can't really appreciate in this case much of the quality of the cytoplasm. The nuclei are uniform with this smooth nuclear contour. We will see in other round cell sarcomas that the nuclear contour is more irregular. The chromatin also is very typical, this vesicular pattern. You know, most other sarcomas will have more hyperchromatic or heterogeneous chromatin, tiny or inconspicuous nucleoli, right? So very monomorphic, very monotonous, not much stromal pattern. You can see maybe necrosis. I don't see much here. Of course, mitotic figures, right? So this is classic for Ewing sarcoma. Let me show you another case just to get the feel for this. This Ewing is a little bit more different, because has a touch more cytoplasm. As you can see here, the cytoplasm appears clear or light eosinophilic. Still ill-defined cell borders. The nuclei have this smooth nuclear contour, open or fine chromatin, and small nucleoli. Yeah, so everything here looks the same wherever we go, usually solid, diffuse sheets, hemorrhagic or necrotic stroma. So once you start seeing larger cells, pleomorphism, spindling, you are not dealing with Ewing sarcoma, right? So you have to have in your mind a reference of this perfect monotonous appearance that is typical for Ewing sarcoma. Okay, just 1 minute just to bring up the entity of PNET, right? The old term, peripheral neuroectodermal tumor. This was thought before the molecular era to represent a different subtype and occurring in more older people, in adults, and in the chest wall. I can't find the area right now, sorry, I apologize. Yeah, so something like this. We have a little bit more stroma, we have rosetting. So this is, and the lesional cells are truly the same as Ewing sarcoma, right? If you ignore all the fibrillary or the stromal component, the tumor cells are identical with Ewing sarcoma, right? Have this perfectly uniform nuclei. Okay, so PNET now, it's considered just a funny looking Ewing sarcoma. So you should, if you have a tumor like this, you should maybe use Ewing sarcoma / PNET, or just drop the PNET altogether so you don't confuse your clinicians. These peripheral neuroectodermal tumors stain with CD99 the same way as the classic Ewing sarcoma, and I brought this slide just to emphasize how CD99 should be positive in a Ewing sarcoma, diffuse every single cell, positive, membranous, strong. We think of CD99 not being a specific marker, which is very true. However, the pattern can help us a lot, right? So with this pattern, we have to be very suspicious that this may represent a Ewing sarcoma. Okay, I'm showing you briefly this next case. This case is a 70-year-old female with an abdominal wall mass, came to our institution with an outside diagnosis of Merkel cell carcinoma, which is not unreasonable for this age presentation. People that are familiar with Merkel cell carcinoma will tell you that the nuclear features are very similar with Ewing sarcoma, very open chromatin and perfectly smooth nuclear contours. So this case was keratin positive, was not a CK20 positive, but was keratin positive, and I think for the outside pathologist that was enough
for them to call it carcinoma in this age group, yeah? However, in our place, whenever we get a round cell tumor, we don't look at the age. We just run the entire immunopanel for round cell tumors, which of course includes a CD99. This is an older case, so we didn't have the NKX 2.2 marker, which is so much better and so much specific. But this is the CD99 on that case, and you can appreciate again the very strong diffuse pattern. You see the endothelial cells are not staining, so it's not non-specific. So this case was an Ewing sarcoma in an older patient, so unusual clinical presentation, unusual immunoprofile. About 10 to 20% of Ewing sarcoma will express quite a bit of cytokeratin, so you should be aware of, and of course may express other markers, aberrant expression, even S100 we can see quite diffusely in some cases. So if you have the right morphology, if you have that strong CD99 positivity, you have to have a high suspicion of Ewing sarcoma, and of course you can confirm by molecular. You may ask, well, what should we do? Should we do FISH or should we do Archer? If everything fits and you just want a confirmation, a FISH EWS will be enough. If something doesn't fit, you know already how many sarcomas with EWS fusions exist. So I would not go to FISH. I would go straight to RNA-seq, Archer, and confirm the partner as well. Yeah. So at least that's how I approach. If it fits with Ewing sarcoma and I just want a confirmation, I will do FISH. Otherwise, I go to Archer. Okay, next case, just to bring up, and again, each institution may do this differently, but once we make a diagnosis of Ewing sarcoma, patient gets treated and comes back for definitive resection. A lot of them are in the bone. This is a hemipelvectomy, and at least in our institution, we use the 4-tier grading system for chemotherapy response. Right, grade 1 and 2 are poor responders, and 3, 4 are good responders. So 4 is 100%, and 3 is more than 90%. So we, of course, we map this very well, and we look at every slide to identify the possible residual viable Ewing sarcoma, as you can see here. It may show a little bit of artifact. You can see some retraction artifacts, some rosetting. So if you are uncertain that's residual viable, again, do a CD99 and you can confirm for sure residual viable disease and be more accurate in giving a chemotherapy grade that correlates with survival. Okay, next case, I brought it up just to start the discussion with a member of the Ewing sarcoma family that has a different partner. So not FLY1, but has ERG. So this is an EWS ERG fusion positive Ewing's, right? And why am I showing this to you? Well, because sometimes the EWS ERG fusion positive tumors look more funny, right? So cytologically, you know, they may look the same, but from an architectural point of view, they may look more cohesive, more nested, even some ovoid to spindling, right? So I find that in a subset of these EWS ERG, you know, the diagnosis on H&E is not so straight for, oh yeah, this is most likely an Ewing sarcoma. Right, so it's a little bit more funny looking. You can see here, maybe it's trying a little bit of whirling or storiform. Cells are more ovoid. Of course, they're entirely back-to-back monomorphic, right? We will not accept any pleomorphism for a member of the Ewing sarcoma family. So what else should we mention here? Well, I can show you an ERG. Although this is also not very specific, we can see other tumors, round cell tumors that may show ERG, including cheek ducts. But this is, you know, diffuse nuclear pattern for ERG. So how else we could, or what are the other pitfalls? So I showed you some atypical morphology, but also you can say, okay, let's do fish for this one. We send for fish, and EWS comes back negative. So in about, I would say, a quarter, 20 to 25% of these cases, bona fide EWS-ERG fusion, the fish comes back negative, so false negative. Why? Because the EWS and ERG genes are in the different direction of transcription, so in order to get a fusion transcript, they have to break and invert, so it's a more unbalanced type fusion and with a cryptic rearrangement that can be missed by fish that has low resolution, right? So again, be careful with fish. If fish is negative, you can do FUS is negative, and then you still think, this has to be, then send to Archer. Or you can send, to molecular, to Archer right away. But I just wanted to raise this point for EWS-ERG because initially we didn't know about this pitfall, so we had a number of cases that we really didn't know what it were. And of course, has significant clinical implication. The clinicians want to know, is this an Ewing's or not? Okay, moving on to a controversial sub-entity. If I can find the area. Anybody knows what this is? Or maybe what it looks like? Very good. Okay, but we are not in the tibia. Yeah, and this one has an EWS Fly1 fusion, right? So everybody knows the controversy. This is an adamantinoma like Ewing sarcoma. I don't want to say that the epithelial pathologists or the head and neck pathologists think it's carcinoma and the sarcoma pathologists think it's because it's not so simple, right? I know a number of sarcoma pathologists that still think this is epithelial and it should be treated and considered as a carcinoma. So this is how it looks, right? It's a small blue round cell tumor, but it's organized in these cohesive nests and trabeculae with almost basaloid growth at the periphery. And then in the center, you may see squamous or epithelial differentiation. Here you see squamous pearls. So these tumors stained with keratins, stained with P16. So clearly has the immunophenotype of a carcinoma as the molecular alteration of Ewing sarcoma. So which one is it? Our experience that most of these cases were misdiagnosed in the past as carcinoma. Well, were diagnosed as carcinomas, were treated as carcinomas with no response. Most of these cases occur in young patients, non-smoker, no other risk. So I don't see why this cannot be a sarcoma. So I wanted to show you, a very good classic case of an adamantinoma like Ewing sarcoma. Okay, so that's all I had for the Ewing sarcoma family. I only brought you one slide for the next category, for the EWS non-ETS fusion cases. And this particular case, looks a bit funny. Yeah, again, very monotonous, but right away you can see the difference from Ewing sarcoma. More abundant, clear, bubbly cytoplasm, a little bit more nesting. The stroma is more loose, maybe myxoid. Yeah, so again, if you can send it for fish alone, but that may not help. However, this is the only round cell tumor or any other sarcoma that has an EWS rearrangement that also shows an EWS amplification, right? So if you get your cytogenetic report back and says that this has an EWS amplification, that's a red flag for you to think of this entity, EWS and FATC2 fusion positive tumor. right? And what else? What else should I say about this? Well, that it may not look like a round cell tumor. It may look a little bit of, epithelioid. And again, what Abbas was saying, in this category that I'm presenting today, there is this spectrum, round to epithelioid, right? We go kind of back and forth, back and forth. It's not purely round like Ewing sarcoma, has a little bit more cytoplasm. So is this truly an epithelioid tumor? Probably not, but there is a spectrum here. Yeah, some lesions have more cytoplasm than others. So also because of the immunophenotype of EWS and FATC2 that may show epithelial markers, this tumor may be confused with the soft tissue myoepithelial tumor. Yeah, so whenever you see something like this and you think this may be myoepithelial, keratin positive, you have to also think of FATC2 in the differential, and of course the Archer or RNA-seq will help you to confirm this diagnosis. Okay, moving to the third category, the cheek ducts or CIC ducts, depending which country are you coming from. Okay, so yeah, this tumor, I would say, mostly looks like a round cell sarcoma, okay? And you can see here, relatively monomorphic. If you don't have a lot of material, if you have a biopsy, you have only this area, this can be Ewing sarcoma, right? I think that it looks pretty good, but there are so many other different areas in here which are incompatible with classic Ewing sarcoma, right? So you have here areas that have more abundant clear cytoplasm, and then we start seeing areas that have pleomorphism, that have nuclei that are larger, so variation in size and shape of the nuclei, again, not a feature of Ewing sarcoma. Here in this area, the tumor cells look clearly more epithelioid. Yeah, so, and here you can see even rhabdoid. So this is one of the classic appearances of cheek ducts for sarcomas that has areas of primitive round cell sarcoma appearance, and then you go through areas that are more epithelioid, more pleomorphic, even more rhabdoid. Necrosis is always present and it's abundant. So very high grade looking sarcoma. It looks much more high grade and anaplastic than the classic Ewing sarcoma. Yeah, so when you see something like this, so Ewing is out. Let me show you another case and then we'll talk about the immunoprofile. Okay, in this case you can see at low power has a nodular architecture, right? And then in some areas you have a little bit more myxoid or loose stroma, like here, which is another feature of cheek ducts. Okay, so how can we distinguish by immuno from Ewing sarcoma? Well, let's see if this is the CD99. Yeah, this is CD99. I wanted to show it to you, right? There are some cells that are positive, strong, membranous, but that's not the pattern of Ewing's, right? That I showed you has to be in every single cell. And then another stain I wanted to show you is the ETV4. Yeah, nuclear expression. ETV4 is a downstream target of cheek, so it's always upregulated due to the fusion, and of course WT1. Yeah, WT1 is also a downstream target of cheek, so it's typically upregulated. Okay, so I think it's what we learned from molecular and immunoprofile. In a number of cases we can suspect this diagnosis on morphology and be relatively certain based on immuno. Am I ever going to say that's enough? No. I would always confirm the cheek ducts fusion, either by FISH for cheek rearrangement or by Archer. We have published in the past the pitfalls. You can have actually a small subset of cases that FISH is again falsely negative. We have published cases that by RNA-seq were falsely negative. So sometimes for these tumors you have to do more than one molecular assay. Why is it important to confirm? Well, first of all, these tumors have a very unfavorable outcome. It's already known now that the Ewing sarcoma protocols don't really work. So some oncologists, sarcoma oncologists now even skip the Ewing sarcoma protocols and go straight to the adult sarcoma protocols for these tumors. So I think they would like to know upfront the correct diagnosis and not just some vague undifferentiated sarcoma. Okay, moving on to B-core alteration sarcoma, and this is the most common member. The B-core CCNB3 occurs a little bit more common in the bone, but also in the soft tissue. And how would I describe it? Well, you have here the prototypical appearance. It's more spindly than round, but a lot of tumors have both round and spindly. So I sometimes teach my fellows that this tumor has a hybrid Ewing sarcoma / synovial sarcoma morphology. The presence of myxoid stroma is quite common, as you can see here. These short fascicles, again, very monomorphic. Yeah, very monomorphic, ovoid nuclei, fine chromatin. Yeah, so it's just that it's more spindle, more ovoid. Yeah, nodular growth pattern, and I think I have another example here to make the point that in some cases there is so much myxoid background that these tumors may be confused or misinterpreted as a low-grade sarcoma. We had cases like this. We had a biopsy and it looked low cellularity, monomorphic like this, with these quite characteristic fibrovascular septae. So we may think this is a low-grade sarcoma. However, you know, if you have the entire specimen, you will see areas that are unequivocally high grade and undifferentiated and solid, like here. So again, these fibrovascular septae dividing the tumor in compartments is quite characteristic, not just for B-core CCNB3, but for B-core altered sarcomas in general. So if you see that, you have to kind of think of this sarcoma again. This is like pseudo clustering because of the myxoid stroma here, even trying to form some rhabdoid histology. So this is the second case I wanted to show you. And then, of course, B-core. B-core should be strong and diffuse in every single cell. Yeah, nuclear, it's a good marker, clean, there's no much background. However, it's not fully specific, right? We have seen other spindle cell sarcomas that may stain with B-core, synovial, and others. But again, it's all in the right context, right? In the right context, all these immunos may mean or may not mean the same thing. But with this morphology, this B-core immunoreactivity, I would suggest to confirm as well by molecular, to confirm the B-core CCNB3 fusion. Okay, let me see what I have here. Yeah, so we are moving now. So I covered the B-core CCNB3. So now I want to show you another tumor with B-core alterations, but not fusions, right? There's another alterations that occur mostly in infants. So very, very young kids and mostly in the abdomen and trunk, not so common in the extremities. So this is an example of a undifferentiated sarcoma with B-core internal tandem duplication, or ITD. Occurs, as I said, more than 90% either at birth or within first year of life. Very monomorphic. You can see tumor is separated by this fibrovascular septae. It's quite vascular here. The tumor is not myxoid, it's quite solid. So these tumors are highly aggressive. They do not respond with pretty much anything, and they are truly very lethal. This is another example of a B-core ITD, round cell sarcoma in an infant. Yeah, at low power you can see these stretched blood vessels, and then the tumor cells, again, very monomorphic. This tumor has a bit more cytoplasm, so again, there is always this spectrum. Almost in every round cell sarcoma that looks more round or looks a little bit more epithelioid. Yeah, but the fibrovascular septae are, you know, a good red flag that you're maybe dealing with this tumor. Okay, B-core, let's see if B-core is positive in B-core ITD. Yes, and it is. Again, strong diffuse. So no difference from the B-core fusions. I brought you here a case of the clear cell sarcoma of the kidney, and you may wonder why. Because clear sarcoma of kidney has a B-core ITD fusion, right? And working so closely with Pete Argani, you know, I wanted to review more of these cases to appreciate, right, the morphologic spectrum between, you know, in general, B-core altered sarcoma, but in particular, B-core ITD, so the exact genetic alteration. And indeed, yeah, I hope I can convince you that we see significant similarity, not just with B-core ITD sarcoma, but with B-core fusion sarcomas as well. Yeah, so this is a tumor that obviously occurs in the kidney. Okay, the next case is related to the B-core altered, but has a different morphology. Don't know if anybody is familiar with this entity. Still occurs in the same age group, infants. This tumor was initially described by Rita Alagio's group as likely related to infantile fibrosarcoma, but being very myxoid. We were lucky when we cloned the B-core ITD in sarcomas to get some of her cases, because was very weird, right? That was so much overlap in the clinical presentation between the B-core ITD round cell and this one. Again, this one looks more low grade, so you may think this is a low grade lesion or maybe even benign lesion. And this tumor, primitive myxoid mesenchymal tumor of infancy, has the same genetic alteration, the B-core ITD. We think it's on the same spectrum. It just has more myxoid stroma, so it's less, it's more hypocellular. And we have published a few years back a large study trying to compare clinically these primitive myxoid mesenchymal tumor with the other B-core ITD round cell sarcoma to see if there is any difference. And it wasn't a statistical significant difference, but these that are more myxoid behave a little bit better than, you know, the back-to-back round cell looking B-core ITD. Yeah, so keep in mind, if you're dealing with pediatric tumors, infants, if you see something myxoid like that, again, mostly in the abdomen, just to think of the B-core ITD family of tumors. Okay, so that's all I had from the round cell sarcoma group included in the WHO. So now I want to show you a number of other entities that are not grouped in that category, but obviously can come up in the differential diagnosis. Okay, so this case, nobody has issues with, right? Although, you know, it doesn't look that different from the adamantinoma, but this is a desmoplastic round cell tumor. And why am I showing you this? Because this occurred in the hand, in the one of the phalanxes of the hand, so a bone lesion, right? So who would think a desmoplastic round cell tumor may occur there, but without any primary anywhere else? But that's what it is. Of course, we confirmed it. Has these trabeculae with central necrosis, desmoplastic stroma, and of course all the polyphenotypic markers that we are very familiar with, keratin, desmin, right? So are all the desmoplastic round cell tumor positive like this? Probably not. Some are more focal, but no, I think the overwhelming majority, they will show some degree of staining. Since we are talking about desmoplastic round cell tumors, I want to kind of show you a bit of the spectrum and more challenging cases. So in some cases, the desmoplasia may be more limited, so you can see more confluence of these trabeculae, right? So again, relatively monomorphic, maybe not as uniform as Ewing. The cells tend to be round to ovoid, often with the central necrosis, and more of a nested trabecular growth than Ewing sarcoma. Okay, and the last unusual feature for this entity are these tubular structures or rosetting. So whenever you see this, you have to think of a desmoplastic round cell tumor. And sometimes these tumors are not, these areas are not associated with any desmoplasia, so it can be quite tricky. And then this extraordinary case that we had that was pretty much entirely comprised by rosetting. Yeah, so this is better than my peanut case. But this had an EWS WT1 fusion. Okay, moving on to a different round cell sarcoma, different tumor that has a round cell component. I want to go here first because this tumor typically shows this HPC branching vascular pattern, and I have not mentioned that in any other prior round cell sarcoma tumor we've seen so far. So again, very primitive round to maybe ovoid with this distinctive vascular pattern. No, I thought somebody said the diagnosis. Very good. Okay, so do we need cartilage or not? We don't need cartilage, but again, we want to see cartilage, right? And we, as Fernanda say, we may have cases, and we've seen cases, especially in the head and neck, with no cartilage, right? So in those cases, I would highly suggest you do molecular, okay? But in other cases, you show this kind of early, ill-defined, maybe not cartilage, as you can see here, more myxoid, more loose. So this is one type of cartilage matrix that you may see in mesenchymal chondrosarcoma, and of course, if you see something like this, right, it's very obvious. Right? And in this case, in fact, if you see this kind of biphasic appearance, you may want to distinguish from a dedifferentiated chondrosarcoma, right? So these tumors, especially the ones that don't have cartilage or the cartilage is ill-formed, you could do a FISH for NCOA2, or you can do the Archer, right? Okay, a few cases left. I think I'm going to beat the clock. Okay, this one, I find this tumor difficult. Yeah, small blue round cell, a bit more angry looking, more proeminent nucleoli. So what's one of the keys of this tumor is the fact that it has more hyalinized stroma, right? So that, again, we have not seen in the prior cases, and you have areas like this that are undifferentiated, can be anything. Yeah, but then if you have a bigger sample, you can move around and maybe find areas with what I just said, with more hyalinization. The cells are more obvious for you, spindly or ovoid, right? So then you start thinking that this may represent a poorly differentiated synovial sarcoma, right? So what do we call poorly differentiated? Well, we call areas that I just showed you that may look like Ewing or Ewing-like, lots of mitoses that are unrecognizable as synovial. And then if again, if you send for Archer, of course you'll figure out, but now you have a lot of immunosurrogates, right? So you have the SSX, SS18, and so forth, markers that you can include in your battery of round cell tumors, and maybe we can discuss at the end, if we have some time, what will be that panel, right? So a good example of poorly differentiated synovial sarcoma. You need to remember that entity when looking at round cell tumors. Okay, so let's see where we are. And this is just to confuse you, not to help you. This is a small bowel, right? So let's see if I can find an area. Okay, let's see, this one. Again, very monomorphic, ill-defined. You could say, oh, these look very, very similar with Ewing sarcoma. What's not great here is the stroma, right? Looks more bubbly, more myxoidy, and you move around and you start appreciating some very, very delicate capillaries in between, right? And then you see cells like this. Is this a lipoblast? Is this, right, some entrapped fat? So, and then you go in other areas that the myxoid component and the lipoblast, right, are more obvious. So this is an example of round cell myxoid liposarcoma. So what is this tumor doing in the belly? What is it doing in the small bowel wall? We know these tumors occur predominantly, 80% plus in the thigh. Some occur in the pelvis, but it's quite rare to occur there or in the retroperitoneum. This is because this is a MET, right? Myxoid liposarcoma that occur mostly in the thigh have a very unusual pattern of metastasis, including intra-abdominal, retroperitoneum, and bones, even before going to the lung. Okay, moving on to a different tumor. This one also seems to have some HPC-like pattern or pseudo-nesting. Okay, undifferentiated. I don't think anybody can say much. Moving around, we see this, so we are in the bone. I don't know if that's a hint or not. It's a bone tumor, right? Again, looks very undifferentiated, primitive, not much to say. And then we have areas like this, right? So this is an example of a round cell or a small cell osteosarcoma, right? Which is one of the most unusual subtypes of osteosarcomas. We're still debating, at least in the past, should these be treated like Ewing? Should these be treated like osteosarcoma? But this is a good example that you have areas of absolutely no osteoid, and then boom, you have areas of lace-like osteoid here. The radiology may or may not be helpful. We've seen cases that the radiologist was swearing it's an OS and turned out Ewing and back, and and vice versa. So it may not helpful, but this is I wanted to show you an example of small cell osteosarcoma. Okay, 3 more cases. Okay, moving on to bring up this discussion. We are in a lymph node, if anybody cares about the location. And this tumor seems to have larger cells, right, with a bit more cytoplasm. So it looks like the cells are bigger than the Ewing sarcoma cells. And then we see these, of course, solid sheets and also this pseudo-alveolar pattern. And then another very important feature here to look for are those multinucleated giant cells. So this is a beautiful, straightforward example of an alveolar rhabdomyosarcoma. Everybody should, be familiar and aware of. This is such a common tumor in kids. So if you have a small sample and the predominant components are round cell, the idea is you have to include desmin myogenin in your panel. Yeah, it's truly critical. Of course, if in doubt, if you think that you prove this is a rhabdo, but you're not sure is this an alveolar versus a poorly differentiated embryonal, right, molecular confirmation is required. They have completely different protocols for alveolar. They may give radiation that they will not otherwise give in an embryonal rhabdomyosarcoma. Okay, 2 more. Okay, everything looks the same, right? After a while, there's no much difference. Undifferentiated round cells, this looks very aggressive. Has lymphoid infiltration, has necrosis. So we tried everything. This was a thigh lesion. We tried everything, immunos, non-successful, and we sent it, of course, for molecular, and this came back as a not M1 fusion. So building on what Abbas has showed you, so you can have these tumors in the limbs or other soft tissue sites far from head and neck or other organs. This tumor in particular, and most of the ones we have seen in the soft tissue, are keratin negative. So there's no epithelial differentiation we can speak of. So what are these? Are these not M1 sarcomas, or the not M1 epithelial poor or absent carcinomas? So it's this always a debate, right, between sarcoma pathologists and the world. Is it SMARCA4 sarcoma or a dead diff carcinoma? I think the consensus for these lesions, in order to publish our paper, was mostly to say it's a tumor, right? It's at least a tumor. I have no problem if it's in the thigh, deep location, no keratin. I have no issue to say this is a not M1 soft tissue sarcoma. But again, this is not something that is fully accepted among experts. But I wanted to bring this up because clearly this case, and most of not M1 in the soft tissue that I've seen have an undifferentiated round cell quality. Okay, wow, we are. So although this may not make it as a, classic pure round cell tumor, I wanted just to show you this case, also because I couldn't really find a better one. To discuss this entity, I know it will be discussed later in, today or tomorrow, and already Abbas has mentioned. The point of showing you this case is to make the case of the GLI1 fusion tumors that have such a wide morphologic spectrum, right? So this may not be the perfect example, but we've seen cases that look like Ewing's, look like a round cell sarcoma, look like a B-core sarcoma, right? So then, we waited for the fusion, and then it was GLI1 positive. So it may show round cell component, it may show spindle cell component, and I'm just wanting to define you a bigger picture, right? Of course, most of them, may show this kind of nested, glomus-like morphology, but just to tell you that this is not something that you can only make it on morphology. And even more so for the GLI1 amplified cases, the morphologic spectrum is even wider. And a lot more cases are in fact spindly and have even some nuclear pleomorphism. So we don't have a good marker for GLI1 fusion. We've heard from Abbas that if this tumor is a GLI1 amplified, then we can do STAT6, CDK4, which are the neighboring genes that are co-amplified with GLI1. Here, some of these cases may be S100 positive. That was our experience in the first initial series, but we know now that not all cases are S100 positive. So may have a variable immunophenotype that may not help you. So in a case like this, I think molecular has to be done. And if, let's say, you don't have the possibility to run an Archer, or the clinician or insurance doesn't want to pay for it, the alternative platform would be a FISH for DDIT3, right? Because DDIT3 and GLI1 are really almost, touching each other, very, very close genes. So usually when you design back probes for GLI1, one of them is DDIT3. They are so close together. So we tested our clinic, because there is no GLI1 clinical FISH probe, but there is DDIT3. So you may try with DDIT3, and most of these fusions will be picked up, right? So I'm just saying an alternative if you don't have the opportunity to send this for Archer, right? So that's it with my cases. I'm hoping I didn't push the limit too much.
Okay, thank you very much for this wonderful tour through round cell sarcomas. We have time for some questions. Abbas?
Now 2 microphones. Cristina, thank you for this very nice overview. Do you think the BCOR or BCOR sarcomas be...
Because
Sorry.
this is not working. Yeah, go ahead.
Sarcomas should be split into subgroups, or using just a general heading, or different entities?
I think we need to split them. I mean, I didn't have a chance to talk about outcomes, but the B-core CCNB3 actually do quite well. They do much better than chick ducks. They do much better than Ewings. They respond very well with Ewing sarcoma protocols, as opposed to B-core ITD that are extremely aggressive. So those two, at least for sure, need to be separated under the B-core altered family of tumors.
CoA-L1 fusions belong to them, or are they a different entity?
We don't have enough cases, I think. They probably don't fit in any of those two, but if we're talking about WHO, that will not be included, you know, like B-core MAML2 or B-core L1. I don't think those very rare events will, you know, will be included as a separate subgroup.
Okay,
But at least I hope the fusion and the B-core ITD will be separated.
Thank you very much.
Hi, Cristina. Thank you for your gorgeous and comprehensive presentation. Although you mentioned cellular monomorphism is the norm of classical Ewing sarcoma, have you ever come across any exceptional but bona fide typical Ewing sarcoma that shows a striking nuclear polymorphism?
Even if I saw it, I wouldn't pick it up to bring it here. You know, I always tell my fellows I'm not going for the zebras. You know, I always want to think of Ewing sarcoma like a very monomorphic, and if it's something doesn't fit, of course we do the fusion and we see if it's a truly unusual atypical Ewing sarcoma. I think as you will show in your presentation, right, we have cases that have the typical fusion, either for Ewing or for extraskeletal mixer, and the morphology doesn't fit, right? So we know that there are these cases that, you know, and that's why some people that don't believe that much in molecular say, well, you know, maybe you just drop the molecular. So I think though, when you talk about Ewing sarcoma, that's truly an exception. There are exceptional cases that you may have some pleomorphism. Yes, I've seen, but I would say less than 1%. That will be not worthwhile discussing in a forum like this.
Thank you.
Thank you. So in terms of not sarcoma versus carcinoma, do you use a fusion partner as a reference? The fusion partner, not M1?
Not in soft tissue that much. I don't actually. I mean, I wouldn't call it a carcinoma just by the partner. If it doesn't have any epithelial differentiation, I would still call it, and it's of course in the soft tissue. I will call it a sarcoma.
Okay, thank you.
Any more questions? If not, I might have one very simple question. So if you didn't work in New York, but in some peripheral lab, without molecular lab behind your back, and you saw a typical case, morphologically typical, clinically typical case of Ewing sarcoma, would you feel secure with your experience signed out by immunohistochemistry and morphology?
Yes, with my experience right now, I would. But again, has to be perfect. In the clinical setting, morphology, that CD99, we have now the NKX, which works so well. So I think now there is a justification to be able to sign out cases without, but I don't want for this audience to say that, you know, it should be done that way. I think the importance of a correct diagnosis for clinical management is so important.
Yeah, and in your practice in New York, do you go straight for Archer or do you start with FISH?
As I mentioned, if everything fits and I just want a confirmation, an EWS FISH is fine. Otherwise, if it's something that I will go straight to Archer.
Okay, thank you very much. Any more questions? We still have some time. Okay, there one in the back.
Hello. Regarding the cheek sarcoma, is DUX4 immunostain enough for most cases, or do you always go to molecular to confirm?
So I showed you the best immunos, right, that may guide you toward the chick dox diagnosis. At the end of the day, I would certainly do the fish or archer. I would not let any case diagnose the chick dox only by immuno or morphology. I could, as Michael said, if I work, somewhere else, based on what we know now collectively from the literature, I think probably we will diagnose correctly 30 to 50% of these cases based on what we know now. But still, as Albert raised the point, we see so many of these unusual cases, and then we get the molecular and we are all surprised. So if possible, I would say confirm it every single time for chick dox.
Okay, thank you.
Thank you very much for the question. There's time for one more question. And if anybody would like to ask a question, please stand up so that this camera can see you. Yeah? Anybody? Question? Okay, if not, I think we can call it a break. And we meet here at 10:50. Please come on time. So, ladies and gentlemen, hello again. Please have a seat. We will initiate the second session of this morning. We will have 3 wonderful talks. The moderators are Abbas Agaimy and Dr. Josephine Dermawan. And the first speaker.
It's my pleasure to introduce the first speaker, Dr. Abbas Agaimy, who needs no introduction, from the University of Erlangen. Dr. Agaimy.
So thank you very much again, Josephine, for the introduction. I was asked by Michael to speak about phenotype versus genotype. I spoke about this as Juan Rosai keynote lecture at the last ECP meeting in Florence, so I adapted this a bit to fit the soft tissue topic. I have nothing to declare, and these are just the outlines I'm going to speak about, just very basic discussion of the phenotypic dogma. Of course, you are all experts, soft tissue pathologists. I don't need to go deep into this issue. Then also I will touch on some emerging issues like fragility of many of the phenotypes that we consider to be specific, the value of clinical anatomic impact or context for classifying neoplasm, and of course, the aberrant phenotypes or immunophenotypes indeed that we are seeing every day, and the consequence of these in giving frequently inappropriate terminologies to name entities because just of one positive marker or 2 or 3 jointly positive markers. And at the end, very few words about the emerging new tools. I think others will speak about this in a more detailed way. We know that historically all neoplasm, soft tissue and non-soft tissue, has been classified by phenotype. And this basis of classification has, of course, some conditions. The first one is that the neoplastic cell population has a normal counterpart. We have a reference cell phenotype, and we measure the differentiation based on that present non-cell phenotype. This, of course, is a very challenging issue because we know that we have more than 200 terminally differentiated cell types in the human body, and then we have a lot of temporally status of differentiation, especially in cells with myoid or myofibroblastic-like, myoepithelial-like, histiocytoid-like cells. They can differentiate and then go back and so on. And if you multiply all these and you consider this gold standard sentence by Dr. Ozai that there is no cell type in the human body for which no neoplastic counterpart exists, even the nail matrix, then we know that we are dealing with more than 1,000 different phenotypes. And this is a very, very complicated issue. And the other complicating point is that not only this huge number of phenotypes, but the reality is that each phenotype can be present in a variation between 0 and 100%. This is a very big problem. So we see something with a focal feature, and then the next case will only show this focal feature at the predominant or the isolated phenotype. This is a very, very complicated issue. We have, until recently, or maybe 2-3 decades ago, 3 gold standard tools. We have the morphology or the immunohistochemistry based on H&E stained slides. And after that, we got the opportunity of ultrastructural morphology, which shows even more reality than what we see sometimes with the naked eyes under the microscope. And then came later on in the 80s, the immunohistochemistry, which is really a solution and a problem at the same time, and we will see that. So these are 3 tools to recognize phenotypes based, again, on the condition neoplastic cells have a non-physiological cell counterpart. Based on these assumptions, we have a long list of differentiated phenotypes in soft tissue: smooth muscle, rhabdomyoblastic, adipocytic, neurogenic, and so on, chondro-osteoblastic, fibroblastic, myofibroblastic, myoepithelial, and so on. And the definition of these phenotypes was mostly based on morphology, differentiated features, plus immunohistochemistry in necessary situations or in selected cases. However, this concept of differentiation or phenotyping of neoplasm has 3 conditions or assumptions. In some words, it is not always a true point. The neoplastic cells have a non-physiological counterpart. The immunomarkers we use are phenotype specific, and the anatomic and clinical context is irrelevant for subtyping of these tumors. This is the situation where you can use immunohistochemistry liberally to tell this is rhabdomyosarcoma in the nasal cavity, this is rhabdomyosarcoma in the urinary bladder, this is rhabdomyosarcoma in the skin or in the CNS, and so on and so on. However, this became very fragile after we discovered many other observations or data. And you see here very simplified approach. Rhabdomyoblast indicate rhabdomyosarcoma, keratin expression indicate epithelial origin or carcinoma, and so on. Neuroendocrine marker as well as neuroendocrine carcinoma. And also even the concept of multipotency with embryonal primitive elements are called malignant or just teratoma. This is not correct any more nowadays. Then I like to show you just examples of the problem with these phenotypic issues. This is an example of a 19-year-old male with a sinonasal mass. We see a small round cell malignancy, very solid chromatin, crush artifacts, really very, very consistent with the small cell neuroendocrine carcinoma morphology. And again, we see here, of course, that the immunohistochemistry, I think this is not this one. As we see here, so keratin pattern is positive with the same pattern we see in small cell carcinoma. Then we have neuroendocrine marker. So everything is perfect for small cell neuroendocrine carcinoma, but we have a false age for that diagnosis. And of course, if you go on, we'll stand for desmin, myogenin, and then you do molecular, you find this is a solid pattern alveolar rhabdomyosarcoma with PAX3 FOX1 fusion. So it means that we see some small cell neuroendocrine carcinoma-like malignancies that are indeed rhabdomyosarcoma. Then we have exactly the reverse scenario in the urinary bladder. This is an older male, 62-year-old, with this morphology, small round cell, synaptophysin diffusely positive, myogenin diffusely positive. Then we ask ourselves, is this a rhabdomyosarcoma with neuroendocrine differentiation, or a small cell neuroendocrine carcinoma with a rhabdomyoblastic differentiation. We recently did a small study on this, and indeed we found that the same frequency of third promoter mutation as a hallmark of urothelial origin neoplasm in the bladder or in the urinary system are present equally in small cell neuroendocrine carcinomas without rhabdomyoblastic features and in so-called adult rhabdomyosarcoma alveolar type in the urinary bladder. This means that we are dealing indeed with a urothelial origin malignancy showing the same genotype and lacking the genotype of rhabdomyosarcoma. So indeed, some of these phenotypically rhabdomyosarcomas at this location are small cell neuroendocrine carcinomas with transdifferentiation. This means only the context in this case, the anatomical and the clinical context is the difference. The morphology, the phenotype, everything is exactly the same, and the genotype then is more fitting the anatomical and clinical context than the morphology itself. We see here 3 examples of 3 neoplasms. All of them by all features are classical osteosarcomas, some with some aneurysmal or angioectatic features. However, one of them is retroperitoneal in a core-needle biopsy initially diagnosed, and one is in the bladder again, and one is in the breast. And we know that when I see something like this, really I don't need to look for more deep molecular testing in the breast. This is metablastic carcinoma with heterologous osteoblastic differentiation. The same thing applies for urinary bladder cases, and the same thing applies also for pancreatobiliary neoplasm with this morphology. And in the retroperitoneum, I go for MDM2 CDK4 amplification, and it was. So this is a dedifferentiated liposarcoma with osteoblastic differentiation. You see here very nicely illustrated. So it means, again, we have a clinical anatomic context that defines and implicates the diagnostic explanation of these findings. We see here a lot of images, really out of context. At least 6 independent entities are seen here. We see undifferentiated, focally gland-forming, focally bone-forming malignancy, then an adenocarcinoma-like. Here images, we have here again cell tumor-like component. We see pleomorphic rhabdomyosarcoma. You see here even within a lymph node, a high-grade chondrosarcoma. So out of context, different morphologies, different phenotypes, and believe me, the immune will not add any more on this, because if you see cartilage, the immune will be that of cartilage. If you see pleomorphic rhabdomyoblastic cells, the immune will just confirm what you are seeing with H and E stain slides. However, all of these were molecularly confirmed and clinically confirmed metastatic melanomas. All of them were negative for all melanoma markers that we have. This means they completely lost their phenotype and they adopted a new immunophenotype, but still, of course, their genotype is retained. We all, as soft tissue pathologists, know this very nice series on epithelioid rhabdomyosarcoma in adults and the elderly. And when you go to that paper and you read, you see that several patients in that series indeed have a disease limited to the lymph node, axillary or inguinal lymph nodes, without a primary. There was no soft tissue primary. So these really are, at least in part, undifferentiated melanomas showing these unusual presentations that we know. This brings us to the consideration that indeed pleomorphic rhabdomyosarcoma in older individuals, in my opinion, is a fiction rather than a fact. And we have very few over the years, really. I made the diagnosis maybe 2-3 times after excluding all possibilities, and even after that, I make a comment, this is not very solid diagnosis. And we see that, we see it mostly in lymph nodes, we see it at location where we expect metastasis more than primary soft tissue neoplasm, and therefore always think of dedifferentiated melanoma when you see this rhabdomyoblastic morphology, no matter if it is axillary or inguinal or GI or in the lung or in the neck, and so on. And then we have, of course, in some visceral organs, sarcomatoid carcinomas, like in the breast, like in the bladder, in the kidney, pancreatobiliary. I have seen a couple of cases in the skin. Really, the biopsy was pleomorphic rhabdomyosarcoma. Then I got resection. It is basal cell carcinoma transmitting into a pleomorphic rhabdomyosarcoma. So we have to be very critical about that. Merkel cell carcinoma, neuroendocrine carcinoma, in general, tend to show these rhabdomyoblastic features. And the clinical history and the mutation testing, of course, is very important. Now, moving on to another point, which is the presence of aberrant immunophenotypes and also of shared genotypes that are very problematic in naming or calling disease entities. We know that the gene fusions that we are discovering almost every day nowadays, they usually dysregulate a lot of cellular pathways. And these dysregulated pathways usually will dysregulate cell differentiation processes. And then you may have either a monotonous new aberrant phenotype or an odd phenotype combining features of many entities. And even we see, of course, at the immuno level, different markers expressed that they are traditionally not fitting each other. But in that context of a specific fusion, they are very helpful to make a diagnosis. We all know that desmin, ALK, and EMA have been used for a long time as surrogate markers for angiomatoid fibrous histiocytoma in difficult cases. Now we know, and we have seen cases of TFCP2 fusion rhabdomyosarcomas with low molecular weight keratin, ALK, and desmin as well. And Dr. Recchi will speak more in details about this FET-CREP fusion sarcoma. They have a little bit from everything almost, but most frequently EMA, cytokeratin, neuroendocrine marker, ALK, and so on. And also we see frequently cases with S100 expression. And S100 was once considered as a neurogenic marker. Now it is only neurogenic if it is combined with SOX10. And it is only melanocytic if it is combined with SOX10. So S100 positive, SOX10 negative, this is a fusion neoplasm or a histiocytic disease, but not really a neurogenic or melanocytic disease. Frequently, we see co-expression of S100 and CD34 in tyrosine kinase fusion, especially in NTRK, but also in RET and ALK fusion cases in subset of them. This means these aberrant markers are responsible for a huge terminological confusion in the unexperienced hand of non-soft tissue pathologists, of course. However, at the same time, they are the best clue for several entities in the experienced hand. So we can use them. I sometimes said we abuse them to come to the diagnosis in specific scenarios. Now we see a lot of literature on these tumors with this fusion, and you see that the soft tissue groups mostly use a descriptive term, starting by the study by Cristina Antonescu and Beta Argani here, just call them epithelioid, and they are keratin positive in the abdominal cavity because you can't give them a specific name. As soon as you start to think to give them a histogenetic term, this will not stay the test of time. This will be revised very soon because you don't know what they are. And we see here all of them have really very distinctive clinical pathological features, morphology, but they can occur at any site. And I have shown you a case with this morphology. And in this case, you see all pattern mostly in the same case. So this will be the topic for Dr. Recchi. I do not like to go in details, but you see paraganglioma-like, neuroendocrine-like, even sometimes you consider Gleason tumors if you see this morphology as well, and you see that the immunophenotype is very misleading. Pankeratin EMA, so the unexperienced will rush to call it carcinoma or mesothelioma if it is at mesothelial sites, and so on, and then we have to be careful about that. Then you see the other scenario, the same entities, the same diseases, the same fusions. You see that they can be called as everything. One case reported as epithelioid MPNST, one as malignant paraganglioma, one case as SEF, and so on. And the only problematic paper, I think, is that here you see that because just GU people has a overhand in this series, they call it sex core tumor because they are in the testes and because they look like inflammatory seminomas and they have some SF1 expression and so on, but really exactly the same disease and very, very, very aggressive biology. So we have really to be careful about that. Then I like to give very few words about emerging tools. And I know that Daniel will go in details about methylation, but I like to give you very few examples from the dark side. He will give the light side, of course, more detailed. I was few years ago in Heidelberg, and I sat with Andreas von Daimling, and then he showed me this very fascinating methylation testing tools, and I asked him to perform a very simple test because I like to see what are extraskeletal osteosarcomas. And then he asked what cohort to put in, so we included classical osteosarcomas, low and high grade, tenosynovial gain cell tumors, chondrosarcoma, low and high grade, and many other gain cell tumors as well of bone. And then we put these extraskeletal so-called osteosarcomas, and indeed it was very interesting to see that these tumors form two clusters, one of them here, very close to one of these categories, and the other one distributed among classical bone osteosarcoma. So we have two distinct cluster and osteosarcoma-like cluster. Then I asked him, please add a UPS cohort to test if this is really still the truth. And as soon as we added the undifferentiated pleomorphic sarcoma cohort, you see that this distinct cohort came and clustered here very close to that or with that. This means, indeed, this clustering, even it seems in some cases to be a relative phenomenon. So if you have a very close cluster, then you go there. If you have a more closer cluster, you may even cluster with this newer or newcomers more closely. We did also recently a study on dedifferentiated melanomas, and also here we see that in at least half of the cases, some of these tumors lost the epigenetic methylation signature. And some of them still are classical melanoma by copy number profiling, and the reverse is true. Some of them are just not concordant always. So we see that some came back as MPNST-like, 4 as osteosarcomas, and 2 as UPS. And if you look exactly at this one case, 4 different samples from the same patient, all copy number profiles are very concordant indeed, but you see that 2 samples came back as osteosarcomas. Histologically, one of them was a chondrosarcoma, the other one like a UPS. This one failed the testing due to degradation of the DNA, and this came as melanoma. So this means even in the same patient, we have different spots. One metastasis is still retained, copy number profiling, and even methylation signature as melanoma. One lose one of these 2 findings, and one lose both, and so on. So this is a very interesting issue, and indicates also that all these tools have their limitations. And of course, at the same time, not only limitation, but they have their hazards, because if you over-depend on them, you are going to misclassify many cases. This is one of these issues, just to highlight, but we will hear this in more details in the talk by Daniel. Just to conclude, we go back to these historical phenotypes in soft tissue, and indeed we see that really very few phenotypes are very resistant. They are still very valid. The most important of them are indeed smooth muscle. I have never seen a smooth muscle differentiation in a non-leiomyosarcoma. Of course, there are reports of dedifferentiated liposarcoma with a smooth muscle phenotype, but really, many of these cases, they are smooth muscle by immunophenotype, not by morphology. If we stick to the classical smooth muscle cell definition, they are not really. They have pointed nuclei, but more fibrillary cytoplasm or very variable nuclear morphology. And a depocytic neoplasm, if we exclude lipomatous variant of some entities, it is still a very solid phenotype. When we see a lipomatous neoplasm, it is a lipomatous neoplasm. And the same applies also for endothelial neoplasm. Really, we don't see heterologous angiosarcoma component in very rare, maybe in MPNST, and we don't know if it is not a trans-differentiation to another neoplasm. So these all other rhabdomyosarcoma-like, osteosarcoma-like, chondrosarcoma-like, and myoepithelial and myofibroblastic-like, all these entities really are just context-dependent. This means we should go back and really revise all the misconceptions. So keratin does not mean carcinoma, and rhabdomyoblastic cells do not mean rhabdomyosarcoma. Neuroendocrine marker are very ubiquitous in many entities of non-neuroendocrine epithelial, mesenchymal, and so on, and even melanocytic can be seen, and it is not justifying to call them neuroendocrine carcinoma. So these are just older misconceptions that need to be revised, and the solution, of course, is not completed yet, but we have always to think that we have limitation of morphology, limitation of immunohistochemistry, limitation of molecular examination by all available tools, of course, limitation of AI as well. I do not like to speak about that. And then we have to incorporate inclusion and exclusion criteria. This means the age of the patient is really very important. The anatomic site is very decisive for many diagnoses that are not possible based on morphology alone. The genotype in many cases is very important to call the entity if it is undifferentiated, because we know that after description of the MFH, indeed we got an MFH epidemic to have it in every organ, including visceral organ as well. So all these are undifferentiated malignancies that have lost their phenotype. The clinical history is sometimes very helpful. If I know the patient has a carcinoma somewhere now coming with an undifferentiated pleomorphic malignancy at another site or in a visceral organ, this is most likely metastasis until proven otherwise. And we have also to consider other context-dependent factors, of course, as well. What matters most, the phenotype or the genotype? Of course, this question cannot be addressed as black and white. The best answer is that we can neither adopt one of these unlimitedly. We have to think in a context-dependent way. Both approaches indeed can harm the patient, because if you over-depend on genotype, you will misdiagnose entities. You will give a fusion that is maybe for Ewing, but for a less aggressive or benign entity. And the reverse, of course, is true. And not only the phenotype or the morphology suffers from plasticity of cells and transdifferentiation capabilities, but also the molecular testing tools, they suffer as well from their limitation. They can just give you a completely new entity just because everything has been reprogrammed. And this is also have been seen as I have shown you in melanomas as well. We always are trying to answer these two questions. Which treatment modality fits which patient or entity? And who needs which treatment and which type or strategy for follow-up? We can do that really not by the genotype, but mostly by putting the phenotypic context, if necessary, with the genotypic features into a definitive and solid entity. The goal after that is just to avoid over-treatment for not aggressive malignancies having a pseudo-aggressive genotype, and to avoid under-treatment for tumors that are looking bland, like low-grade fibromyxoid sarcoma, that looks sometimes like a neurofibroma, but they are very aggressive, we know that. And the inappropriate treatment, of course, to give a neuroendocrine treatment for a mesenchymal neoplasm or a sarcoma. So we have to be careful about that. This is just an example from our own cases. Internally, patient developed very huge, fleshy lower leg mass. You see here it is ulcerated, skin-based, and histology was UPS, all markers negative. Of course, the context is most suggestive of melanoma, but we don't have any melanoma marker positive. Send it for simple genotyping, BRAF 600 mutation positive. And you see here, it looks like just cut with the knife after a few weeks of vemurafenib and immune therapy. So this means if I go in such a case by the morphology and immunophenotype, it is undifferentiated pleomorphic sarcoma. I give that treatment, the patient will die within few weeks of extensive growing metastatic disease. So this is a very, very, very important take-home message. And if we think, this is the final slide, just in descriptive terminologies versus histogenetic labels, I think this is still very problematic, because for the greatest part of what we are seeing every day as soft tissue pathologists, if you exclude the classical like liposarcomas, leiomyosarcoma, angiosarcoma, and so on with these very solid phenotypes, then we have something really that we don't know what it is. So giving a descriptive cytological terminology like epithelioid sarcoma, I don't think that one day will come that we need to change that name. Or alveolar soft part sarcoma, everyone knows what it is. These are merely descriptive terminologies. They are now more than 60 or 70 years old, but they will continue as such because the definition is very clear and the name is very descriptive. So we can't, this was the question before also by Cristina, how to call some of these. I think descriptive terminologies are much more resistant than presumable histogenetic committed terminologies. And the answer is just based on the observation that gene fusions will generate a lot of phenotypes that are not really finally differentiated. We don't have a terminal differentiation. We have a little bit epithelial-like, a little bit myoepithelial-like, or neurogenic-like, and so on. So at the end, really, we can't give a final name. So histogenetic origin is just elusive if we think about these entities. We know now that we see a lot of neural-like, perineurial-like, and so on and so forth. And I think this is last year. We give you very nice example from my original country. You see the sun even is not always looking the same. So thank you for your attention.
Thank you so much, Abbas, for the amazing talk. We have some time for questions. So, please raise your hand if you have any questions.
Questions, comments, critics, different views.
Thank you very much for your talk, Ms. Abbas. I was wondering, because you told beautifully about the difference between the phenotype and the genotype. How do you think our reporting will evolve? Because, for example, now in the neuropathology, there is integrated diagnosis certainly with the upcoming of the methylation profiling. An integrated diagnosis is given with also the histological and genetic information all included in the conclusion. Do you believe that for the soft tissue tumors we will, in the end, do a similar thing? Or how do you see these things evolve? Thank you.
Thank you very much. At least I hope it will not go the same way neuropathology went. And there is now no neuropathology in the sense of phenotypic pathology or histopathology, but molecular. And you will get back the clustering, if it is IDH2 mutant glioma with or without that deletion of certain chromosomes. So in my opinion is that all these tools complement each other. If you go back, as in the 80s, as the immuno came, everyone said you don't need morphology anymore. And 20, 30 years ago, as molecular came, many people said you don't need a microscope, but a microchip in 10 years. So all these really are not real. You will see propagation of these tools, but you always, in my opinion, I like to see the morphological control. What is coming back from the molecular, I don't sign the report just finally because that fusion was found. And really, not rarely, I sent the report back to the molecular lab and I said, this fusion does not fit this entity. You have to go back to eliminate contaminations. We know this also with mutation testing. We see occasionally positive mutations for presumable BDF receptor alpha mutated yeast, but I get exon 11 mutation in KIT. I said, no, there is something wrong. Go back, they repeat it, it disappears, and the correct one will emerge. So we have to have this morphological control. It's the same thing we do with bone pathology, clinical imaging. So you have these multi-step diagnostics. If really we start to omit any of these, then we are at a very high risk for patients, not for ourselves maybe, but for patients. And we have this tool or the list of tools. I do not go sequentially, H&E, immuno, and that, but at the level of H&E, I decide I need morphology plus what? Genotyping, and if genotyping, mutation or fusion testing, or even something else, or I stop at some point and I said, I like to see the methylation profile of this case. So all these are needed, but in still morphologically controlled way. And I hope very much that we will not give up and change our basic approach, because I think really this is a very important issue. We have the control now. We see the new findings. If we omit the morphological control, then we have a big problem, I think. And I think Daniel will confirm this as well in his talk. So you have to go back to see, is this matching really for that morphological context? Is the age consistent? Is the anatomic site consistent? So these really are very, very important issues. But if we go just immediately to the highest available tool, this would very likely be misleading. So I don't think our practice will change, but we have to integrate. So we cannot give just a descriptive, because S100 is positive, this is a myoepithelial carcinoma. That would be wrong. But we have to go for all these issues to see if there is specific diagnostic genotype. Sometimes you don't need more than morphology, the differentiated liposarcoma, or well-differentiated in the retroperitoneum. You don't need even immuno. You can diagnose that by H&E. And in classical cases, as Cristina said, classical Ewing, CD99, NKX2, everything is fine. I never have seen a case that looked like that and was tested for molecular, and a surprise came back. So you can't feel comfortable with these things. You have to select which modality you need. This is my opinion.
We have time for one more question.
Abbas, I have a question. Can you give the audience a guideline? When do we have enough to call a new entity?
The question should be referred to the WHO committee of experts. I'm not a part of it, but of course, I think as soon as we can recognize something by morphology and clinical context, anatomic context, and then go to the molecular, we have the same genotype. So this uniformity is really very indicative of a specific entity. If all molecular findings are surprise, then it is not. Sometimes, of course, it depends on the individual observer eye. I see one case and I get a fusion, then I see the next case, I said, I suspect that fusion, it came. This is an entity for me. But for others, you need to see maybe 5, 10 cases. If you go back and you look the morphology again and you see really they have shared features, I would say this is an entity. The problem will be then, is it defined really by genotype or by morphology? We have entities like pseudoendocrine sarcoma. It is very clear diagnosis, even you don't need really molecular testing, or chondroid calcifying myxoid neoplasm. It is a low power diagnosis, but it still have a very specific genotype. I think uniformity is enough to call something entity. And really, if we go back, all entities described by Franz Enzinger, they were H&E based, and in some cases selectively with electron microscopy. Epithelioid sarcoma, clear cell sarcoma, all this now, if for those questioning the value of morphology, all of them are confirmed as molecularly distinct. They were based really only on molecular characterization, but usually with clinical anatomic context. So for him, clear cell sarcoma was a tumor of tendon and aponeurosis. We don't think about that now. We see everywhere something, we call it clear cell sarcoma. So I think uniformity is really very important. The WHO, by the way, asked it for 2 independent series, 5 case minimum each, and then this can be at least considered as a possible entity. But I don't think. So the earlier descriptions were just single case series of 50 or 60 cases, especially those came at that time from the FIP. They were definite entities. Of course, sometimes we miss something. I remember Dr. Enzinger revised himself at least twice by angiomatoid fibrous histiocytoma. He pulled it out from the MFH category and said this is a low-grade distinctive neoplasm of adolescent and young patients and is not killing any patient. And took also the spindle cell hemangioendothelioma as being a vascular malformation based. Initially was called as a subtype of hemangioendothelioma. This is really something that we currently, unfortunately, we don't see. People are protecting what they have postulated, so they will not come back and say, no, we were wrong. This is a fully benign. It is not intermediate. This is even not neoplastic. This is a vascular malformation and so on. So we need this approach, but I think now we have 2 tools, which is very superior to the earlier time. And these two tools indeed were molecular. We can't confirm. We know that earlier we pressed many things just because of some morphology overlap into a category. It was not the correct diagnosis, but now we can test that by molecular. And then we have the new tool of methylation, if this is really an entity. We have something that overlaps with an entity, it has this different genotype. We send it for methylation, it clusters completely separate. I would say this is in favor of an independent entity. Although I cannot also claim that molecular subtypes in a specific entity should always cluster together. I don't know. This may be not my experience.
Okay, thank you very much. The next speaker will be Josephine Dermawan. Josephine works as a bone and soft tissue pathologist and also a molecular pathologist at Cleveland Clinic. And in her research career, she has been taking advantage of her knowledge and education in both of these areas, and her talk will be also a combination of molecular pathology and soft tissue pathology.
Hi, thank you so much for the kind introduction and the kind invitation. So this talk are designed to be extremely practical. All of the cases I am going to discuss are all actual cases that we've seen at Cleveland Clinic, and how we emphasize the using morphology, as Abbas has mentioned, to correlate with molecular findings. And it can never be a vacuum when we interpret molecular findings. And by extension, I'm also going to be touching upon immunohistochemical surrogates, like next generation IHC, that's supposed to be a surrogate marker for molecular findings. So this first cluster of cases I'm going to talk about really focused on this extremely important chromosomal locus, which is chromosome 12q13-15. As Dr. Antonescu has talked about, as a very high concentration of transcription factors that often involve in genomic alterations that drive a lot of soft tissue and bone sarcomas. And some of the ones that everyone is familiar with include MDM2, CDK4, GLI1, DDIT3, STAT6, and HMGA2. A lot of those actually drive lipogenic tumors, but not all of them. So, okay, first case, we have a 28-year-old female, so young adult patient, liver mass. So again, like Abbas has pointed out, the clinical pathologic context really is extremely important. Young patient, and then, of course, you know, we have a fat-rich tumor, even on low power. And then high power, you can see the cells are pretty pleomorphic, has cytologic atypia, a lot of cytoplasm. I mean, in this location, you might think it could be a liposarcoma, and you'd fish for MDM2. And this is the test. First of all, the top line of the test will be positive, and then, but both MDM2 and SAP12, centromere 12, it's like kind of a low polysomy. Usually for liposarcoma, you know, you have the absolute copy number of MDM2, it's like way above 10. And so, okay, now what do you do with this FISH test result? So really, the point of this particular case is about distinguishing between polysomy versus amplification. So the consensus criteria of calling MDM2 amplification is the ratio of the absolute copy number of MDM2 versus centromere of chromosome 12. And a ratio greater than 2 is considered positive. But what do you do when the ratio is, in this case, is less than 2, right? It's like both like 6 and 7 copies, but it's kind of indicative of like kind of like a low polysomy of chromosome 12, or the region with multiple copies kind of encompasses chromosome 12, centromere 12. And so there's this actually really nice paper that I really like, but maybe it's often neglected, paper from International Journal of Surgical Pathology. They really tackle this issue of what does low and high polysomy of chromosome 12 means. And they found that you can see low polysomy in both benign and malignant adipocytic neoplasms, but pretty much when you see high polysomies, which they define as greater than 10 copies of both MDM2 and centromere 12, really is strongly correlated with a malignant adipocytic neoplasm in true liposarcomas. This is an example. Of course, you don't need to count the fish signals. It's almost uncountable. There are so many copies of MDM2 here, and this is an example of a true well-developed liposarcoma. And so really, it's important to look at the fish test results and also like the actual fine text, and not just look at the first line and then take that. You have to like really look at the report. And so this turns out to be a fat-rich picoma, and it makes sense actually in this context. It's quite unusual for someone younger than the age of 30 to develop well-differentiated liposarcoma. And this person turns out to have TSC complex. And so it actually makes perfect sense in this clinical pathology context. It's a fat-rich tumor, and now in hindsight, and then HMB45 is diffusely positive. Okay, next case is a 51-year-old gentleman with a fine mass. This is a fatty tumor, and again, soft tissue pathology 101. Every time you get a fatty tumor, I expect the fellow to tell me is it deep or superficial? Like, nothing else really, like this is like the most important thing. If it is an extremity, I expect them to tell me immediately if it is above or below the fascia, right? Because really, in general, atypical lipomatous tumor should be below the fascia, intramuscular. However, this fatty tumor kind of like straddles both, like it is subcutaneous mostly, but it kind of extends beyond the fascia into the superficial musculature. And of course, like you fish for MDM2. And MDM2, again, ratio is 1.21. So technically the report top line is negative for MDM2 amplification. However, if you read the second line of the report, MDM2 copy number 25. So that's the absolute number of signals. Like basically when the fish type will just count number of MDM2, number of centromere 12, and this is a really high number, higher than 10. So how would you interpret this MDM2 fish? So in this situation, this is like a high level of chromosome 12 polysomy. So both SEP12 and MDM2 copy number are very high. And so again, if we remember what we just talked about, like we interpret this, okay, this is much more likely for it to be in a malignant or atypical lipomatous tumor than a benign adipocytic tumor. So again, read the report, don't just read the top line. Okay, next case. Groin mass, older gentleman, kind of spindled ovoid in a collagenous stroma. You know, SFT, of course, can have a very diverse morphologic spectrum, and it's not always a good idea to include STAT6 in a panel of kind of like a spindle cell lesion with collagenous stroma. And then you do STAT6, right? It's positive. It looks like it's probably nuclear positive, but it looks like there's some cytoplasmic expression as well. But as we know, STAT6 immunohistochemistry is actually very useful. It's most of the time it's very specific and very sensitive. But this is a talk where this class of cases, again, I'm talking about this chromosome 12q13-15 locus. So Leona Doyle has a very nice paper about a pitfall of STAT6 immunohistochemistry is that when a tumor has amplification of this 12q13-15 locus, STAT6, again, is a neighbor of all of these transcription factors, including MDM2. And nobody says only MDM2 is amplified, right? Like the amplification locus can really encompass any number of these transcription factors. And so when MDM2 and STAT6, they are co-amplified, it will lead to the upregulation of STAT6 gene and the protein. And you will see this nuclear and cytoplasmic expression pattern. And so in those cases, the positive expression of STAT6 immunohistochemical stain, it doesn't mean that it has a STAT6 fusion. In this context, it's a de-differentiated liposarcoma with co-amplification of MDM2 and STAT6, and which was confirmed by the MDM2 fish test result with this positive amplification and high MDM2 copy numbers. Okay, next case. We have a superficial subcutaneous thigh mass, 42-year-old man. For some reason, someone ordered MDM2 fish. If you believe in superficial dative or sarcoma, And MDM2 is amplified. And if you like the immunostain, it does show pretty strong dark nuclear expression of MDM2 by immunohistochemistry. But you already know there's a trick to it. Maybe superficial differential liposarcoma is a real entity, but you look at the morphology, it is mostly composed of epithelial cells, somewhat monotonous, fakely nested. And so this is a case of a GLI1 amplified sarcoma with co-amplification of MDM2 and GLI1. This is a very nice paper from Carla and Dr. Antonescu from Memorial Sloan Kettering, where they look at a series of GLI1 amplified sarcomas and also GLI1 rearranged tumors. And this plot that Carla created, she's really showing that there's this like co-amplification of MDM2 and GLI1, kind of in a bimodal type of amplification in GLI1 ultrasarcoma. So often MDM2 is co-amplified with GLI1, and if you only fish for MDM2 and you only take MDM2 fish testing as equivalent to liposarcoma, then it's very easy to go down the drain and say, oh, this is the differential liposarcoma. And why does it matter? I mean, in this paper, they show that GLI1 amplified sarcomas seem to do even worse than the differential liposarcoma. So in my opinion, it does matter, correctly classifying it being a GLI1 driven GLI1 ultrasarcoma versus a differential liposarcoma. Okay, this case actually I really like. So the molecular pathologist who's signing out Archer, they reached out to me. It's like this intra-abdominal mass, 29-year-old man, with this out-of-frame STAT6 fusion. So they were like, what do you think? Is this real in this context? Because obviously they haven't seen the morphology, they don't know what we're trying to look for. Is this some kind of a novel fusion variant in SFT? And then we can write a cool case report, send it to Dr. Antonescu's journal, GCC. But then it's out of frame, right? I mean, that raises a red flag. And so once I saw this and then I went back and looked at the morphology, it's like, oh, wait a minute, this is like kind of, again, nested and the cells are epithelioid. It's nothing super specific, but it doesn't make sense for a novel out-of-frame STAT6 fusion with a different powder that is not NAP2. And so one thing about a lot of RNA fusion panel, including Archer, is that you can actually look at the gene expression on some kind of like pseudo heat map to look at the expression of the genes on the panel. And here, actually there's like a strong upregulation of gene expression of HMGA2, GLI1, and some STAT6. And so again, is this amazing locus on the chromosome 12q13-15 that has such a rich concentration of all these important genes and transcription factors. And in this case, again, this is a GLI1 amplified tumor that we confirmed by FISH showing GLI1 amplification with co-amplification. And so the point of this is really when we interpret fusions, of course, a lot of soft tissue tumors and bone tumors are driven by fusions. But just because you have a structural rearrangement doesn't mean that that's a driver. I really want to caution everyone, especially in the locus with gene amplification, that's often when there's some level of chromotripsis, where it's like this portion of the genome is shattered, and there's like this breakage, fusion, bridge cycle. So there's all these like little circles of structural variants. They are all passenger structural variants, passenger gene arrangements. Sometimes they can be transcribed from a DNA to an RNA level. So you can detect some of these passenger structural arrangements on RNA sequencing. So just because you detect something, a gene fusion, don't immediately think that, okay, oh wow, I have a novel fusion, I discovered an entity, submitted to GCC, or to just try to look at the context, and if this is a region that could have potentially gene amplification, be extremely careful. I'm not saying that it can never happen, that you cannot have a fusion driver in a region with gene amplification. Like PAX7 FOXO1 is a good example. PAX7 is almost always amplified in alveolar rhabdomyosarcoma with PAX7 FOXO1. But really, in a lot of cases, they are really just like garbage. It's like, do not just look at the fusion and then say, okay, we have a novel fusion. They have to be, most of the time, they should be in frame for them to be functional, or it should make sense in the clinical pathologic context. Again, as I have alluded, Carla has showed very nicely with this largest series of GLI1 altered tumors that GLI1 amplified sarcomas have a significantly worse survival compared to GLI1 range sarcoma. This on the left is the overall survival, so the outcome is death. It's like almost the GLI1 range cases are completely flat. Doesn't mean that they are benign and perfect, but it's the amplified cases are really much worse. So in my opinion, it's important to really correctly identify these cases. Next, I'm going to talk about cases using so-called next generation IHC. Again, these are very good tools. We don't necessarily always need to do expensive molecular testing. You know, they are very good surrogate markers. But again, as Abbas has pointed out, nothing is perfect. Nothing is 100% sensitive or 100% specific. We always have to remember the pitfalls of every single marker that we use. Okay, so we have a young patient, young adult, foot mass, very monomorphic spindle cell sarcoma with this herringbone arrangement. Looks like synovial sarcoma, monophasic. And then, you know, our lab had these two really useful immunohistochemical markers, SSX and SS18 SSX. But then only SSX is positive and SS18 SSX IHC is negative. What does that mean? Does that mean that it's synovial? Does that mean that it's not synovial? As we know, SSX itself can be upregulated in non-synovial sarcoma cases. And so the SS18, SSX antibody is actually remarkable because the breakpoint, the fusion breakpoint of SS18, SSX is remarkably conserved. In 95% of the cases, it is exon 10 and exon 6, and this, no matter whether it's SSX1, X2, or X4. And so the peptide flanking this fusion breakpoint is very conserved, and so Dr. Hornig and their team developed this specific fusion, this antibody that specifically recognizes this fusion junction. It has to be this one. It has to be exon 10 and exon 6 with this particular combination of peptides flanking the breakpoint of SS18 and SSX fusion. Whereas SSX is a C-terminus antibody that detects the upregulation of SSX protein itself. And so this is a downstream event when you have oncogenic transformation by the SS18, SSX fusion. One of the genes that is downstream that is upregulated is SSX itself. And so this combination, so SSX is highly sensitive, almost 100% because of this. SSX protein itself is almost always upregulated in the presence of SS18, SSX. So what is happening with our case? Because of this remarkable conserved fusion breakpoint, but again, we say that it's 95% of the cases approximately, meaning that there are 5% of the cases where the breakpoint is actually not SS18, exon 10, SSX1, exon 6. In this case, we sent for Archer because we're like, this has to be synovial. It really makes perfect sense. Young patient, foot mass, morphology is great. It turns out that this is exon 9 and exon 5, so it makes perfect sense. It's like, this happened to be one of the few subset of cases that falls outside of the 95% of cases that has this fusion breakpoint that is conserved. Dr. Antonescu could talk about CIC, Czech duct sarcoma. So we have a young adult with a fine mass, kind of like a round cell sarcoma, some myxoid stroma, but some of the cells have more prominent nucleoli. There's some pleomorphism that you don't see in Ewing sarcoma. And then we did DUX4 immuno. So I think there was a question this morning about, is DUX4 immuno enough to just say, okay, this is Czech ducts, I don't need to do molecular. We have recently published a series with Michal, and it is very helpful. Of course, like, I mean, the series, we include like a few dozen cases, but sometimes I will still do molecular to confirm just because, like Dr. Antonescu has mentioned, this diagnosis is so clinically significant. But some people in our group, actually, they would just sign out the case with DUX4 immuno alone with nuclear expression, and whenever we do molecular testing, I've never seen a case where it hasn't turned out to be a Czech duct sarcoma. But in this case, our RNA sequencing panel is negative for gene fusion, including CIC rearrangement. So we're like, oh no, maybe this is not 100%. So what is going on? And so, again, one thing about this talk that I want you to walk away from is that molecular testing is not like a black box, you know, you push a button and then like everything is black and white, right? I'll just tell me the answer. It's gonna be great, and it's like completely objective. There's no subjectivity, no variation. That is completely untrue, as we know. So every single targeted panel, they know the word targeted does not just mean that the genes are just like a subset of genes that are not all the coding, not all 20,000 coding genes, but it also means that the particular exons that are targeted, it's also targeted, meaning that not every single exon is always covered on the gene that is included on the panel. So in this case, if a fusion, if the genes involved in the fusion, the exons, are variable, sometimes even if that gene is on the targeted panel, does not mean that all the exons involved in the fusion is included on the panel. In this case, I actually sent it to Dr. Antonescu, like, can you use your Archer to see if this is a CIC sarcoma? And it showed exon 15, exon 1, fusion between CIC and DUX4. And then when I went back to look at our in-house Archer panel and look at exactly the exons covered, actually, it turns out that they cover quite a few exons on CIC 12, 17 to 20, but except for exon 15. So it really happened to miss this fusion. So again, really the point is just sometimes negative is truly negative. Most of the time, a lot of the panels, you know, like are very reliable. But if a result does not make sense based on the clinical pathologic you know, context, and you still really think it's something, try to confirm it with a different molecular test or different panel, because sometimes not everything that is designed to detect something, it can detect it 100% of the time. In this case, it's because it's an alternate fusion breakpoint. And in this case, it has ETV145 upregulation, so it's a perfect CIC DUX4 case. So this is the paper I was referencing. Michael, we worked together. And really, the caveat of this, one of the caveats is that it really is helpful when it's a CIC sarcoma where DUX4 is the 3' gene fusion partner. But of course, as you know, there's a subset of CIC sarcomas where the 3' gene is not DUX4. They are very rare, but they do exist, like FOXO4, not M1, etc. And so the DUX4, even though it's a chemical antibody, is a C-terminal antibody that detects the DUX4 protein. And when there's a CIC DUX4 fusion, it drives the nuclear translocation of CIC DUX4 into the nucleus so that it binds to CIC transcriptional binding sites. And so it does not detect CIC sarcomas when the 3' partner is not DUX4. So in this case, it's very sensitive, and we compare to many other mimickers of CIC sarcomas. But there's like one case that is a CIC sarcoma that we did not detect, which is a CIC FOXO4 case. Next case. This is a remarkable case. This patient presented with neurological symptoms with multiple brain lesions, not doing well. And when you look at the morphology H&E, it looks like there's all these like epiphyloid cells with abundant eosinophilic cytoplasm, lots of admixed hemorrhage, and then it expressed vascular markers including ERK and CD31. And then we tested for gene fusions, and there is this EGFL7 FOSB fusion. So as we know, this fusion has been reported in cytomyogenic hemangioendothelioma, but as I have mentioned, be extremely cautious when you detect a fusion that's out of frame. So does that mean that because it's out of frame, it's not real? The caveat is that there are certain fusions. USP6 gene rearrangement is a great example where it's always, the mechanism is through promoter swapping, meaning that the breakpoint is actually before the start codon of USP6. And so it will never be in frame because it doesn't, the breakpoint doesn't involve protein coding region. And FOSB fusion is actually quite similar. There's two really elegant papers looking at FOSB fusion, where there are situations where the breakpoint is actually, it causes the loss of the first exon of FOSB that contains the start codon. And then this fusion actually creates a novel start codon in exon 2. And so technically, when you map the breakpoint back to the reference genome, it will look like it's out of frame. But so this is also a promoter swapping mechanism that leads to an upregulation of phospho expression. So in this case, it involved a lot of conversation with the molecular pathologists, because for them, they don't just sign out anything that the pipeline spits out. They always look at the fusion and decide whether it's so-called real or not. And in this case, the molecular pathologists wrote to me and they were like, is this real or not? It's out of frame. They're not sure if they should report it. Maybe it's just an artifact. Of course, every NGS testing has artifact. But a deeper dive into the literature shows that it is possible. This RF fusion actually makes perfect sense, and it confirms the diagnosis of cytomagenic hemangioendothelioma, which is very important because the differential in this case is epithelial angiosarcoma, and we know that some cases of cytomagenic hemangioendothelioma respond to mTOR inhibitors, sometimes pretty well, and so it's not really very different from calling it epithelial angiosarcoma, which also has a much worse prognosis, as we know. So taking a step back, when do we do so-called NGS? Of course, we suspect something, we want to confirm our impression. Also, when there are like different entities with a lot of morphologic overlap, and at least one of them have a recurrent genetic alteration, it's helpful to do molecular to distinguish between these two possibilities. Sometimes I do that all the time too. It's like, oh my God, I don't know what this is. Looks monotonous. Looks like it has a fusion. Let's send it for Usher and see what happens. And then you pray to the soft tissue god that it detects a fusion. But then finally, of course, they are now emerging, no longer emerging actually, soft tissue tumors, right, that do have targeted actionable alterations. GIST is a classic example, but the emerging kinase altered features, now we can target them and it's treatable. And so in this case, it's not just for diagnosis, it's for therapeutic purposes. Again, this is just, to say that like, I really don't like the term just NGS, oh, let's just do NGS, let's do NGS. Like, NGS means so many things. It could be DNA, it could be RNA, it could be whole genome, it could be whole exon, it could be targeted. And when you have a targeted panel, which is what a lot of institutions are using, it's so important what exactly is on the targeted panel. If the genes that you're interested in is not on the panel, this is useless. The negative result is not helpful at all. Okay, next case. This is an abdominal wall mass in a young adult woman. It looks like it's collagenous, has this like blend of praying myofibroblastic cells in sweeping fascicles. Looks like a desmoid. And then you try to look for CTNB1 mutation because desmoid of it, even though technically it's not malignant, it does carry with it pretty significant morbidity, and the management is very different. And so it's negative, right? But then when you read the NGS report, sometimes we like to, nobody has time to read scroll down all the way to the end. But in this case, if you scroll down all the way to the end after like 5 pages, there's like a footnote saying that there's all the genes that have low coverage for this particular sample. And in this case, CTNB1 has low coverage. It's only 67 to 70 coverage. The coverage here means that how many times you have sequenced that genomic locus. Really, for low variant allele frequency variants, having high coverage is really important to detect the variant, because you have all these non-neoplastic cells, with wild type sequences that would like overwhelm the actual signal. And of course, the very hot spot that you're interested in desmoid is on exon 3, S45, usually S45F in desmoid, and that's the exact region with low coverage. So you're like, oh, maybe it's a false negative result. So what do you do? Instead of just taking the report, just like, okay, that's black and white, that's the final result. Again, you talk to your molecular pathologist colleagues, they are also pathologists, they are also clinicians, so they are there, they are your resource. And then, you do a manual review on IGV, the genome browser. And then here, basically, this is a pair-end sequencing. All the pink stuff is forward reads, and then the purple lines are the reverse reads. And then whichever is not the wild type sequence, we show it in a different color. In this case, you look at the reads that are the variant reads containing the mutation. There are 6 alternate reads out of 70 reads. Alternate reads meaning that it has the variant. And it's actually, even though it's very low, it has very good balance of forward and reverse reads, meaning that there's no strand bias. Strand bias is one source of artifact we see a lot in NGS testing, and that usually those are just background noise, it's not real variance. So in this case, actually, the signal looks very good. There's 3 forward reads, 3 reverse reads exactly with the alternate C to T. And so with this, we added a footnote that we amended the molecular report saying that there's a low-level CTM mutation. Even though it falls below the usual threshold of variant calling, it looks legit, and then we're able to confirm the diagnosis of desmoid fibromatosis on this core biopsy. Next case is it's very interesting. It's a peripharyngeal mass, 38-year-old man, a ton of melanin pigment, a lot. It's much more than what you will see in melanoma. It's like so much that it almost obscures some of the cytologic features in a lot of the cases. Positive for all the melanocytic markers, OXA S100, HMB, melanate. It's very cellular. It's done a small biopsy, it's a resection. It came back QNS, which means quantity not sufficient from NGS testing. Doesn't make any sense. You know, we have a lot of tissue, good quality, it's not like necrotic. Why is it QNS? And one of the things that actually, it's a reason for QNS is not just the absolute quality and quantity of the nucleic acid. If you know a little bit about biochemistry, actually what is in the solution is very important, and melanin pigment is one of the substances that can interfere with NGS testing because it actually binds to the DNA polymerase. You know, like amplification of DNA is one of the essential steps in almost most NGS testing, library preparation. And so, but there is a way to overcome this is by diluting the solution so that you can, or you add some binding proteins like milk, albumin to kind of bind to the melanin to kind of like sequester it out from the solution so that it doesn't interfere with the DNA polymerase. And as you have suspected, this is a case of MMNST, formerly known as melanotic schwannoma, now it's malignant melanotic nerve tumor. And then actually the molecular laboratory, they already went ahead and repeated testing with a different method, and they were able to demonstrate the PRK RNA mutation, confirming the diagnosis of MMNST in this case, which of course is important because the treatment of melanoma versus MMNST is very different. MMNST usually does not respond to immunotherapy. This is really straightforward, but also not. So this is, again, young person with this pleomorphic tumor. It looks like it should be a sarcoma. You know, the cells look atypical, very irregular nuclei, a lot of cytoplasm, diffusely CD34 positive. But as we know, there is this entity called superficial CD34 positive fibroblastic tumor that often is diagnosed as sarcomas, but they are indolent, and really there's maybe a subset of cases with lymph node met, but nothing so far has been particularly aggressive. And so you really want to make sure you're not calling something a high-grade sarcoma when it is one of these superficial CD34 positive fibroblastic tumor, which you suspect with all this abundant glassy cytoplasm. And so, but then again, when you receive this case in consultation, it already came with outside, in quotation, NGS testing that is negative for fusions. So it is a panel that includes fusion testing. So you're like, oh, so it's not, because as we know, a lot of these cases, they have PRDM10 fusions. But really, it's really just to take a look at what exactly is on the panel. A lot of standard commercially available NGS panel, they are really for carcinomas. The fusions that's on those panel, they're usually fusions that we see in carcinomas like ELK, you know, NTRK, BRAF, but which is not, and often they do not contain genes that of interest for us that is seen in soft tissue tumors. And again, so this case, it doesn't have any mitotic activity, necrosis, so this disconnect, right, between the extreme nuclear atypia but the lack of mitotic activity. And so the outside NGS testing does not include PRDM10 fusion. So it doesn't help to exclude this entity, and so we're able to confirm it in this case. This is something that Abbas has talked about, how we see a lot of polydifferentiated sarcomatoid malignancies. Sometimes they came with a diagnosis of sarcomas, but again, the differential diagnosis would include polydifferentiated sarcomatoid carcinomas, undifferentiated, transdifferentiated melanomas. So in this case, this is young, this is like an old adult with a lung mass. Again, visceral organ, something that looks like a UPS. But then history of melanoma on the scalp, and everything is undifferentiated, does not express any melanocytic markers. So, so what do? Do you just call it UPS of the lung, and it's like extraordinary in an old person, probably a smoker, and then be done with it? So molecular testing actually it's very helpful because there's this dichotomy between carcinoma, melanomas, and sarcomas. It's general, of course, but in general, melanomas, as Abbas's paper had pointed out, they usually have an extremely high TMB. And what is high TMB? High TMB is really greater than 10 mutations per megabase. TMB, again, tumor mutation burden, really you're just counting the number of mutations per megabase of the genome. And anything greater than 10 is considered high. And usually in melanoma, it's like much, much higher than 10. And of course, if you happen to have access to a panel that detects mutation signature even better for you, most of these have ultraviolet light DNA, like a DNA damage etiology. And so those will still be present in the case of the differentiated/undifferentiated melanoma. And again, the treatment implications would be extremely different from having a UPS diagnosis. This is a paper that I actually really like. Again, maybe it's overlooked. So basically, just look at like 100,000 human cancer genomes across like almost all cancer types that you can think about. So like the gray box is really it draws a line at 10. Maybe like 20, like 30 mutations. And then the very top of this plot is like the 2 cancer types with the highest TMB across all cancer types. And then number 1 is cutaneous squamous cell carcinoma. Number 2 is cutaneous melanoma. If you look at the median TMB is like off the charts compared to like all the other cancer types in this plot. And there's like a bunch of, you can't see it on this slide, but there's a bunch of sarcomas on this plot, and they're like way low on this plot. And so, like, again, these 2 tumors, right, they are both really driven by ultraviolet light. And UV light inflicts a lot of mutations in the genome. It's one of the ways that they cause oncogenic transformation. And so when you see a sky-high TMB, it is not a sarcoma. The etiology that causes the oncogenic transformation is completely different. And so really these 2 I want you to keep in mind is really with high TMB across, the highest TMB across all cancer types. This is a really nice paper from Memorial Sloan Kettering from Dr. Mira Hamid. They look at the mutational signature pattern of undiff/diff melanoma versus UPS. It's completely different. Every single case here of melanoma is predominantly ultraviolet signature, whereas UPS is like has this like variable signature, is not very specific aging, etc. And so if you can detect UV signature, that's very helpful. On the flip side, we talk about like sarcomas that have a dichotomy of fusion-driven with a quiet genome versus complex keratoid sarcomas, usually driven by high chromosomal instability. But in this case, the genomic complexity of complex keratoid sarcomas is not high TMB. They usually have low TMB, but the genomic complexity really stems from copy number and structural variation. And so this paper from Memorial Sloan Kettering, they look at the sequencing of many soft tissue bone sarcomas. You can see on the right is this copy number arm level changes from chromosome 1 to 22. And then there's like all this like up and down amplification, copy number gains and copy number losses. Not just liposarcoma, UPS, it's like across many different sarcomas. And they also, it's marked by structural variants as well. But TMB in general is like all very low. Like you see all of the distribution of TMB, it's like way below like 5 mutation per megabase. But FGA, the fraction of genome that's altered, which that has copy number variation, is much lower, much higher and very variable. And so in this case, we actually detected BRF600E both by immuno and mutation testing and confirmed this is a melanoma that is undifferentiated and met from the scalp of this patient. And so probably the final case I'm going to be talking about. So we have, this is actually a very scary case. I really want to share this with you. It's a peritoneal mass in a middle-aged women with history of FIGO grade 1 endometrial carcinoma. And then we have this like undifferentiated round cell sarcoma looking or epithelial sarcoma looking thing in the peritoneum, like diffuse omental peritoneal deposits, completely negative for keratin, absolutely no epithelial or glandular differentiation to speak of whatsoever. So does this person, this poor patient, did they have a second primary, there's a sarcoma, and then they have this well differentiated fibro grade 1 endometrial carcinoma in the uterus that has been curated, and actually they have a hysterectomy as well. It turns out that the prior endometrial carcinoma is MMR deficient. And so we have a very easy tool in this case to see if they are clonally related. We did a MMR immunos, and it has the exact same loss of PMS2 and MLH1. Again, you can say, oh, maybe the sarcoma is like, has MMR, but I mean, what are the chances of two different, like these two different MMR deficient things that are clonally unrelated arising from the same patient? And when I saw this case and I said, this is a undifferentiated neomalignant epithelial neoplasm with MMR deficiency, but then it could be from the endometrial carcinoma. And when I reviewed the prior curettage, there's like a very, 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 very tiny focus that has this undifferentiated endometrial carcinoma component. The majority is just like this nice glandular differentiation. And so they refine the diagnosis as endometrial carcinoma with focal high-grade component consistent of dedifferentiated carcinoma. So really the take-home point is that not everything is a sarcoma, and you can use molecular surrogates, in this case MMR-IHC, to nail the diagnosis, because MMR deficiency is like very, very unusual in a primary sarcoma. So I think my time is up, so thank you so much for your attention.
Thank you very much, Josephine, for this very nice journey with highlighted case-based approach to difficult cases. I think in the interest of time, we can go on, or we can have, if there is any burning question in the room. If not, thank you again. Yes, yeah, Dr. Rosenberg.
Maybe not a question, but different interpretation. You showed the case of, I think, a young adult with a fatty tumor, superficial, with polysomy of a count of 25, and you said that is sarcoma. Or you said, that number of copy change is indicative of sarcoma. But I've never seen, and I don't know if anybody else has seen a tumor with that morphology metastasize. So I would say it's not a sarcoma, and it would be an example of at least a non-metastasizing, and I would view as benign but potentially locally recurring tumor that can have a high polysomal copy number for MDM2.
Yeah, that case was to illustrate that it was a case of GLI1 amplified tumor with co-amplification of MDM2.
All pure fat.
Oh, the all pure fat. Oh, I see. In that case, I favor the diagnosis of ALT because there is extension into the superficial musculature. So it was called an ALT, not a liposarcoma. So it's not malignant per se. But okay. The high polysomy, it extends to ALT as well. It's almost to as opposed to benign adipocytic tumors. Thank you.
Thank you very much, and thank you again. The next speaker is Professor Daniel Baumhoer from the University of Basel in Switzerland. And I think all we know him, for many, of course, interest bone soft tissue, but last and not least is methylation. So, Daniel, please.
Yeah, thank you very much, Abbas, and the organizers for having me. I'm very happy that I have the last word on methylation in this session. Just full disclosure. Although I don't disagree a lot with what has been said already, because I'm not advocating, I never advocated that this is something as a standalone solution for non-experts to just do methylation profiling and then everything becomes clear and it goes out of the hands of experts. Well, although I have just as a comment, on this neuropathology bashing, I think there is a reason why methylation profiling in neuropathology is so successful and convinced so many people. And although I think it's really bad if new residents do not learn morphology anymore or cannot be motivated for that, then it might be an option that the morphology and immunophenotyping and the conventional type produces more mistakes than the methylation profiling currently, just as some beginning remarks. Okay, so we all know that the distance between these blue books gets closer and closer, and as most of you heard, there was the first expert editor meeting of the 6th edition last Monday, so with a little bit of optimism, we might have a new, better version of the 6th classification by the end of the year. Currently, we are differentiating and distinguishing 117 soft tissue tumors for undifferentiated round cell tumors occurring both in bone and soft tissue, and 54 bone tumors. So only slightly more than in the last classification, but nevertheless, a huge amount of different entities, some of them exceedingly rare, some of them can be treated by watch and wait, and some are oncologic emergencies. So it's a quite a difficult task to take care of. Well, as I said already, morphology is still the cornerstone, and I don't doubt that. Although we shouldn't do it in isolation, we should consider everything that has been said. And this also applies for methylome profiling. It's just another ancillary test. It's just another layer of information that shouldn't be neglected or not used, because it can be useful. And just bear with me for this great animation. We're actually only looking for something that highlights the specific change that helps us to classify the lesion, not only on morphologic basis. Okay, so when it comes to methylome profiling, I will make this rather short. You know, there's this paper, I think it was 2018, where the guys from Heidelberg, neuropathologists from Heidelberg, first came up with a classifier for brain tumors, and then 3 years later they came up with a classifier for soft tissue and bone tumors, and it was still neuropathologists, right? Always keep that in mind. Well, a lot of us submitted cases, and I did as well, but nevertheless, this is a bone and soft tissue or sarcoma classifier made by neuropathologists. We should keep that in mind. Well, the technique itself is completely different than everything else we're doing. It's different than immunohistochemistry, of course. It's also different from classical sequencing or RNA sequencing or whatever. And we're not looking for a single mutation that is objectifiable. We're looking for patterns. And as you know, in the genome, there are about 30 million CpG sites. This is where a cytosine is followed by a guanine. And this cytosine can be either methylated or not. And this is somehow reminiscent of a binary system. So there's only two variables. It's only 0 and 1, and that's why it's also referred to as the bits of neoplasia. And as I always try to explain, just imagine there are 30 million of these light switches in the genome, right? And we don't know what these switches mean individually, at least not yet. Perhaps eventually we get a little bit closer to this picture. And now if they are showing this pattern, then it's fibrous dysplasia, right? That's how it works, right? And so that might sound a bit strange, but we are used to patterns, right? Because morphology is all about patterns. And probably, at least partially, I don't know to what extent actually, this kind of patterns underlies the morphology, probably. And so it's not a big surprise that there is a correlation to it. So it's a new diagnostic layer. It's a little bit more like morphology, less like sequencing. It's a molecular histology, if you want to put it that way. And that is very handy. You can always derive, you can always derive a copy number profile of these data. And this is quite useful, especially as long as we do not have any classifier that has a full coverage of all lesions that are in the blue book. So as long as we don't have this, we don't know how good it works. We just know how good it works for the entities where we have methylation classes that are included in the classifier. And that's why people are so disappointed in many ways, because they say, well, I sent it out for methylation, didn't come back with anything. It's completely useless. Well, that is because the entity that they submitted is not included in the classifier yet, right? And then sometimes it can be interesting to have a copy number profile. There is no clear cutoff. Just as Josephine pointed out, also not for the number of signals in a fish to say this is malignant, this is benign. But if you have a lesion that has a completely flat copy number profile, it's probably not a high-grade sarcoma. And if you have a rearranged copy number profile, it's probably not a benign lesion. Just an additional layer of information. And so in our platform that we have in Basel, which is called the EpiDip, which stands for Epigenetic Digital Pathology, we have now more than 25,000 cases included. These are, of course, not all from ourselves. It's also publicly available data. And we, if you submit a case, which I can only encourage you to do, it's completely free of charge. You get this UMAP plot. It's a dimension reduction plot, trying to downsize this huge amount of information on a two-dimensional plot. And then you can see that obviously these dots, if you make it a little bit larger, correlate to tumor subtypes. That's how it practically works. And of course, what you include for this comparison is important for your result. And that is something probably a little bit difficult to swallow for most of you, because if you're doing the analysis with a different set of tumors, or even if you're doing the same analysis twice, you get a different UMAP plot. But the clustering should remain the same. Okay, so just a few words about the literature, about the sarcoma classifier from Heidelberg that was published in 2021. Well, they have these 4 categories, and what is quite reassuring is the category 1. So they found in the vast majority of cases, they found for the individual entities described in WHO corresponding methylation classes, right? So it confirmed our classification. And in a few cases, they found for one entity more methylation classes, for example, in chondrosarcoma, also depending on IDH status. And what is also interesting, in some lesions, they found that lesions that we differentiate or distinguish in the WHO, they cluster in a single methylation class. For example, pleomorphic liposarcoma, high-grade myxofibrosarcoma, and UPS. So it might well be that this is just a morphologic spectrum of the same disease. I'm not saying that this is proof. It's just an argumentation in favor of that. So this is what they came up with in the first time, and in their publication. And it's a bit of cherry picking involved here. I don't argue against that, because all the outliers they just got rid of, right? Because it was too complicated to, they wanted a nice, neat classifier. So this is not the whole picture, but at least, well, it works in the cases that are included quite solidly. And there are these validation studies on the left-hand side from the British group, and on the right-hand side from the NIH. And, well, in the majority of cases, they confirmed that, that the well-known methylation classes can be detected using this classifier. What is quite interesting is that in the RNOH, or in the London paper, they claimed that the detection rate of MPNST was only 30%. And in the NIH group, they found 72% concordance in the MPNST using the same classifier. So this is, of course, a lesion that is a little bit difficult to define. It's difficult, more difficult than having a giant cell tumor with a histone mutation. And so this might also, of course, also affect the ground truth. So now, this is a very important slide. I show you here the number of entities in the current WHO classification. On the right-hand side, the number of entities that are yet included in the sarcoma classifier. And you can see for soft tissue, this is only 35%. And if you go further, for bone tumors and the undifferentiated round cell tumors, it's only 24%, adding up to a total of 31% coverage, if you want to put it that way. And now something very important. This has not changed since it was published. So this is a frozen thing. It is frozen because these are neuropathologists. No, they're not really so keen on perhaps they are, but at least there is not a big progress coming. It's still the same classifier with the same flaws and a coverage of 31%. So I think the picture is quite still blurry. And, well, I don't want to be too negative on this, but the Heidelberg classifier might not be available for free any longer soon because it's going to be commercialized. And this is really an ethical problem because they have included all the samples that you perhaps uploaded in their classifier. The data is not publicly available and it's going to get commercialized. So this is something very, very odd. And there was a classifier for carcinoma of unknown primary from Barcelona. They did the same thing. It's not available any longer at all because no one paid for it, and it's just dead, which is really a pity. Okay, so I'm going to show you some examples now. I hope I convinced you. At least you're not sleeping shortly before the lunch break. Okay, whoever saw talking me about this before, and the likelihood is quite high, is I always show this first case because it was the first case where methylation profiling helped me. It's from a 20-year-old female, got this lesion in the left mandible. And yeah, non-specific imaging, and this was the histology. Now, since I've shown the case like multiple times, and I know the answer to the conundrum, I can only say, well, if I would have been the better pathologist, I wouldn't have needed methylome profiling in the first place, but I wasn't. So we did some immunos, was more non-specific. We couldn't really know what it was, and we discussed might be an extrameningeal meningioma, should rather be curated thoroughly. And then it was a consult case, and what always happens is you don't get any feedback of what happens to these patients. But this patient came back 4 years later, and obviously it hasn't exploded, but it's still obviously progressing or has progressed. Looked the same on morphology, and perhaps all of you already recognized it, but I didn't. So the methylome profiling was in keeping with the synovial sarcoma in the mandible. I just didn't think about it. And we confirmed this also by FISH, and you see there's a very high calibration score of 0.99 from the Heidelberg classifier, a flat copy number profile, everything fits together. And this is me after I got the results back. It's not François Lelorin, although it looks very similar. But it was actually me. And now the patient is in follow-up. Well, it has been resected, obviously, and was in follow-up since, I think, more than 5 years, and hasn't recurred. But for synovial sarcoma, this is not a safe bet so far. Another example, well, I could show you a few of them. I'm just going to, because of time restrictions, show you the second one. It's from an 89-year-old female. She has a mediastinal and lung nodules. History of colorectal cancer 5 years ago. You see this huge tumor in the mediastinum. This is the histology, very monomorphic, epithelioid, no higher grade atypia. I didn't really know what to make out of this. I did a huge immunophenotyping. As you can see, everything was negative with the exception of INI1. And then it sent it out to methylome profiling, and it came back in keeping with sclerosing epithelioid fibrosarcoma. And then I did a MUC4 stain, it was positive. So if I would have included the MUC4 stain in the first place, it would have been much easier. And we did not find one of these EWS1 CREM fusions, but the typical fusion for the SEF type. And so, yeah, this was just something. You can always argue, you could have think about doing a MUC4 stain, wouldn't have needed, but it's also a proof of concept. Well, when I prepared the talk earlier, Judith Beauvais asked me, well, you have to show some pitfalls. And actually, it's not so easy to show pitfalls because in the majority of cases, it just doesn't come back with a result and said there is no clustering or it's a very low confidentiality score. So this is not something that you would say it's a pitfall. But I got a few cases, of course. This is one. It's from a 4-year-old girl. She had a tumor in the left fourth metatarsal. It's a giant cell-rich lesion. It looks like a solid ABC. Also, here's some blue bone even involved with that. Everything would be fine. But we did not find fish. We did not find a USP6 rearrangement in the fish, and the classifier came back with a match of high-grade osteosarcoma with a very high confidentiality score, which is obviously not true. And you see there are few copy number alterations, but it's rather a flat profile. So I don't know. Probably it is a solid ABC with a cryptic fusion. But why this clusters with osteosarcoma, I don't know. So it can happen, of course. We shouldn't stop thinking and just diagnose an osteosarcoma here. It's no doubt. So of course, we shouldn't do microscopy in isolation, and we should also not do methylome profiling in isolation. Some examples why copy number profiling can be helpful. I find it very helpful when it comes to recurring giant cell tumors of bone. This is an example. This was a 31-year-old female. It's a primary manifestation, but she underwent a denosumab therapy after biopsy, and you can see there's a lot of cellular atypia here, but there's no increased mitotic activity, so most probably a symplastic GCT, probably as a result of this anti-resorptive treatment. And the copy number profile was completely flat, and so we called this giant cell tumor of bone with reactive symplastic changes following anti-resorptive therapy. And another case, which was a recurrent GCT of the distal right radius, and you can see already in the right, I'm going to try this after all. You can see that there is some bone permeation here in this little aspect. Again, but it does not look as atypical as the first case. We did copy number profiling. It was rearranged, and we said, well, it's a recurrent giant cell tumor of bone with multiple chromosomal alterations in keeping with malignant transformation. So I think it can help you to differentiate good and evil. Sometimes, at least, it's another layer that you can use. Okay. So now I'm going to give you some examples of scientific and taxonomy-related projects. As you know, pathologists always try to sort things thoroughly. And one that has been mentioned a few times already is the adamantinoma-like Ewing sarcoma. This is another example, as was shown this morning already. And we did assemble a set of, I think, 14 or 15 of those tumors. And what we could nicely show is that you can see here is the Ewing sarcoma here. And this is the adamantinoma-like Ewing sarcoma. So from an epigenetic point of view, they are distinct. Does that mean that they are carcinomas? No, it doesn't. It just means that they're not conventional. Well, at least it suggests or indicates that it's not a frankly only a morphologic variant of Ewing sarcoma. And interestingly enough, there was one case where we did not have the fusion confirmation, and this clustered very nicely with conventional squamous cell carcinoma. So it's also a technique where you can sort things out or can find outliers, which here in this project was nicely possible. Another thing that we were talking a lot, and we will hear also from Karen Fritchie about that, is about these long nodules in patients with known melanoma. And in the study, I won't go much into detail now, that we published recently, we could nicely sort them out and found the methylome signature of melanoma, with the exception of 2 cases that showed losses of H3K27ME3. And these are the ones that also Abbas in his work found as MPNST-like, because this messes the methylome up very much and leads to, if you want to say it like this, to a misclassification because it's not clustering with melanoma anymore. But if you know that, then you can also keep that in mind and might consider that. Another example is the cytokeratin positive or xanthogranulomatous epithelial tumors that have this HMGA2 fusion, as you all know how they look like. And in this case, we were also nicely able to illustrate that they cluster separately, although they form 2 clusters. And we're still thinking about why this is the case. Purely on morphological correlation, we were not able to clearly say, well, this are the XJETs and these are the KPGCTs. So what I can tell you, it won't be as easy as for brain tumors, right? So there will be lesions that have different methylation classes. But if you have a good map with reliable ground truth data, you can nevertheless find convincing evidence also on this, even if they have different methylation classes. Another tumor that was recently been described by Andrew Fulp and also by Carina Dehner are the neurocystic tumors, cutaneous tumors with fat ETS fusions with a very with a subcutaneous site and a rather indolent course, and also those cluster very nicely separate from Ewing sarcoma, which I don't see right now, but it's definitely on this list here. Anyways, it's definitely very distinct from it. And the last lesion I want to mention, it was a very recent paper, is about odontogenic myxoma. This has been bothering me for a long time because we just couldn't find anything in those tumors using RNA or DNA sequencing. They are locally aggressive. They can be easily confused with local structures of hyperplastic follicles of the developing tooth. Sometimes you wish that you have something to confirm it. And we assembled a nice set, and we could again show that they cluster very distinct on methylome profiling. What is even more interesting is that they show very distinct copy number profiles. Unfortunately, we messed up the interpretation and thought that there were amplifications here in these chromosomes. But since we were dealing with relative copy number data, David Papke kindly contacted us and said, guys, I think you messed this up. It's probably not amplifications, but these ones that you thought were amplifications are the baseline, and the rest of the material is actually deleted. So we were very happy that he informed us, and we were just writing together a short note in the American Journal of Surgical Pathology about that. But nevertheless, it has these haplotyping, which also is characteristic, for example, for the inflammatory rhabdomyoblastic tumors, and so we found a recurrent methylation pattern and also a recurrent copy number profile, which is quite interesting. Okay, for now, this should be it about that. Some new developments, which I really find very interesting. And this is the ultra-rapid methylome profiling in less than 4 hours, which the neuropathologists in our department do on a regular basis. And using these nanopore sequencing chambers from Oxford Nanopore. They are hardly as big as a pack of cigarettes, and you can, that was not it, perhaps here, no, you can probably not see, but there, where the arrow is there, you can pipette the extracted DNA into it. You just plug it with a USB connection to your computer, and the sequencing can begin. It's a direct sequencing, so there is no amplification step involved, and you just let it sequence, and after 3 or 4 hours, you have enough reads to do a methylome profiling. This has been showcased also in this New England Journal of Medicine publication, where they put these chambers in parallel, had a lot of computational power, and did whole genome sequencing in less than 8 hours. Right? So this is a very powerful technique, and since these chambers are called minion chambers, we labeled them accordingly in our lab, and you can see by comparison of the size of this pen, they are really very small, and they are active in our lab every day. So how can this help in a sarcoma diagnosis? Well, I can show you just only 2 recent examples. This is from a 16-year-old boy, tumor in the right scapula. It was radiologically also already highly suspected for Ewing sarcoma. This is a fresh frozen slide, was in keeping with that, but we nevertheless, just to showcase it, did a methylome profiling in 3 hours, and it came back as 100% matched with Ewing sarcoma, right? This is another example where the suspected diagnosis radiologically was osteosarcoma. And this is also well in line with that, but although you could at least consider that this might be also a hint of a mesenchymal chondrosarcoma, we did this ultra-rapid test, and it came back as osteosarcoma 100%. So this is just something, you get the diagnosis in 3 or 4 hours, right? And of course, this is experimental and it has to be confirmed by conventional techniques. But if this is something that is really coming into reality, this could really make a difference. A lot of people here sitting in this room are highly educated experts in the field. They probably don't need that as urgently as other people might need it. But if you just imagine you start doing some immunos, they don't fit together, then you make 2 or 3 fishes, then you make an RNA sequencing, and easily 4, 5, 6 weeks can pass until the treating doctors can start with the treatment. And this at least could offer, I'm just saying it's really purely scientific currently, a real quick way to make this, to overcome this hurdle. So, the outlook. As I told you, there are 30 million CpG sites in the genome. These are the arrays we currently use. So the 935K arrays are the current ones from Illumina. They cover 3% of the CpG sites. And our classifier, the UMAP classifier, uses 25 to 75K, and the Heidelberg classifier uses only 10K. So I think the blurry picture over time could get better by, great, isn't it? Yeah. So you're still bearing with me, by increasing the resolution of the arrays. And just to remind you again, this is the WHO soft tissue classification. These are the entities depicted in the HD SAR classifier, and this is our platform. And we currently went up to 60 of 117 cases. So we're increasing the coverage. That's our goal. We absolutely share everything with everybody who is interested. I don't think that we should have the only platform. I think it would be really good to work internationally together to fill the gaps, and then to share the data so everybody's looking at the same thing. And if we get a coverage close to 100%, then we can evaluate how efficient this works, or maybe not. Same thing for bone, and this is the coverage in total. So currently we have 51% coverage. So the only thing I can say, upload the cases not own any longer to Heidelberg. Well, eventually it will cost money anyway, so no one will do it anymore. But you can use our system, the EpiDip platform, epidip.org. It's free of cost. You don't have to identify your sample, so we can't do anything with it without a collaboration set up. But if you want to do methylome profiling, you have a much higher coverage if you use our system than the Heidelberg classifier. This was put in a nice light. So as I said, this is an international effort, and I apologize already for all the collaborators I missed to include in this slide, but I'm really very happy. It's been an amazing 2 or 3 years where we made this amazing progress by this international collaborative effort, and I'm quite confident that the best is yet to come. Which is not only the lunch, but also. Thank you very much.
Okay. So thank you very much, Daniel. And believe me, I am on your side, not against. I see Peter.
Can you hear me? Whoa.
Louder than ever.
So I guess I have 2 questions. How many cases do you need? How many cases do you need for positive control? So you know that you have a reliable cluster to compare to unknown cases.
Usually 10 to 15 cases.
The second question I have, like with the Heidelberg classification, or I'm sure yours is correct, but the problem is who's making the diagnosis and how do you know how accurate they are? Should there be, if you're creating a international methylome classification, should there be like several people looking at the slides and agree on the diagnosis before you do the methylation analysis? You know what I'm getting at.
The quick answer is yes.
Okay. So if you have the wrong diagnosis,
sure,
you're going to have the wrong results.
Yeah, you're absolutely right. No, it's very important. Of course, in many of those lesions that we added, we had molecular confirmation, also and it was from bone and soft tissue experts. But you're absolutely right. I think it's very crucial, and we don't know what in the Heidelberg classifier, what is underneath the Heidelberg classifier. We don't know that, except for the case that I submitted.
Yes, Dr. Rosenberg.
You didn't say anything about the methylation profile of normal cell types. Have you compared that to benign malignant neoplasms with a similar phenotype?
Not systematically, but we in the EPD platform are indeed methylome profiles of normal tissues included. But it's not that, you know, what you can say in this in these humor plots is if something belongs together or not. But the distance between the clusters does not indicate that they are connected, right? So you can't say, well, this is close to Ewing, so it might be very, very similar to Ewing. And so this is why we couldn't show so far that, for example, skeletal muscle clusters very close to rhabdomyosarcoma. That's not how it is.
Okay.
Question for you, or just a short point to mention. I think the problem starts with the tissue or tumor highlight for DNA isolation, because sometimes when we have a lot of reactive normal cells in the background, we know that examples in the study by Dr. Meetin and some tenosynovial will come back as Langerhans cell histiocytosis. I have seen a few cases sent to me for third opinion after the glioma came back as IMT, because yes, it has a very prominent lymphoid reaction. So there is a need either to be very careful with highlighting, if possible, of course. It is not always possible. If it is intermingling, it's very difficult. Or if there is any way to use a software that will subtract these immune expression features, that would be more refinement.
That's absolutely true. This is a known flaw that everything comes back as IMT or Langerhans cell histiocytosis when you have a mixture of cells. For example, a tumor like Hodgkin lymphoma would be very difficult to investigate because you have so few lesional cells. There are approaches, but they are also purely scientific yet, that you try to, with a special software, that you try to do selective sequencing with nanopore. So that if a fragment is torn into the pore and the system recognizes this must be from a normal cell, then the sequencing is stopped. But since this is a very, very rapid moving thing, it's not there yet. But that is what people try to exactly address this problem. Selective sequencing.
Finally, I'd like to come back to the point by Dr. Peter about medico-legal issues. Someone unexperienced, like some people now doing with this, AI. So yes, they upload to the platform. They will get back, like in your pitfall case, a diagnosis of high-grade conventional osteosarcoma. They just send it out as a definitive diagnosis. The child is overtreated or even killed by the therapy. And then it came out after that for any reason, after revision or review, this is indeed a benign lesion and not an osteosarcoma. In such a scenario, where is the responsibility, or is there any intention to try to protect this?
Well, you know, this holds true for every other test as well. Right? If you misinterpret the immunophenotyping or the fusion testing and make a wrong decision derived from that, there's no way to exclude this with certainty. But I fully agree, as long as we're in this state we're currently in, this shouldn't be done without an expert review of the case.
There any type of FDA approval, for example? I don't know how these things do.
I don't know how it's with the brain tumor classifiers. I don't know, but it's done in the U.S. So and they building up. Well, because of the hurdles with Heidelberg, the NIH is very strong. It's very well, at least before Trump was elected, was very strong in building up their own platform.
Okay. Okay. Thank you very much. Thank you for the discussion and the nice talk. And I will give up to the.
Okay, so we have a lunch now, and we meet here at 1:45, please. Thank you. So good afternoon, ladies and gentlemen. Welcome back after lunch. Please have a seat. In the next session after lunch, we have 4 talks. The moderators are Dr. Carina Dehner and Dr. Cristina Antonescu, and they'll take it over from there. Thank you.
The first speaker will be Isidro Machado from Valencia, Spain. He's going to talk about round cell tumors.
Okay, thank you very much for the invitation and for this wonderful meeting, Michael. So this is my presentation. So maybe it's a little overlap with tomorrow Cristina presentation, but I try to skip it if there is something that is a repetition. So first of all, I have no conflict of interest to declare, and this is my summary for the presentation. And this is my first diapo that I could say that really there is a provisional molecular entity whose clinical pathological features are in the early stages of evolution. Unfortunately, we are facing undifferentiated tumors that do not fit within the Hugh entities. For instance, for Ewing sarcoma, in the WHO there is an essential criteria, a small round cell morphology with CD99 membranous expression, but we know that there are many other tumors with these criteria, and this is a desirable fit ATS gene fusion that we really know now. There is another completely different entities that may have this translocation. Primarily for the young oncologists, that is a message for the young oncologists that extensive molecular profiling of sarcoma, while valuable, is not the only way to improve patient outcome. Maybe one of the most important ways to improve the patient outcome is the real multidisciplinary team communication and the integration of the radiology, pathology, molecular biology. You know that sometimes the radiology try to make a direct soft tissue diagnosis, and that is really tricky for us. Sometimes we have to be aware of presence of mimickers. I think that is very important, the effective communication that sometimes, I could say not really infrequent, is not as easy as it appears to be. So as you know here, we have 4 different tumors that look like some type similar. Maybe the first tumor, as you may see here, also, okay. As you see, I mean, he's some discohesive. There is more trabecular, some collagen formation, some rhabdoid morphology. And here more next vascular in the background. This is round cell tumor that without desmoplastic stroma, and now more collagen in the background. And now there is typical small nucleoli. However, there are completely different tumors, and when we see this is a gene fusion for all of these tumors that may look like similar morphology. So first, for the Ewing sarcoma, I could not say no more about Ewing sarcoma because there is not really very frequent news in this type of tumor. As I will highlight in the rare morphology, maybe this is the alveolar pattern and an atypical pattern, but I would like to highlight the usually biphasic population in Ewing sarcoma, and that's this cohesive pattern, so the light and dark pattern that is very frequent in Ewing sarcoma, and we have to be aware of this. Regarding immunohistochemistry, you know that CD99 is stronger and diffuse in many of the cases, but in case where CD99 is poor positive due to decalcification artifacts, we can use this antibody that work fine because they are nuclear, so NK2.2 and PAX7 that are also positive in Ewing sarcoma. And for fish that we may have missed some case with air translocation when we perform only fish in Ewing sarcoma. So I would like to highlight that the visceral Ewing sarcoma could be a problem. For instance, this is a gastric tumor in the patient that looks like yeast at the beginning of this radiological inform, like probably yeast. And when we saw the morphology was very discohesive. And usually we perform c-kit and cytokeratin when we are dealing with gastric tumor with round or epithelial morphology. The c-kit was strong and diffuse, so we're thinking about epithelioids, but this cohesive morphology is not fit with epithelioids, and cytokeratin was positive. However, the CD99 was positive, and the air was also positive with an air translocation and a wild-type key and PDA-FR. So we have to be careful with the c-kit expression in the gastric Ewing sarcoma because it's a tricky differential diagnosis. That is the same in a kidney tumor. That is a young patient with a kidney tumor that a morphology, despite they have some areas with the rosette, and there is a pseudoalveolar pattern also. The morphology could help to perform the diagnosis of Ewing sarcoma. But, however, in this case, at first glance, we perform cyclin D1 because in renal tumor, clear cell sarcoma is one possibility, and this case displays a strong diffuse cyclin D1 morphology. The WT1 was negative, and the cytokeratin was negative, and also the tumor revealed CD99 strong and diffuse positivity with air. And despite ERVs, strong and diffuse positive, the tumor turned out to be AWS translocation, so it's not always there. Maybe in Ewing sarcoma, the most problematic concern at present is that should they be considered distinct entities or histological streams of the same disease? I mean, between Ewing sarcoma, the melanoma-like Ewing sarcoma, and superficial neurocystic tumor recently described by the group of Carina Dehner. And as previously Daniel has explaining, there is two interesting articles by Fritchie and by Dehner that separate adamantinoma-like Ewing sarcoma from neurocystic, and curiously, that this neurocystic tumor also close to neurofibroma. So that is interesting because neurofibroma also spread as under at short stems. That is interesting, at least to me. So when I saw this article, I was wondering, I was a little bit scary because we have published some cases some years ago of a superficial Ewing sarcoma, and I wonder, it's obvious that need to be excluded a superficial FET ATS neurocystic tumor in this case. But when we review this case, all these cases were as under as sub-10 negative, but I really think that maybe it would be interesting to explore in the other series of Terrier Lacombe for the French group to discover that any of these tumors could be included in this new subtype of Ewing sarcoma. And recently we have received a patient with a foot tumor, a 60 years old tumor, with a morphology that at the first glance reminds round cell tumor, and with a biphasic, this light and dark morphology, some myoepithelial pattern in some way. So you may see here high power fields, and the tumor really looks like could be during sarcoma, but there is no mitosis, no necrosis, so we performed the immunohistochemical profile. The tumor was CD99 strong and positive, and the cytokeratin was also very positive, and the p63 was also extensive positive. The FISH was positive, so we may ask, this is a real superficial adamantinoma during light. This is a myoepithelial tumor or a neurocystic. So we performed the NGS, and the NGS turned out as an Ewing flight. We think that it would be interesting to make a methylation profile, and that we are already sent to Daniel to perform that. This is ongoing, because probably this tumor could be fit with superficial adamantinoma like during sarcoma, but how should this patient be treated, like during protocol with conservative treatment or a wait and see? So maybe this methylation profile could help us to convey this information to oncology in order to planning the treatment of the patient. So this is the other tumors included in that already Cristina have spoken tomorrow, and only a few things about this MFAX tumor. This is a really interesting, the positivity for NCase 3.2 and agregan. This was described by the French, but I think that when we are dealing with a tumor with round cell morphology and this cordonal or myoepithelial-like tumor, and we have AWS amplification and positive for NCase 3.2, it's rare that it could be another tumor different to MFAX2 tumor with amplification. However, this tumor may have any other pattern that could remind prostatic carcinoma, remind recurrent sarcoma, or undifferentiated sarcoma. So, but the immunohistochemical is help. You know, you see here the CD99, and this positivity, and also the amplification. And this is a courtesy for Dr. Yoshida. When I was in Tokyo, he performed this proof with MFAT, and you can see in this diapositive, so the gene fusion with the amplification of the AWS. So the other subtype of tumor that not recently, but emerging or a provisional entity, so provisional already established in the WHO, is the area impacts tumor. I would not say no more about this tumor because I guess that Carina will talking some about this tumor. But important in this tumor is when we see a combination, a round void and a spindle cell, we always have to think about this tumor combining with a perivascular collagenization and a polyphenotypic, so neural and myogenic expression. And this is important because there is a subset that tumor that may be clinically indolent. That is a tumor that we, at the beginning, thought that it will be evolved in a malignant way or in an aggressive way. And recently, paper has described that this tumor evolved quite different in some patients. So this is another histological picture of this tumor, usually located in the thoracic abdominal location, and that's specific, the perivascular collagenization of the tumor and the combination of round, spindle, and ovoid morphology. And the immunoprofile you may see here is very complex, and of course you may have mixed this translocation because it's intrachromosomal inversion by the fish, and this is difficult in some way to detect. And that is what I'm saying, that at the beginning this tumor was thinking that was aggressive tumor. However, in the last report, many of these tumors were evolved in a not very aggressive. And this is a photo of Valencia. This is a plantation, the rice plantation of Valencia, and this is a Valencia Sea. I'm sorry, but I forgot my phone in the room, and I cannot check that already. The Mediterranean Sea is continue to call Mediterranean Sea. I hope that this continue to be a Mediterranean Sea, Valencia. So, but regarding to 6 rearranged sarcoma, sarcoma with record translocation, so already Cristina has explained in this speaking. Interest in the ETB4 and DUX4, and recently also Dr. Yoshida has reported the MUT5AC positivity in isolated cells in 6-dog sarcoma that may help in the differential diagnosis of this tumor. And that is a tumor that we were dealing some years ago. It's a 6-dog tumor in a gluteal area. You may see here the cytology with a rhabdoid morphology. This is a peritheliomatous pattern with a discohesive pattern, but more pleomorphic than Ewing sarcoma. And that is interesting because this case was a sheet duct, and however displayed strong and diffuse CD99 expression with a Golgian positivity. So also cytokeratin and ATV4, and was demonstrated by molecular there was a sheet duct sarcoma. And it was also demonstrated by the aggressive evolution of the patient that 4 months later developed lymph node metastasis. And that is the other pattern that this tumor may reveal. You may see here that the tumor may reveal clear cell pattern. Clear cell pattern, maybe say it has a rhabdoid pattern, and a chondromyxoid background that may raise another concern with other tumors. Also a spindle cell pattern of this tumor may reveal, and also here the myxoid background. But that is interesting that also this tumor may reveal a chondroid differentiation, a chondral metaplasia that could provide differential diagnosis with mesenchymal chondrosarcoma or with other tumor with chondroid metaplasia. So this is to be aware in relating to the histological diagnosis of 6-dux sarcoma. Record altered sarcoma, so this was already described. It's more frequent in bone comparing with soft tissue. And that is important that the prognosis is similar to Ewing sarcoma. So despite we have to make a lot of effort to separate this entity, still the oncologists continue to treat patients with a similar protocol, despite they know that some tumor, like sheet duct, doesn't respond very well to this therapy. So you may see here that is interesting case because you may see how the tumor in soft tissue looks like this with these angulate tumor cells and the background with next word, and this is a bone tumor infiltration due to the calcification, so you may see the completely different morphology and the histological appearances. And as Cristina mentioned, the tumor usually reveal because strong and diffuse, and if the pattern is the same with 3, it's always helpful. And of course, the FISH and molecular analysis confirm this type of tumor. And my last part of the presentation, I would like to present one emergent or provisional, or I don't know how to call this entity. And what I present this case, this is a case of poorly differentiated synovial sarcoma that you may see in the picture that remind some Ewing sarcoma, despite there is a collagenous fibrous stroma that is unusually in Ewing sarcoma. This case was very positive for the immunohistochemistry for SS18, SS8. So also, synovial sarcoma may reveal epithelioid morphology that in some way is difficult to make a differential diagnosis between this and myoepithelial tumor, but when we perform the immunohistochemistry, we can really confirm or make a confirmation if you have a positivity for both antibodies. But recently have been described this new I don't know how to call, new type of tumor with specific AWS SSS translocation, first with SS1, second with SS3, 2, and third, the Caterina Fumagalli and Dr. Cristina has been published this case. And when I was reading this paper, I think could we eventually detect this tumor with the SSX antibody? Because it's supposed to be positive in this tumor if they have a translocation. Caterina Fumagalli was kindly sent to me the unstained slide to make the immunohistochemical profile. And you may see here the histopathology of the primary tumor. That looks like to any undifferentiated tumor with round spindle, a combinating morphology between gene or synovial sarcoma, maybe more closer to synovial sarcoma. And when we performed this antibody in Valencia, that was really interesting because the tumor in primary tumor was strongly and diffuse positive of SSX. So this could be fixed with this tumor. The gene, the fusion, the protein fusion was negative, and curiously, some of the antibody that can be positive in synovial sarcoma, as this antibody, so TRPSE1 that was first to describe it in breast carcinoma, and this is also present in synovial sarcoma, and also BCOR was a strong diffuse and positive, and we haven't saw the IN1 reduction that you know that also in synovial sarcoma is frequent as described by Yoshida, that is sweeping the smart CB1, and you may see reduction of INA1. So this is a metastasis of this tumor, a long metastasis, and this was the same result. This is a SSS antibody, a strong and diffuse positivity, and the same result of the primary tumor. So what is my conclusion of my presentation? Well, we think that the molecular testing really plays a crucial role in accurate diagnosis on differentiated round ovoid sarcoma, but particularly where overlapping morphology and immunophenotype. It's true that morphologic assessment and clinical correlation continue to refine our understanding compared to initial description of provisional entity, I mean as Ewing-Pax tumor, that we initially think that evolved in a different way than now. It's also really true that there are many gene fusions have been identified. However, most reports remain isolated case studies rather than the case series. So how should we combine all this information to clinicians? But they are continuously asking us, how should we treat this patient with this new gene fusion? And how should this patient be treated? So this is a tricky question that when oncology asks me, I don't know sometimes how to say. So, and the other that may be retrieving comprehensive case series of this new gene fusion will enhance our understanding of tumor behavior and therapeutic approach, and we provide more important information to oncology on how to treat this new entity. Of course, I cannot cover all the new small round cell tumor, and I'm pretty sure that this entity will probably cover in the next presentation, including the smart CI4 deficient primary bone sarcoma that I wasn't aware that there exists. Of course, there is still more to see, and I would like to thank to all my colleagues for my Instituto Valenciano Oncologic, so that's the place where I'm working on. Pathology Department of Hospital Clinic of Valencia with Professor John Bosch, also the Department of Pathology, Hospital Quirón Salud, and also the international collaboration that we have made with Dr. Yoshida, Dr. Parafioriti, Dr. Catarina from Barcelona. And I would like also to mention to Impera's project that this is a project that we have in Spain for a central review of all new sarcomas in Spain, and we in a monthly basis we make an international session. We were speaking the many experts in sarcoma to share the way to approach not only a small round cell tumor but other sarcoma in general. So thank you for your attention. If you have any question, I'm more than happy to reply.
Are there any questions? Okay, well then I will be delighted to introduce our next speaker who really needs no introduction. Dr. Cristina Antonescu from Memorial Sloan Kettering will be talking to us about an update on vascular neoplasms of bone and soft tissue.
Okay, so for today's talk, I'm going to focus only on a selected number of vascular entities that were included in the 2020 WHO classification. But before I start, I would like to provide a checklist of morphologic features on how to approach vascular tumors. And you will see that for each entity I'm going to discuss, I will try to cover if the tumors have a lobular versus infiltrative growth, if there is hemorrhagic background, if there is vasoformation or not, and if there is high nuclear pleomorphism. Yeah, so we'll start with the benign entities, epitheliohemangioma, which is a benign vasoformative tumor composed of epithelioid endothelial cells. You probably are aware that this entity was long controversial, was thought to represent a malignancy by some experts, and that is the reason being that has a wide morphologic spectrum, including atypical features, as you will see. Clinically, these occur in young patients and with a wide. It's too close. With a wide anatomic distribution, but mostly involving soft tissues and bone. Okay, so like most hemangiomas, epitheliohemangioma at low power has a distinctive lobular growth pattern, as you can appreciate in this low power. And another important features are I'm turning this way, so maybe I shouldn't be turning. Yeah. Okay, sorry. So the next important feature here, if the tumor has vasoformative features, and you can appreciate here the well-formed mature blood vessels, which are typically seen at low power of these tumors. And the vascular channels are lined by these epithelioid endothelial cells with pale eosinophilic cytoplasm and variable number of intracytoplasmic vacuoles or blister cells. Another important feature for epitheliohemangioma are these dilated vascular spaces lined by epithelioid cells with abundant pink cytoplasm, and you can appreciate the hobnailing and the nuclear projection in the lumen taking the appearance of a tombstone appearance. Most epitheliohemangiomas have a hemorrhagic background, as you can see here, and they may have variable or no eosinophilic infiltrate. As mentioned before, a subset of these tumors have atypical histologic features, and this is one example showing mostly solid growth pattern, increased cellularity, nuclear enlargement with mild and moderate nuclear pleomorphism, scattered mitotic figures, and as I will show you in the next cases, they may even have punctate necrosis. But what's missing here is the marked nuclear pleomorphism and atypical mitosis. Another reason for this long controversy has been its aggressive radiographic appearance, including bone destruction, multifocality, soft tissue extension as illustrated here in these images. And another feature that is usually not very well recognized is the presence of spindling. So it's not that uncommon for bone epitheliohemangioma, especially the ones that have abundant hemorrhagic stroma, to show areas of spindling, and you can see in this rib lesion side by side with areas that are more epithelioid and vasoformative. The genetics of epithelial hemangiomas have been described, and they include FOS and FOSB fusion, however, only in half of the cases. FOS gene rearrangement are a little bit more common, and they are typically involving LMNA and vimentin gene partners, and this fusion results in a truncation of the FOS protein. And this particular fusion occurs in 60% of bone lesions. In contrast, the ZFP36 FOSB fusions are more often associated with atypical histology, increased cellularity, and even focal necrosis. So let's look at some examples with molecular confirmation. So this is a foot lesion in a 56-year-old female with a FOS vimentin positive fusion. And you can appreciate here the dramatic radiology and gross appearance with destruction of metatarsal, phalangeal bones, multifocality extension into soft tissue. This required a Chopard amputation. Microscopically at low power, again, very important, the lobular architecture. Once you go at high power, this tumor shows worrisome features, including solid growth, epithelioid, as well as spindling. This is another example with the same fusion, but this time this is a solitary cuboid mass. And you can appreciate, again, very solid back-to-back growth of epithelioid to ovoid cells. Tumors with FOSB fusions show a quite wide morphologic spectrum. Some of the cases on your upper left look quite benign and classic, while the remaining have quite atypical features, including solid growth and nuclear pleomorphism and even necrosis. This fusion also is quite common in penile epithelioid hemangiomas. If one reviews the old literature, most of these cases were overcalled as either angiosarcomas or epithelioid hemangioendotheliomas. Again, you can appreciate these large cells with enlarged nuclei and proeminent nucleoli, glassy eosinophilic cytoplasm, and mild to moderate nuclear pleomorphism. So very worrisome histologic features. The same kind of worrisome features in the soft tissue. You can appreciate here solid growth as well as some tombstone appearance. And there is, again, mild to moderate nuclear pleomorphism and nuclear enlargement. Just to briefly mention here the angio-lymphoid hyperplasia with eosinophilia, since this was thought to be synonymous with epithelial hemangioma. However, more recently, data has shown that this is more likely a reactive rather than neoplastic process. And morphologically, these lesions look quite different than epithelial hemangioma, and they occur mostly in the skin of head and neck, where epithelial hemangioma is not occurs uncommonly. And these lesions occur in association with a medium-sized blood vessel, as you can see here, and showing the fibrointimal hyperplasia and destructive mural damage. And in addition to the abundant eosinophilic infiltrate, these lesions show lymphoid aggregates, a feature that is not seen in an epithelioid hemangioma. A different example, again, the muscular wall of a vessel with mural damage and lymphoid aggregates. So moving on to the next entity, the vascular neoplasm with NFAT-C1 and NFAT-C2 gene alterations. In the initial reports, this was thought to represent a benign or plain hemangioma or vascular malformation. These lesions may show, in fact, aggressive radiographic features. You can appreciate here with the cortical breakthrough in the soft tissue, extension in the soft tissue. And in a larger study that was done by Nushin Dashti here, including 14 cases, it became obvious that this represents a novel group of unusual vascular tumors. They showed solid as well as vasoformative features, mostly epithelioid morphology and hobnailing. And another important feature was that it has so many architectural patterns, including retiform, hemangioma-like, even hemangioendothelioma pattern that may be reminiscent of a composite hemangioendothelioma. However, these lesions, in addition, may show areas of atypia and worrisome histologic features, solid growth, nuclear pleomorphism. And in the study that Nushin ran of 14 cases, there was an even distribution between NFATC1 and NFATC2. And most of the fusions involved the EWS partner. So these are unusual cases. The entity is still emerging. I don't think it's going to make it as a separate entity in the new WHO. So my recommendation is to do molecular analysis in something that may look like composite hemangioendothelioma but has an additional epithelioid morphology and confirm the diagnosis of an NFATC1 and NFATC2 vascular lesion. So far, all our cases behaved in a benign fashion. However, there is a case report in which this tumor metastasized. Moving on to the next category, the intermediate or rarely metastasizing vascular tumor. And here, of course, the main member is the pseudomyogenic hemangioendothelioma. For younger people here that don't know the pathology history, this entity was first described by Dr. Billings and Wise under the name epithelioid sarcoma-like hemangioendothelioma. And from these pictures, you can appreciate right away why, because it truly looks like an epithelioid sarcoma. These epithelioid cells with glassy eosinophilic cytoplasm. These tumors occur in young adults as multiple nodules. They stain with vascular markers. And this entity was further, the morphology of this entity was further expanded by Dr. Hornick and Fletcher a few years later and redesignated as pseudomyogenic hemangioendothelioma. They show that most of these lesions have a predominantly spindly and strikingly myogenic or rhabdomyoblast-like look, with these cells with bright eosinophilic cytoplasm that may mimic a myogenic or skeletal muscle neoplasm. The clinical presentation in their series was the same as Dr. Wise, young males or young patients with multifocal presentation, and their immunos included vascular as well as cytokeratin positivity. This is a good example from our institution showing the typical clinical presentation, multiple lesions within different planes, usually affecting one local regional area, in this case lower limb. And you can appreciate in the skin that there is a diffuse growth pattern, there is no lobularity. The cells in this case are predominantly epithelioid with glassy eosinophilic cytoplasm, and of course staining for vascular markers. The genetics of this pseudomyogenic hemangioendothelioma have been described. Half of them have SERPINE1 FOSB fusion, and the other half have an actin B fusion. And there are some correlates with morphology between these fusion types. This is from our series showing that the actin B FOSB fusion show more often a spindle or myogenic or pseudomyogenic morphology. Of note that cytokeratin can be diffusely and strongly positive, and we've seen cases that were misdiagnosed as metastatic sarcomatoid carcinoma of uncertain origin. So the idea is, especially in younger individuals, you have to include vascular markers, and if the morphology is rather monotonous, to include molecular analysis. These are a few examples with the SERPINE1 FOSB fusion that shows mostly an epithelioid morphology. And now moving on to two other members from this intermediate category, the retiform and composite hemangioendotheliomas. In a recent study, together with Dr. Fletcher, we showed that about a third of both retiform and composite hemangioendothelioma share YAP1 and MAMEL2 gene rearrangements, suggesting that this may represent a morphologic spectrum or morphologic continuum between these two entities. These are a few examples of retiform hemangioendothelioma with YAP1 rearrangements, and you can appreciate these elongated, stretched, and somewhat branching vessels reminiscent of retitestis. They are associated with a very dense hyalinized, collagenized stroma. There is no lobular architecture. These tumors diffusely involve the dermis, and you can appreciate in the upper left, they also infiltrates within adipose tissue, and that's the main reason that these lesions are associated with high local recurrence. The endothelial cells that line these vessels are small in size. They are the nuclear pycnotic and somewhat hobnailing. These are a few examples of composite hemangioendotheliomas with YAP1 MAMEL2 that have, in addition to the retiform, have additional growth pattern, as you can see here. I want to briefly mention another subset of composite hemangioendotheliomas that are associated with an more aggressive clinical behavior, including lymph node as well as visceral metastases. I would urge you to try to make a correct diagnosis and distinguish them from a high-grade angiosarcoma, because although they are aggressive, they are still long-term. They have a much better outcome than a high-grade angiosarcoma. The morphology is like composite hemangiothelioma, different patterns. Maybe this one shows more hemorrhagic, angiosarcoma-like. However, the morphology, as you can see, is composed of these monomorphic endothelial cells, something that we usually don't see in angiosarcoma, where there is overt nuclear pleomorphism. Of course, these tumors have neuroendocrine differentiation, and you can have usually patchy, not diffuse synaptophysin or chromogranin staining. In our experience, this tumor remains a mixed bag of entities or mixed bag of, I don't know, molecular subtypes. Only about 50%, half of the cases, we will be able to detect a gene fusion. The most common are listed here on the left, still involving YAP1 and MAMEL2. So still there is work to be done in this category to identify the remaining, genetic abnormalities and the remaining cases. Okay, so moving to malignant category, and we'll start with epithelioid hemangioendothelioma, which is an angiocentric malignant vascular tumor that occurs in young individuals, both in soft tissue as well as viscera. Typically multifocal. Just to highlight the angiocentric propensity of these tumors, I'm showing you this case that has intravascular growth in the innominate vein. You can see the vessel is completely obliterated, and the tumor extends into surrounding mediastinal soft tissue and thymus. Let's dissect a little bit the morphologic features of EHE. First, it doesn't have a lobular architecture, has a diffuse growth pattern, and the architectural pattern are quite heterogeneous, including single files, cords, solid sheets, nested. Another important feature is that we don't see vasoformation, we don't see mature vascular channel formation in this tumor. So again, very important, as well as the lack or very limited hemorrhagic stroma. So right away, very distinctive features from epithelioid hemangioma. Despite the fact that this lesion lacks hemorrhagic stroma, it has a lot of extracellular matrix, which may be a key diagnostic features that may appear myxoid or myxochondroid or even diffusely hyalinized. This tumor also shows a variable number of blister cells, so the blister cells themselves do not tell us which type of epithelioavascular tumor we are dealing with. The genetics of epitheliohemangioendothelioma includes a recurrent 1-3 translocation that results in a WWTR1 CAMTA1 fusion. This fusion, in turn, results to upregulation of the CAMTA1 protein. So how can we diagnose EHE molecularly? Well, you can do FISH for one of the partners. More often now, we replace FISH with targeted RNA sequencing. And, of course, we have a very solid immunomarker, the CAMTA1, which is the surrogate immunomarker for the CAMTA1 gene rearrangement. So I want now to discuss a little bit about the organ-specific presentations of EHE, because you'll see how they may look differently in different locations. And I'll start with the lung. And in the lung, the most common presentation of EHE is this multifocal nodular involvement that you can appreciate from this X-ray, as well as gross appearance, that it mimics granulomatous or miliary or metastatic disease. These nodules have different sizes and typically involve all lobes bilaterally. And at higher power, the lesion is composed of these epithelioid endothelial cells with abundant eosinophilic cytoplasm. Often they have this nodular growth pattern filling the alveolar spaces, or more like tumor plugs. This was first described by Dale and colleagues back in 1983 under the terminology of intravascular bronchoalveolar tumor, IVBAT. And they correctly recognize this entity being a peculiar sclerosing endothelial tumor. And you can see why, because this lesion was associated with abundant hyalinization. Some of these lung tumors, instead of having extracellular matrix, they may have abundant central necrosis. The diagnosis, of course, can be confirmed with positivity of endothelial markers. Another important presentation is the diffuse pleural involvement, and here is truly a dramatic example that we had years back. This young man who presented with diffuse pleural thickening, encasing the lung parenchyma that required a pneumonectomy. There was no pulmonary parenchymal involvement grossly. And microscopically, you appreciate here the pleura is very thickened, mostly by stroma, by collagenized stroma, and with rather hypocellular, atypical, or malignant cells. And this is something I want to convey to you, that pleural involvement of EHE looks very different than other locations of EHE. They have this spindle, variably pleomorphic, fascicular growth pattern with variable cellularity. Here, these examples are more cellular than the prior one. Cytokeratin positive, so they may easily be misdiagnosed with sarcomatoid carcinoma or sarcomatoid mesothelioma. So you really have to be aware that in the pleura, EHE looks quite different. The pleural involvement, again, is variable from the diffuse case I showed to more focal, patchy, but also the lesion may extend into the pulmonary fissures. Moving on to liver EHE, again, multifocal presentation. This may may have a deceptive or subtle appearance microscopically. One, because it has a very infiltrative growth pattern, and second, because of this pale fibrotic background that you may not really appreciate what's going on. The features of EHE become more obvious with this intravascular growth, either small to medium-sized vessels showing this large tumor emboli, which can be highlighted by vascular markers. In addition, you can see tumor cells, individual or small cluster floating within these dilated sinusoid spaces. So a distinctive sinusoidal growth for liver EHE. The prognostic factors of EHE have not been very straightforward, and they usually depend on the organ it originated. So in the soft tissue, an old paper suggested that large tumors larger than 3 cm and 3 mitosis per 50 high power fields are associated with more aggressive outcome. Our experience is that surgery is usually curative for solitary soft tissue EHE. For thoracic cases, everybody agrees that once you have pleural involvement, that's really bad news. And this is an old study of ours showing the dichotomy in survival when you have pleural involvement it has a very aggressive outcome. So EHE has two histologic grades, if you will. The first one, low risk or G1, the tumors look relatively bland, and here are two examples of what I would call low risk or G1 EHE. In contrast, the malignant EHE or G2 has overt malignant or sarcomatous features, nuclear pleomorphism, hyperchromasia, necrosis. And I vividly remember when I was young that when we didn't have all these fusions that I struggled with some cases like this, if this represents an angiosarcoma or a malignant EHE. So now it's truly easy to, in any challenging case, to confirm the diagnosis in molecular studies. Okay, moving on to EHE with YAP1, TFE3 fusions, very interesting tumor, and that has distinct pathologic features than the conventional EHE, and you can see why. It has these epithelioid endothelial cells with voluminous, pale eosinophilic cytoplasms that are arranged in solid sheets, alveolar or pseudoalveolar, as well as vasoformative features. These tumors stain, of course, diffusely with TFE3 rearrangement. This is actually the index case. Due to this case that was sent to us as rule-out alveolar soft part sarcoma by an outside pathologist, we were so curious about what's going on. How can a vascular tumor have TFE3 positivity? I actually didn't believe that TFE3, and we did first FISH and we confirmed the rearrangement, and then we had enough tissue to confirm the YAP1 TFE3 fusion that results in upregulation of TFE3. Despite the different histologic features, the EHE with TFE3 fusions, I think, share similar clinical presentation with the classic variant, including multifocal visceral involvement. And also quite intriguing, in one of these cases, we had EM, and this tumor showed identical rhomboid crystals with what one sees in alveolar soft part sarcoma with TFE3 fusions. This is a classic typical example of YAP1 TFE3 with multifocal pulmonary liver involvement. The microscopic features, you can see here abundant pink cytoplasm, and this tumor in addition had lymph node metastases. This is one case that it seemed to have a more hybrid morphology. This was a bone lesion that had areas that looked more like a conventional EHE with abundant myxoid stroma, and then areas that look more pseudo-alveolar or pseudo-vascular appearance. So in a large study we've done a couple of years back, it became apparent that the YAP1 TFE3 fusion is associated with a significantly better outcome, with a 5-year survival with 86%, while the conventional EHE only 58%. So based on the differences in morphology, the clinical behavior, as well as the more recent publication from Josephine and Brian Rubin, this entity in the WHO will be included as a separate standalone vascular entity from the classic WWTR1 CAMTA1 fusion. So moving on to angiosarcoma, very briefly, this tumor has so much clinical, pathologic, and molecular heterogeneity. For this presentation, I'm just going to briefly touch on the 3 most common types that also are associated with distinct genetic alterations, implying they have different biology, and maybe they should eventually be treated differently. The first one, radiation-induced, defined by MYC gene amplifications, primary breast angiosarcoma with more often KDR mutation or VEGF receptor 2 mutations, and then the head and neck angiosarcoma, which has the genomic closer to melanoma or squamous cell carcinoma with high TMB and UV signature. So very, very briefly, the radiation-induced angiosarcoma is a cutaneous disease, and this is the classic clinical picture of this diffuse skin pigmented lesion. On gross appearance, there are multiple hemorrhagic lesions, and you can see on the whole mount that they are centered in the dermis. Most of these cases have a high grade and solid appearance, and of course the genetic hallmark, which is the MYC gene amplification. Sorry. Okay. So this is the appearance of the cutaneous skin lesion, and what I wanted to briefly point out is the pattern of MYC amplification. Yeah, you can see there those big blobs, red blobs of MYC amplified material. This is the intrachromosomal HSR or homogeneous staining repeats. This is in contrast to, for example, the pattern of EWS amplification that was shown earlier with NFAT-C2, which looked more like double minutes. So this is a very distinctive type of gene amplification. Radiation-induced angiosarcoma also may have vasoformative features, as you can see here, small slit-like spaces, and the line by these endothelial cells that have quite distinctive purple to basophilic cytoplasm and nuclei with open chromatin and small nucleoli. Post-lymphedema angiosarcoma shares pretty much all the features of radiation-induced angiosarcoma, being a cutaneous lesion and having MYC amplification. The differential diagnosis in this context, of course, includes radiation-induced atypical vascular lesion, or AVL. These tumors look quite different, though, are composed of these dilated spaces with hobnailed endothelial cells that are arranged in this linear pattern in the superficial dermis with parallel to the epidermis. These lesions stain with D240, indicative of their lymphatic derivation. Importantly, these lesions do not show MYC amplifications, and we do not think that this represents a precursor lesion of radiation-induced angiosarcoma. This is a very ambitious, large study that Josephine did when she was at Memorial, and she compared the genomics of the radiation-associated versus no radiation angiosarcoma. So the radiation one, you can see the are overwhelmingly positive for MYC amplification and plus minus the VEGF3 or FLT4 amplification, while the non-radiated or primary angiosarcoma, especially breast, have KDR mutations. So moving on to primary breast angiosarcoma, the key features here that this is centered in the breast parenchyma, young patients. These tumors are often well differentiated on morphology, and this is an entity, this is a subtype of angiosarcoma where histologic grading impacts on survival, right? So this is the typical gross appearance, right? It's a mastectomy specimen, and you can see these multiple hemorrhagic lesions within the breast parenchyma itself. Microscopically, the common picture are these well-formed vascular channels, some of them interanastomotic, lined by only mildly atypical endothelial cells. The diagnosis of angiosarcoma is not based on cytology most of the time, but it's based on the infiltrative growth of these tumors. This is in contrast with a lobular hemangioma here that you can see the very well-defined borders. This is also the only type of angiosarcoma that we use histologic grading. This is based on seminal work from Dr. Rosen from our institution from the 1980s. His three-tier grading was based on solid component, mitotic activity, and necrosis. However, this was challenged subsequently by another study from Nascimento et al., suggesting that histologic grade is not important even in primary breast angiosarcoma. So we were intrigued about this, and we recently re-evaluated the topic using modern criteria to diagnose angiosarcoma. And we showed that either using a two-tier or three-tier grading system, again, based on solid component mitosis and necrosis, this correlates quite well with outcome. You can see here the low grade 5-year survival 74 versus 38% 5-year survival for high grade. So I would strongly suggest you grade your primary breast angiosarcomas. So the last subtype, the head and neck angiosarcoma, which is actually the most common subtype of angiosarcoma, occurs in the sun-exposed skin, mostly scalp in older men. And the genomic landscape, as I said, has UV signature and high TMB, which is very different than any other type of angiosarcoma, and they respond to immune therapy. Microscopically, the appearance can be deceptive because the infiltrative growth, relatively low nuclear pleomorphism, and abundant lymphoid infiltrate that may obliterate the findings. So I hope with this talk, will help you a little bit in approaching vascular tumors, especially epithelioid vascular tumors in the future. And nowadays, we are fully equipped with all the molecular platforms needed to define all these genetic alterations, genetic hallmarks that these lesions have for a correct diagnosis. Thank you.
Thank you very much for a wonderful talk. Do we have any questions?
I have one question, well, two. So you use the term malignant EHE. I'm just curious if you use that term or not.
I did.
Okay.
But I also put in parentheses G2.
Okay. Second, so angiosarcoma, it never made sense to me that breast angiosarcoma grade didn't matter. But can you explain the discrepancy between your study and the others saying that angiosarcomas of breast should not be graded?
I can, yes.
You can?
Yeah.
Do you want to?
Sure. So in our study, we include only cases that were managed at our institution. So with a lot of slides that were reviewed for grading purposes. The prior study that questioned histology grading was done mainly on consultation material from all sorts of institutions, all sorts of management treatments. So, and who knows how many H&E slides were reviewed for each case. So we think that that particular study was full of biases. So.
Thank you. That was a very nice talk. I think along the same lines, the reason that breast, and I think Nascimento's study was suggesting not to grade, is because we've all seen quote unquote low grade angiosarcomas of both cutaneous and also breast that have, you know, killed the patient basically. They have very aggressive behavior. So the morphology or grading doesn't always correlate with outcome.
When we say low grade, doesn't mean that low grade tumor will not kill the patient. We are not saying that. It's still a sarcoma. But if you look at survival, you know, the low grade angiosarcomas, the way we define them, they live much, much longer, even with metastases. So it's clearly a more indolent behavior. So that's what we are saying.
Dr. Antonescu, I'd like to get your opinion on what is the underlying biology of the multicentricity of epithelioid hemangioma. Do you view that as a type of benign, localized metastatic disease or concurrent, independent mutations occurring at different sites?
Yeah, we try to address that to prove to everyone that these are probably monoclonal. They're local regional, benign metastasizing lesions, but we were not able to get good RNA from different distinct lesions in epithelial hemangioma to prove that. But my opinion is that the same thing with epithelial hemangioendothelioma. These are clonal and they are metastatic locally.
Is the WHO going to come up with a category or recognizing some type of local benign metastases in different types of tumors?
I don't think they will because, as I said, this was never demonstrated. So there is no really, this is just my hunch. I was hopeful that I could demonstrate that to show an identical breakpoint for all these different lesions, the way we showed in liver EHE, but we were not able to. But no, WHO will not touch upon that. And epithelial hemangioma will remain in the benign category. This was addressed last WHO because I think that epithelial hemangioma, as I showed you, has more aggressive behavior. I'm not saying it's not benign, but the consensus was to keep it under benign category.
Dr. Antonescu?
Yeah.
What is your approach on low-grade vascular tumors on radiotherapy sites outside the breast? Are they all best classified as angiosarcomas, or could they be other tumors as well?
Low-grade vascular tumors in the radiation field?
But outside the breast, for example.
You mean like an AVL? Or truly malignant low grade? I'm not sure I'm following.
I mean, can they also be, would you regard them all as radiation-induced angiosarcomas, or could they be also other neoplasms, low grade?
So if you're talking about radiation-induced angiosarcoma outside the breast, they're all high grade. We don't grade those. Okay. And that's number one. I think you have a good point. We studied quite a number of those, and they have a different genomics. They don't have MYC amplification, most of them, which is very curious. So most angiosarcoma that have MYC amplification are breast angiosarcoma after breast resection and radiation. So there is clearly something different about radiation-induced angiosarcoma at other sites for other diseases. And it's not necessarily based on the different doses of radiation. We looked into that. I don't think that's, it's mainly, you know, the milieu, the background that maybe allows a MYC amplification clone to be more permissive than in other locations.
Okay, thank you.
Thank you for your very interesting presentation. I have just a question concerning classification of neoplasm that is becoming increasingly...
We may have to, I'm sorry, we may have to move on. I'm sorry.
Okay, I will ask her the question directly.
Sorry
then.
about that.
Thank you.
I think we'll have to move on for sake of time.
Our next speaker is Carina Dehner from Indiana.
Thank you very much. And also thank you very much for the kind invitation to be presenting at this meeting. I'll be giving you an update on mesenchymal tumors with skeletal muscle differentiation. And just very briefly, this is how currently the rhabdomyosarcomas are classified in the 5th edition of the WHO, and I'm sure there will be changes. But right now we recognize embryonal rhabdomyosarcoma, alveolar rhabdomyosarcoma, with most of them being fusion positive. Then there's a category for spindle cell sclerosing rhabdomyosarcoma. And lastly, we have pleomorphic rhabdomyosarcoma. For the outline of my talk today, I want to briefly show you some known things about embryonal and alveolar rhabdomyosarcoma and touch on some more recent studies. Then we'll be discussing the fusion-driven rhabdomyosarcomas of bone. Then we'll move on to some of the fusion-driven rhabdomyosarcomas of soft tissue. And lastly, I want to briefly talk about the EWS1 PATS1 tumors that are round cell sarcomas with non-EDS fusions right now. But I just want to address the question about the relatively frequent rhabdomyoblastic differentiation in this entity. Other things that would technically fall possibly into this lecture but will be discussed separately will be rhabdomyosarcoma arising, or specifically inflammatory rhabdomyoblastic tumor, and also the Deister mutated or Bortreau type embryonal rhabdomyosarcomas. Just some basics about embryonal rhabdomyosarcoma for those that don't see them so commonly. As you know, it's a most common soft tissue sarcoma in childhood with a median age of 6.5 years. And most commonly they present in the head and neck region, but it can also involve the GU tract or other sites. There's an association with several syndromes, so Deister 1, Costello syndrome, or neurofibromatosis type 1. And histologically, generally speaking, they're most commonly a primitive round cell neoplasm within loose myxoid stroma. By immunohistochemistry, they're usually desmin and MyoD1 positive, and then usually they're more limited myogenin positive. The prognosis is relatively good for younger patients, but does worsen with age. And the presence of anaplasia is associated with a poor prognosis, or a worse prognosis. There are some pediatric staging systems in place that I won't be discussing in detail here today, but these generally factor, amongst other factors, also the site, the tumor site, into account. So favorable sites include the GU tract or the bile duct, the head and neck, and unfavorable are some of the other sites. Just to show you some morphologic pictures, you see on the upper left, often low power, these are like variably cellular neoplasms. On the right, you can see they're frequently having loose myxoid stroma, and you can see on high power that they're primitive spindle to ovoid cells, sometimes more round cells. Here on the upper left and right, you can see what we mean if there's anaplasia. You see several of the tumor cells are significantly enlarged. And then by immunohistochemistry, you can see the MyoD1 is diffusely positive in this case, but the myogenin is more focal and multifocal. Just wanted to highlight a very, I thought, very interesting recent study by Dr. Antonescu and colleagues that was triggered by an index case of morphologically unclassified rhabdomyosarcoma. You can see on the left it showed some features that were reminiscent of alveolar rhabdomyosarcoma, other foci looked more like a rhabdomyosarcoma sarcoma with sclerosing features, and so molecular testing was performed. I should mention the immunohistochemistry though. You see MyoD1 was diffusely positive, but myogenin was more multifocal, similar to what we just saw in embryonal rhabdomyosarcoma. And so molecular testing was performed, which showed this FGFR1 ANK1 fusion. So subsequently, the authors reviewed their files and looked for additional possible rhabdomyosarcomas with FGFR1 fusions, and identified one additional case, which was a case with an FGFR1 TAC1 fusion, and that was a tumor that resembled morphologically embryonal rhabdomyosarcoma of anaplasia, but did not have any pathogenic variants in TP53 or DISO1 on germline testing. And then they also identified two additional cases which didn't show FGFR1 fusions, but high levels of FGFR1 expression. And so they did this unsupervised UMAP clustering on RNA expression data. And it was interesting, albeit only 3 cases, you can see all 3 cases did cluster with embryonal rhabdomyosarcoma. So they raised the possibility or the question, are those is this a separate new subset of rhabdomyosarcoma, or could FGFR1 fusions be occasional drivers of known rhabdomyosarcoma subtypes, such as, for example, embryonal rhabdomyosarcoma? And this could be therapeutically relevant because it would open a pathway for FGFR1 or FGFR inhibitors. Moving on to alveolar rhabdomyosarcoma, which is the second most common rhabdomyosarcoma subtype. The peak incidence is a little bit older, with 10 to 15 years of age, and they're more frequently in the deep soft tissue, but can also rise at any site. Morphologically, these are monotonous tumors, more primitive round cells that are often forming this pseudoalveolar growth pattern. If present, what can be helpful is the presence of tumor giant cells, multinucleated tumor giant cells. And then by immunohistochemistry, these are usually strongly desmin and really strongly and diffusely myogenin positive. So the majority of cases harbors fusions with FOXO1 and PAX3. In most cases, or PAX7, smaller subset of cases, and that's what we refer to as the canonical fusions. And then there's actually there are new studies showing that there's a marker for this. So FOXO1 could be used as a sensitive and relatively specific marker as a surrogate for the fusion. And then there's a smaller subset of cases where you have PAX3 fusing with either FOXO4, NCA102, or INO-ADD, and that's what we call the non-canonical fusions. Now, just a small pitfall to keep in mind, these tumors occasionally show some synaptophysin and some cytokeratin expression. And prognostically, these tend to do worse than the embryonal rhabdomyosarcomas. And specifically, the presence of a fusion has been associated with poor prognosis, with the PAX3 fusion being worse than the PAX7 fusion, and also amplification of MYC and CDK4 and so on have been considered poor prognostic factors. If we look at the morphology on the upper left, you can see on low power, there are more upper left and right, you can see it's a more discohesive pattern often, and you can see on the bottom left that you have often these thin fibrous septae that are kind of engulfing these clusters of monotonous tumor cells leading to this pseudoalveolar pattern. Sometimes you'll see more obvious rhabdomyoblastic differentiation. You can see on the bottom right that there are these little cells with brightish pink cytoplasm suggestive of rhabdomyoblasts. These are just high power photographs. You can see the cells are much more round and monotonous because these are fusion tumors. You can also see some examples of these tumor giant cells that I mentioned. Occasionally you may see pseudo-rosette-like formation, as we see on the bottom left and the bottom right. And then by immunohistochemistry, this case was MyoD1 positive. And then in contrast to the embryonal rhabdomyosarcomas, you can see how strong and diffuse the myogenin is usually positive. You can also see some examples of focal keratin and synaptophysin expression. There's also a very new study on alveolar rhabdomyosarcomas by Dermawan and Karen Fritchie. In modern pathology, they had these really interesting cases, 2 cases, one in an infant and one in an adolescent with clinically stage 4 metastatic rhabdomyosarcoma that morphologically were more like sheet-like, small round blue cell tumor lacking the distinctive alveolar growth that we would think of by alveolar rhabdomyosarcoma, but by immunohistochemistry, they were diffusely positive for desmin and also diffusely positive for myogenin. So molecular testing was performed and showed this PAX3, exon 7, MAML3, exon 2 fusion, which is a fusion that we usually more commonly see in biphenotypic sinonasal sarcoma. So the authors pursued methylation testing, and let's see if I can, oh no, where's the, sorry, I was gonna, oh, sorry, yeah, I wanted to highlight this one, okay. Oh yeah, sorry. And you can see here, hopefully, these two cases with the PAX3 MAML3 fusion, they're clustering with all the other alveolar rhabdomyosarcomas, so the FOXO1 rearranged and the ones with non-canonical fusion, and they cluster separately from the biphenotypic sinonasal sarcomas with various fusions, including the PAX3 MAML3 fused biphenotypic sinonasal sarcoma. So this is obviously important clinically, and the treatment then as fusion-positive alveolar rhabdomyosarcoma led to partial and full remission in the both cases. So I thought this was a really interesting study, and it just supports that this should probably be considered a relevant fusion in fusion-driven alveolar rhabdomyosarcoma. Moving on to fusion-driven rhabdomyosarcomas of bone. So far there have been about 80 cases, 78 cases reported. And most of these present in young patients with a predilection for the craniofacial bones, but most common second location is the axial skeleton. Morphologically, they're usually mixed spindle to epithelioid, but sometimes you'll see predominantly spindle or predominantly epithelioid morphology. And by immunohistochemistry, they tend to be positive for desmin and MyoD1 with very focal or even negative myogenin. Now, we heard about this morning too. A large subset of them also expresses ALK, which can be really helpful for the diagnosis even before the molecular testing. But it's also relevant to remember that they can be positive for cytokeratin. So, we're dealing with a bone lesion in a younger patient without a known primary. This is a very important diagnosis to keep in mind before moving on to a metastatic carcinoma. So just a good reminder to add the desmin stain and the MyoD1 stain. By molecular testing, the majority of these cases harbor TFCP2 fusions, and the more common fusion partner is the FUS. The second most common is EWS01, and then there's a smaller subset that most commonly harbors MEIS1 and CA2 fusion. There have been some recent studies showing that some cases show additional ALK fusions. Maybe that's also an explanation for the expression of ALK by immunohistochemistry. And there was a really interesting study in Nature Communications by Schöpf and colleagues that showed that in contrast to many of the other fusion-driven sarcomas that usually have a more stable genome, this fusion-driven sarcoma has an unusual high genomic instability, so they often show chromothripsis, high loss of heterozygosity, and also these cases frequently show co-deletions of CDKN2A and MTAP. They also had two cases in their paper which showed where they had a seemingly benign precursor lesion that later on behaved as a high-grade sarcoma. So I think some of the cases can have significant nuclear pleomorphism, as we saw this morning, but sometimes they can be deceptively bland, at least in my experience. Clinically, overall, this is a very aggressive sarcoma with a poor outcome, and there have been initial studies now using ALK inhibitors of kind of variable success. Let's look at some of the morphologic pictures. This was an example of a case with an EWS01 TFCP2 fusion. If you look on the upper left, you can see we have really this mixed spindle and epithelioid morphology. You see on the right that these are really destructive lesions usually that do not produce bone, they destroy bone. You can see the radiologic studies, really aggressive lesions, often with soft tissue extension. And on the bottom right, you can see in occasional cases you have more obvious rhabdomyoblastic differentiation. Just to show you some of the morphologic spectrum, this was an example with a MEIS1 NSOA2 fusion that shows a predominantly epithelioid morphology and to me looks relatively bland, has very limited mitotic activity, but still behaved as a high-grade sarcoma. By immunohistochemistry, the desmin sometimes is a little bit more weak, but still relatively diffuse, and the MyD1 can be more focal or relatively strong and diffuse. And then especially if there's a lot of epithelioid morphology, the cytokeratin, I find, can be really scarily positive. You can also see that this was an example where the ALK was also positive. This is that same paper that I mentioned earlier by Schöpf and colleagues in Nature Communications. They also pursued methylation studies, and you can see here that interestingly, we have here kind of a cluster of all these different types of rhabdomyosarcoma, that some of which we talked about, but you can see that the TFCP2 clusters were much closer to undifferentiated sarcoma, which may be due to their high genomic instability. Moving on to fusion-driven rhabdomyosarcoma of soft tissue. This is a group that is a little bit more difficult to discuss because there's many papers with many different fusions. And so overall, this seems to be a really clinically and morphologically diverse group that I think we don't fully understand yet if these are a group of tumors with variable morphology and molecular features. Do they represent all distinct rhabdomyosarcoma subtypes? Are they actually better classified as fusion-driven sarcomas that have some level of rhabdomyoblastic differentiation? I think many of these, you can see the number of cases in parentheses. It's too early to tell because we just don't know enough. But definitely, relatively frequently, we do see the fast EWS1 TFCP2 fusions in soft tissue presenting as primary soft tissue or even cutaneous lesions. And then, in my experience, they're relatively morphologically very similar to the osseous cases. Then there are some other fusions that I think we have a few more cases, and they seem morphologically relatively distinctive, and we'll go into the details of some of them, and those are those with CFP64 NCA2 or 3 fusions, and those with VGL3 fusions in the head and neck. But many of these other cases, I think it would be really great to collect more cases and learn more about them. This is one of the study I mentioned. There's really Abbas Agaimy and colleagues that describe the largest series so far, which are those with VGL3 fusion in the head and neck, with a head and neck predilection. In total, we have 9 cases so far that are reported. 8 were in male patients and 1 female patient with a broad age range. Most lesions involve the tongue, but there were also some cases in the oropharynx, in the jaw, and the nasopharynx. And these seem to harbor most commonly TCF12 VGL3 or EP300 VGL3 fusions. The outcome, it seems like initially they're possibly more indolent tumors. I think this is also a type of rhabdomyosarcoma where it would be great to collect more cases and learn more about the outcome. Morphologically, these are bland spindle cell neoplasms infiltrating through the skeletal muscle. They usually don't show necrosis. They have a relatively low mitotic count. And by immunohistochemistry, they're positive for desmin with more rare myogenin and myod1. Just to show you another case, you can see here, this was also a lesion in the tongue, relatively bland spindle cell morphology, very limited mitotic activity, and really monomorphous growth. You can see it was positive by myod1. The other entity that I mentioned is the spindle cell rhabdomyosarcomas with CFP64 NCA2 or 3 fusions. There's really Han and colleagues and Dr. Antonescu and colleagues that showed the largest initial series. In total, there have been 8 cases so far based on my literature research, also a predilection for male patients with a broad age range. And morphologically, these are characterized by this very distinctive herringbone growth pattern, almost reminiscent of fibrosarcomatous transformation of DFSP or adult type fibrosarcoma, if you will. By immunohistochemistry, they show expression of desmin with more limited myod1, and myogenin has been negative in all cases. And I've seen a few of these cases, and to me it seems like some of the cases seem to have almost no skeletal muscle differentiation, so it's very interesting, you know. By molecular testing, the majority seems to harbor a CFP64 NCA3 fusion, with a smaller subset harboring CFP64 and CA2 fusion. And the outcome is relatively variable. Definitely, there have been some cases that showed death from disease. And then the only last entity that I want to mention that may not be perfect here, but that's more up for debate, I guess. And this was something that came up a few years ago when I presented some of our work at ASCAP. And this was based on the question essentially, should these be considered tumors with skeletal muscle differentiation? Why are they not called rhabdomyosarcoma if we think of all the other sarcomas we just looked at that have sometimes very limited rhabdomyoblastic differentiation? Maybe just very briefly to recap what we've heard from Isidro earlier. So far there have been about 46 cases reported, with most of them presenting in middle-aged adults. Median age was 48, with a male predilection. So far all of them have presented exclusively in soft tissue, so there's not been any bone tumor to date. And there's a preference for the thoracoabdominal region. Morphologically, they're usually partially encapsulated, lobulated neoplasms with these distinctive microcystic and pseudoalveolar spaces. You often have thick fibrous septa that are separating these tumor lobules. And then on high power, the cells are usually relatively uniform to spindled, arranged in sheets and whorls. Now, these initially were reported as polyphenotypic sarcomas, which I think is very true. They very consistently express GFAP. They show often some S100 or SOX10, occasionally even some keratin expression. But then when we looked back, we found that all the tested cases, and most of the cases were tested, were actually indeed showing some level of skeletal muscle marker expression. And then interestingly enough, there were 2 cases so far that had true areas of overt rhabdomyoblastic differentiation. So I think I don't want to say this is a rhabdomyosarcoma, but I think the question is valid, and I don't know the answer, and I'd be interested to hear what others are thinking. But here I just want to show you some of the morphologic pictures. You can see on the upper left, to me, the low power is the most helpful for the PATS1 tumors, because you see the microcystic spaces always reminds me a little bit of like Swiss cheese appearance. On the upper right, you can see the higher power on the microcystic spaces. Often they have proteinaceous secretions in them. On the bottom left, you see what also Isidro nicely highlighted, the hyalinized vessel walls, somewhat reminiscent of what you could see in SFT. And then this was an example of one of the cases that had, oops, sorry. I'm struggling, that had obvious rhabdomyoblastic differentiation. And you can see how positive the desmin sometimes can be. So I think it's an interesting point. And with that, I just wanted to summarize. I think, as many of the other talks have shown, that advanced molecular techniques have led to the recognition of novel entities and clinically relevant molecular alterations in previously known entities. We talked about the PAX3, MAML3, and alveolar rhabdomyosarcoma. And I think it's very important to stress that our understanding of these novel entities is really limited due to the often small cohort size and the short follow-up. And with that, we can probably assume that the subclassification of rhabdomyosarcoma will continue to evolve. And I just wanted to thank my mentors and my colleagues at Indiana University and many collaborators. Couldn't list everyone, but thank you very much for your attention, and happy to take any questions.
Any questions?
Hello. I have a question. So you agree with Dr. Agaimy that pleomorphic rhabda doesn't exist?
I have to say, I find it a more and more difficult diagnosis to make, because there's more things that we now know that we have to exclude to truly get to a diagnosis of pleomorphic rhabdomyosarcoma. I don't know yet if I'm at the point where I say it doesn't exist, but I have a hard time. I was looking for cases, and I had a very hard time finding them, because when you start testing for the things that may not have, that have to be excluded, then there's not so much left.
The other question is, and I ask this question, how many myogenic positive cells do you need to call something rhabdo?
I think that's a very good question, and that's very, I think for many of these tumors, I think especially just thinking about the parts 1 tumors, they have consistent but often limited expression of skeletal muscle markers, but we don't call them rhabdo, and then we have those with CFP64 fusion that sometimes have barely any skeletal muscle marker expression, but we think they're rhabdos. Yeah, so I don't have the answer, but I think it's a great point.
Yeah, because you said that one of these fusion associated sometimes don't show any skeletal muscle differentiation, but still you call them rhabdomyosarcoma.
Well, I mean, I think that's when, I don't know if that's the right thing to do. Morphologically, they have all this very distinctive herringbone growth pattern, and maybe it's better to call it then spindle cell sarcoma with this fusion. Maybe they should be defined by the fusion. Yeah, those are great points. I don't know.
Can you hear me? Oh.
Yeah.
So that was very nice, thank you. A clinical correlation to that is rhabdos are often treated with a sort of a very aggressive chemo, right, more than the other sarcomas. So what do you recommend when there's no definite skeletal muscle differentiation versus some in terms of treatment?
Yeah, I think that's a great point. I mean, I think they should be treated as high-grade sarcomas. I think, I don't know, I personally would think our current understanding is, I guess, that for those with CFP64 fusion, we think they're rhabdos, so they should probably get rhabdo treatment, but I think a lot of these are so new and we have so limited data that I don't feel as a pathologist qualified to to give good treatment recommendations.
Repeated cannot be answered. How much rhabdo is required or how much rhabdo is tolerable in non-rhabdomyosarcoma? There is no answer. Oh, sorry. And I remember as we published the series with VGLL3 fusions, and we called it in the initial draft low-grade myogenic neoplasm with VGLL3 fusions, and then Cristina reviewers insisted upon calling it spindle cell rhabdomyosarcoma, and we called it according to that or due to that reason to avoid rejection of the paper by the reviewer. But we are not really convinced. Some of them indeed have much myogenin or myo-D1, but some of them are barely rhabdomyoblastic. They have more desmin and no really myogenin, myo-D1. And I think they are very low grade. And I remember I was contacted by one patient diagnosed with the same disease, think well-informed academic or biologist, and was asking through his oncologist about treatment. I said I would consider anything more than local excision and over-treatment because we don't have too many cases, but the cases we have with long-term follow-up, in some of them really no single case recur. They have no mitosis, they don't have necrosis, so it looks really, even it can be mistaken by the non-worry as benign or harmless. So I think still we don't know if they are really rhabdos and if they are really recurring or metastasizing or not. But this question is difficult, but we need to answer it one day.
I agree.
Thank you very much for your presentation. Now, because there are so many sarcomas, spindle cell rhabdomyosarcomas, I am really concerned. Have you had the opportunity to study, retrospectively study MPNST with rhabdomyoblastic differentiation?
I haven't specifically studied that, but I think as we're collecting rhabdomyosarcomas, some of the fusion-driven rhabdomyosarcomas, some studies are ongoing. We find that some of the cases were initially diagnosed as MPNST with rhabdomyoblastic differentiation. So I think that's a great point, and especially in a setting where there's no known neurofibromatosis type 1, I think some of those may actually represent fusion-driven rhabdomyosarcomas.
Thank you.
We have to move on, and our next speaker is, can you hear me? Our next speaker is Michal, our dear local host, who's going to talk about myoepithelial tumors.
Okay. So, as everybody knows in this audience, this group of tumors is highly heterogeneous. The tumors are also generally very rare neoplasms. The first concept of myoepithelial tumors was introduced in 1997 by Dr. Kilpatrick and Fletcher. They basically defined the first useful morphological and IHC criteria. In WHO, the group currently encompasses mixed tumors, myoepitheliomas, and myoepithelial carcinomas. And as you will see, the diagnostic criteria are somewhat vague. Morphologically, the tumors should be trabecular, reticular, or nested. They can show also solid growth of variable spindled epithelioid cells. And the stroma can be myxoid, hyalinized, or even chondroid sometimes. The mixed tumors, in addition, often show ductal differentiation. The myoepithelial carcinomas are basically defined mainly by the presence of cytological atypia, and they usually also have some increased mitotic activity. Immunohistochemically, they should be positive for so-called myoepithelial markers, that means EMA or keratin, and S100 or SOX10 or GFAP. However, the expression is highly variable, and there are myoepithelial tumors confirmed by molecular, which are negative with all of these markers. At the same time, the same immunoprofile can be found in tumors which do not have molecular alterations of myoepithelial tumors, so it's also non-specific. In addition to that, a subset of myoepithelial tumors was shown to have loss of SMARCB1 expression. By molecular, there are various fusions of EWSR1 or FUS gene with multiple gene partners, as we will see later. And also, the mixed tumors were found to have PLUG1 fusions. So the mixed tumors should have completely different molecular and also very often show ductal differentiation. In 2003, Dr. Hornick and Fletcher first defined the prognostically relevant microscopic features. Basically, it means the presence of atypia, so tumors without or with very mild atypia should be called benign myoepitheliomas. And whenever there is moderate or severe atypia, this qualifies the tumor as malignant. Obviously very subjective, but that's what was available back then. So in their study, the tumors classified as benign recurred in about 20% of cases. None of the cases metastasized. From the malignant group, 1/3 recurred and roughly 1/3 metastasized. So in 2008 and 2009, the first case reports from the Norway group of Dr. Heim, they published the first molecular alterations in myoepithelial tumors, EWSR1 PBX1 gene fusions and EWSR1 ZNF 444. And about 1 year later, the first systematic study of myoepithelial tumors was published by Dr. Antonescu and Dr. Fletcher. They, for the first time, found EWSR1 POU 5F1 fusions in myoepithelial tumors. Also, a bunch of cases had PBX1 fusions, one case had, again, ZNF 444 fusion, and then there was a bunch of cases which were found to have EWSR1 rearrangement, but they didn't find the fusion partner back then. Already in this study, they noted that the myoepithelial tumors negative for EWSR1 rearrangements tend to be more often benign. Histologically, they are more often cutaneous or superficially located. And about 1 year or 2 years later, they, in this superficial subgroup of myoepithelial tumors, they indeed found PLUG1 gene rearrangements, which, as was already known back then, occur in salivary gland myoepithelial tumors. They also noted that these tumors very often show ductal differentiation. The vast majority of cases shows some epithelial differentiation in the form of ducts, typically. Then multiple papers appeared with descriptions of other gene fusions, EWSR1 or FUS with KLF17 or KLF15. PBX3 fusions were described, and the most recent addition was subgroup with SS18 POU5F1 fusion. I'll touch on that a little bit later. In 2009, the SMARCB1 loss of expression was, I would say, partially coincidentally found by Drs. Hornick and Fletcher in a study of epithelioid sarcomas. So they found that about 10% of myoepithelial carcinomas show loss of INI1 expression. Then later, Dr. Baratrecki and his group found 40% of myoepithelial tumors, so including the benign ones, to show loss of INI1 expression. And I think the most comprehensive study on this topic was published in 2020 by Dr. Surmaier and Antonescu again. They included only fusion or positive cases or EWSR1 FUS rearranged cases. Most of them had also known fusion. So almost 70 cases with various gene fusions that were described previously already. And this beautiful study already kind of managed to match certain morphological features with the fusion subtypes. And basically a year ago, the first methylation studies, mainly focusing on adnexal tumors, but also including myoepithelial tumors, were published. They included, this study focused on mixed tumors. They found that ecrine subtype of mixed tumors had SOX10 intern tandem duplications and was completely different from the apocrine subtype of mixed tumors, which was known to have PLUG1 gene fusions. If you notice in this part of the graph, here are the green ones, I think, were salivary gland myoepithelial tumors with PLUG1 rearrangements, and their cases in the study of apocrine subtype of mixed tumor in the skin basically perfectly match with the salivary gland tumors. They also included few cases of soft tissue myoepithelial tumors with EWSR1 fusions with various fusion partners. It was clear that they cluster completely separately from this subgroup. Something similar was found by another French group a little bit later in this study. So right now I would like to show our, let's say, preliminary data on a study we are working on with Josephine Dermawan, and it's basically possible only thanks to Dr. Antonescu, who provided us generously with almost half of the cases we are studying. So we have 53 cases of myoepithelial tumors of skin, soft tissue, and bone. And there are many collaborators sitting in this room, so I think this is a nice example of friends of bone and soft tissue tumors working together on studies that are hopefully needed. So we focused on two aspects, or focusing on two aspects of these tumors, mainly on the methylation analysis and comparison of the fusion subgroups, and on the clinical data, the outcome of these tumors. Because the outcome of these tumors is largely unknown, there are very few reports on cases with fusion data, with genetic data. So this is our cohort, what we have. Basically all the main fusion subtypes are covered. We also had 15 cases of the cutaneous myoepitheliomas or apocrine mixed tumors, if you wish. 15 cases with various fusion partners. There, it doesn't really matter which fusion partner, it's just PLUG1 fusion, that's all that matters. And we obtained methylation data for the vast majority of cases. We were also able to add external data sets from Dr. Malik's recent study in Virchow's archive. I would like to thank him, if he's watching, for their cases. And we used also external data sets as the reference groups for all the other entities like Ewing sarcomas and so on. We had some internal data sets for OFMTs and FAT-C2 tumors and some others. So here are our results. So in this UMAP plot, you can see some entities which we thought are included in the differential diagnosis of myoepithelial tumors. And in the middle, you can see the purple cases are soft tissue myoepithelial tumors with EWSR1 or FUS gene fusions. In this plot, in this graph, you don't see the fusion partners. We just try to show here that it seems to be one, let's say, relatively close cluster. And all the differential diagnostic entities are around it. Again, notice here are our PLUG1 cutaneous mixed tumors or cutaneous myoepitheliomas with PLUG1 fusions. And they cluster with a reference cohort of salivary gland myoepithelial tumors, so completely different. What is also interesting at this view is, look here in the middle, there are NFAT-C2 sarcomas. They land basically in the middle of the myoepithelial cohort. So imagine you're looking at this at a 4x, and now we go on, let's say, 20x on the microscope. So we use higher magnification, we look down, and we break it down to the various fusion subgroups. Now we see in purple the fusion subtype with POU5F1 fusions, The green and blue are PBX1 and PBX3 tumors. They overlap. They seem to form one distinct cluster. Here in yellow or orange, there are myoepithelial tumors with KLF17 fusions. Then here are 2 cases. We had only 2 cases with this fusion subtype. And here in the middle, again, purplish color, KLF15 subgroup. So all the fusion subtypes, it's not perfect. It doesn't work for 100% of the cases included, but still the different fusions seem to form a different cluster, which, however, they are all closely to each other. So I think with also looking back at the morphology and immunophenotype and clinical features, I think this suggests these tumors are kind of closely related, but they each form a distinct subtype. That's, I think, how we will frame it. And again here, NFAT-C2 tumors right in the middle of the myoepithelial subgroup. So when you look at the morphology of NFAT-C2 tumors or sarcomas, which is basically very often perfectly myoepithelial-like, and you look at the immunophenotype, which often includes positivity with EMA or keratins, they're always S100 negative, but otherwise the epithelial markers are there very often, at least focally. And you see the methylation data, you may start to wonder whether it would not be better to classify these tumors with myoepithelial-like neoplasm instead of with round cell sarcomas. Here is the heat map, hierarchical clustering, and here, again, on the left, plug-1 tumors clustering perfectly with salivary gland, myoepithelial tumors, and then all the EWSR1 FUS rearranged myoepithelial tumors. They, again, it's not perfect, but you can see distinct clusters getting close together. And perfectly in the middle sits NFAT-C2 group again. So now when I will try to summarize basically all the data, all the clinical pathological data in our study, as well as from the literature, so everything what was published, and where was molecular confirmation, because there is a lot of papers on myoepithelial tumors, but there is quite few with molecular confirmation, so I included only the cases with molecular data. We can see some recurrent overlapping clinical pathological features for each subgroup. So the plug-1 rearranged apocrine mixed tumors or cutaneous myoepitheliomas, the morphology is variably used here. Although they partially overlap morphologically and by IHC with the EWSR1 FUS tumors, when you look closer on the molecularly confirmed cases or cases with plug-1 IHC data, the plug-1 IHC is a pretty good surrogate marker, you start to see distinct clinical pathological features. These tumors occur only in adults. The median age is some 53 years. They are much more common in females, twice as common in females. They're basically always superficial. They occur in the dermis or subcutis, and they never occur in bone. And they are basically never centered to deep soft tissues. They may kind of infiltrate there from the dermis, but they are not centered there. They have very distinct predilection for acrocytes and for head and neck. I don't recall the exact number, but some 80% of cases occur at these 2 sites. And although the follow-up data or the outcome data are very scarce, the majority seems to be completely benign. 2 out of 12 cases had adverse event, 1 case showed local recurrence, and 1 of those 2 cases metastasized, but no patient has died so far. So morphology, I'll say this shortly, that basically perfect overlap with salivary gland, myoepithelial tumors, so these epithelioid plasmacytoid cells with a lot of eosinophilic cytoplasm and myxoid or chondromyxoid stroma. There is typically no or minimal atypia, low mitotic activity, and typically in the vast majority of cases you find some small areas with ductal differentiation. Here this is just an example of common apocrine mixed tumor of the skin when you have lack of the ductal structures and a lot of the myoepithelial cell differentiation. You basically get the extreme of the spectrum, which is usually called cutaneous myoepithelioma. It's a spectrum of tumors. So by molecular, the vast majority has plug-1 fusions. Rarely you have basically mutually exclusive HMGA2 fusions. There, by IHC, these tumors are always S100 SOX10 positive and also cytokeratin, broad spectrum cytokeratin positive. You can use surrogate markers for the molecular alterations. They are very sensitive, and in this location seem to be relatively specific, not perfect. And now we're moving to the soft tissue and bone myoepithelial tumors, EWSR1 PBX1 or PBX3 tumors. There are overall 65 cases either published or in our study. So these tumors are mostly in adults. The median age is 35 years, and the vast majority occur in the dermis. They are likely heavily underreported. It's a relatively common tumor. We see it a couple times a year here. I'm sure you do too. And when they are in the dermis, when they are cutaneous, they are almost always on the extremities. Overall, 21 cases have been found in bone, mostly in metaphysis or diaphysis of long bones. 5 cases were found in visceral locations, all of them in lungs or thorax. And when we speak about the cutaneous cases, so far all reported cases were benign. In bone, it's somewhat more variable. There are reports showing repeated local recurrences, and in one case also metastasized, and that all despite a short follow-up. Also in bone, they look sometimes a little bit differently. I'll talk about it on the next slide. The thoracic cases, 2 out of 2 cases with data recurred, 1 patient died of disease. Regarding the morphology, the vast majority has been classified as benign. Basically, those are called syncytial myoepitheliomas. And those that were classified as not benign, either atypical or malignant, based on the nomenclature used, they usually look like ovoid spindle cell sarcomas with or without hyalinized stroma. And sometimes at the periphery there was like a low-grade syncytial myoepithelioma morphology. Most cases showed co-expression of S100 and EMA. Cytokeratins are usually negative. And perhaps interestingly, SOX10 in all 18 cases studied was negative. The vast majority of these tumors have PBX3 fusions. PBX1 fusions are much less common. So here we have the first paper on cutaneous syncytial myoepitheliomas by the Harvard group around Dr. Fletcher. So they first described this tumor by morphology, and only later they show PBX3, EWSR1 PBX3 fusions in these tumors, and that was after this fusion was described by Dr. Antonescu's group in, I think it was mostly in bone tumors first. And then here are 2 recent papers by John Gross and his group and Dr. Bahrami group, which included a bunch of skeletal cases that look somewhat differently. So this is a typical morphology of syncytial myoepithelioma, either in the skin or in the bone. When the tumors are benign, they look identical whether they are in bone or in the skin. So the syncytial growth of this ovoid or histiocytoid cells with eosinophilic cytoplasm, and a very useful morphologic clue is this perivascular lymphocytic infiltrate. Some cases may have adipocytic, either metaplasia or differentiation, I don't really know. Sometimes it's really, really prominent, so it almost presents like a lipomatous tumor. And here are some examples of the malignant-looking tumors with this fusion. All of them were either in bone or in the thoracic visceral locations. No case has been found with this morphology in the skin, as far as I know. So now we're going to speak about the group with POU5F1 fusions. Overall 32 cases, either reported or found in our study. These tumors have a predilection for young adults. The median age is 26 years. They are typically in subcutaneous or deep soft tissues. About 1/5 occur in bone, and 2/3 are on the extremities. Rarely, they can also present in visceral locations. Interestingly, all 3 cases in visceral locations were in the kidneys. They seem to be very aggressive, despite quite a short follow-up. 8 out of 13 cases metastasized. 1 patient died of disease so far. Regarding the morphology, I found it very interesting because we could review so many cases there. We could also identify as kind of like a spectrum of morphologies, which includes like benign-looking tumors, which resemble some epithelioid schwannoma perhaps, or kinase fusion tumors maybe with this prominent hyalinization in the stroma and around the vessels, and bland epithelioid cells. The most common morphology, though, is the one described in the Dr. Surmaier and Antonescu study, these nests of epithelioid cells with clear cytoplasm. And a subset of cases has been published or presented with basically undifferentiated round cell sarcoma morphology. So this spectrum kind of a little bit reminds me of tumors like PATHOLOGY sarcomas or myxoid, low-grade and high-grade myxoid liposarcoma. So there is a very wide morphological spectrum where the low-grade tumors can look completely different from the high-grade tumors. Regarding IHC, to be honest, there don't seem to be major differences between the various fusion subgroups. So the POU5F1, KLF15, KLF17, and ZNF444 don't seem to differ dramatically with regard to expression of S100, EMA, and cytokeratins. However, there seem to be some differences in SOX10 expression because, for example, POU5F1 cases have been always negative for SOX10 so far, but only some 7 cases have been studied. I'll just briefly mention that there seems to be another subtype of perhaps myoepithelial tumors with POU5F1 fusion, but not EWSR1, but SS18 fusion partners. They seem to be somewhat different because they always present with high-grade round epithelioid cell morphology, and basically all cases have behaved very aggressively. Regarding the other fusion subtype, KLF17 tumors, altogether 16 cases with known data. Again, predilection for young adults, typically in deep soft tissues or in bone, and there is a predilection for extremities. Kind of interestingly, the 4 visceral cases, again, predominantly favored one specific location, and that was the thoracic cavity, lung, and pleura. 3 out of 7 cases with data metastasized, and so far 1 patient has died of disease. Morphologically, these tumors present as coarse or trabeculae of epithelioid to spindle cells in myxohyaline stroma, so basically the parachordoma-like morphology described many years ago for the first time. And only 6 out of 16 cases had a malignant morphology. The rest very often presented like this, benign appearing or very low-grade appearing mesenchymal tumor. And the majority so far expressed SOX10. The KLF15 group, so another group that was KLF17, now we are speaking about KLF15, they appear very distinct. They have a very strong predilection for infants and young children. The median age was 3 years. No case so far has been described in bone. They typically arise in deep soft tissues or visceral locations. And they seem to be very aggressive again. 6 out of 9 cases metastasized, 4 patients out of 9 died of disease. And they also have a very consistent morphology. 13 out of 14 cases had malignant morphology, and majority of those presented as this, so basically quartz sheets of round to epithelioid cells in myxoid stroma, and all 5 tested cases were consistently SOX10 diffusely positive. So I think this is the last fusion subtype. Very few data on those, only 4 cases with ZNF444 fusion. All were in females. 2 cases out of 2 metastasized, 1 patient died. All 4 had a high-grade malignant round cell morphology. Typically, the cells were deposited in hyalinized stroma. And one of my last slides, the SMARCB1 deficient myoepitheliomas. Although they were not a subject of our study, they were the subject of the study by Dr. Faizan Malik and his group. And they also did methylation analysis. They didn't have so many fusion positive myoepithelial tumors, but they have quite a few SMARCB1 deficient ones. And if you look at their methylation results, the blue color and the light green or light blue color are epithelioid sarcomas and malignant rhabdoid tumors. And the green cases here are basically the SMARCB1 deficient myoepithelial tumors. So they seem to cluster with these other SMARCB1 deficient tumors, malignant rhabdoid tumors, and epithelioid sarcomas. In contrast, the fusion positive myoepithelial tumors with these alterations, they formed again distinct cohesive cluster similar to our analysis. So my basically last slide. How about the nomenclature? I think we are in agreement with Josephine that there is quite a mess in the nomenclature today, because basically the plug-1 rearranged the mixed tumors. They are always superficial. They are intimately associated with apocrine sweat glands. They show very consistent myoepithelial phenotype, and there is a morphological and genetic overlap, almost perfect, with salivary gland myoepithelial tumors. So I think we would argue that these are true myoepithelial tumors. They have mainly association with physiologically present myoepithelial structures. In contrast, the soft tissue and bone myoepithelial tumors with EWSR1 or FUS fusions with those variable fusion partners typically arise in deep soft tissues or in bone or in visceral locations, so there is no association with normal myoepithelial structures. And there is a much less consistent myoepithelial immunophenotype. Sometimes, again, all the myoepithelial markers are negative. Also importantly, the malignant cases are routinely called myoepithelial carcinomas according to the WHO. Although they are probably not carcinomas, we think those are basically fusion-associated sarcomas, and this might lead to inappropriate treatment. So we would suggest a change in nomenclature, perhaps something like EWSR1 or FUS, I don't know, PBX1 rearranged, myoepithelial-like neoplasm or sarcoma if it's apparently malignant. So I think that's up to discussion. And I'm running out of time a little bit, so I'll leave this slide for you to go through if you want. It's like the most important key features, and I'm ready for questions. Thank you.
Very nice talk. Do we have any questions? We maybe have time for one question.
Make a comment. Thank you, Michal. Very nice series, well characterized. I fully agree. I think the black one alters. These are true mixed tumors, and we know that in the salivary glands, pleomorphic adenoma and myoepithelioma cluster exactly the same group. So it is even will be revised maybe in the future in the salivary gland to omit the term myoepithelioma or to put them in the same category. And these are always associated with the skin adnexal, so they are salivary analog skin adnexal neoplasm, while the others are fusion-driven with aberrant myoepithelial-like phenotype. The question is, are myoepithelial carcinomas sarcomas? I think this is a justified question because we see the phenotype in extraskeletal myxoid chondrosarcoma. They have myoepithelial-like phenotypes. Many are called sarcomas. OFMT are myoepithelial-like. They are called sarcomas. So at the end, I think these are not epithelial in sensu stricto, but they are sarcomas with ME-like phenotype. That would be a better terminology for the second group. The first one, I will go for the salivary approach.
Yeah, we are in agreement, basically. Thank you. Any more questions? Or do we have time? Probably not.
I think probably not.
Okay, thank you. So yes, that's it. So we meet in half an hour at 4:20. Thank you. So once again, hello everyone. Welcome to the last session of today. We have 4 talks. The moderators are David Suster and Karen Fritchie. So please take it over from here.
Is this working? All right. Thank you everyone for hanging in there. Some people are still filtering in, but we're just going to move forward. So the first talk is going to be given by Professor Abbas Agaimy from Germany. Abbas, are you here? He may not be here. Would you like me? Okay.
Oh. Okay, change of plans. So.
Wait. He just walked in.
Never mind.
Okay, ladies and gentlemen, Dr. Agaimy.
So thank you very much. Again, my second and last part in this interesting meeting. Indeed, this topic has been very overlapping with many others, so at the end, I have to skip some slides because they are already discussed or they are going to be discussed today or tomorrow. And just a general overview. mesenchymal neoplasm in the head and neck are very special in that we have very specific entities that usually present almost exclusively to head and neck pathologists or to soft tissue pathologists doing head and neck as well. And some of these are restricted to the head and neck area. We'll give some examples. Some of them are showing striking predilection for the head and neck area. This means almost more than 2/3 or 3/4 of cases are seen there. And then we have neoplasm with moderate or variable predilection to the head and neck, in which we see maybe up to half of the cases in that location. Common to this neoplasm as a category or a family of lesions is that they are all individually rare to very rare, and most of them have odd immunophenotypes, and many of them are gene fusion associated. This is the new WHO classification of head and neck neoplasm, and we see that, as always, now for all organ systems, the soft tissue or the mesenchymal neoplasm have been removed from the different locations and put into a common chapter at the end. There is only one exception, and that is for entities that are seen in a specific location exclusively. For example, B phenotypic sinonasal sarcoma cannot be put into this list, but it is included in the sinonasal tract, as well as glomangioperitocytoma and some other special entities. We see here that we see for the first time 2 newcomers. One of them is new indeed, one is old but has not been listed before at this site, which is phosphaturic mesenchymal tumor, and GLI1 altered neoplasm are included now also among the list of soft tissue neoplasm in the head and neck. These tumors, as said, that are restricted or only seen in the head and neck are very rare to rare. Most of them are genetically defined. They are diagnosed in occasions readily by morphology alone, with or without supplementary immunohistochemistry. In difficult cases, they can be solved by molecular testing, but that is not always necessary in some scenarios. And they are, of course, challenging molecular cases in some occasion. As I said, they do not follow a specific line of differentiation in that we just go directly to call it rhabdomyoblastic or epithelial or myoepithelial, but we have, as we have seen through the day-to-day, just an admixture of myoepithelial-like or rhabdomyoblastic-like. That might be another terminology for some of these tumors. And of course, very rarely we have seen analogous tumors that may occur at other sites, although they are almost exclusively head and neck. An example of these restricted tumors in the head and neck, ectomesenchymal chondromyxoid tumor, which is by definition a tumor of the anterior tongue, mostly or exclusively in the tongue area, but it can occur on the margin of the tongue, rarely on other subsides on the tongue or the dorsum of the tongue, and so on. Sinonasal B phenotypic sarcoma as fusion-driven and sinonasal glomangioperitocytoma as beta-catenin altered neoplasm are strictly and by definition sinonasal in location. This is just the overview of the main key information about ectomesenchymal chondromyxoid tumor of the tongue. This is really very rare entity, and if you are aware of it, it is not difficult to diagnose because of the specific site, and the morphology is also very impressive, although the immunophenotype is very confusing. Less than 100 cases have been reported to date, mostly in adults with a median age of 32 years, and they are, as most head and neck lesions, painless nodules, so there is no specific clinical symptoms. Some of them have been present for many, many years, and local recurrence is there. You see here 10% of cases may recur locally, but they are not destructive and they are not metastasizing. And the immunohistochemistry is also, again, myoepithelial-like. So we have expression of GFAP, variable cytokeratin, S100, SMA. Desmin is usually negative, as well as rhabdomyoblastic markers. You see here an example, the very classical squamous mucosa on top of it, and then we have this hybrid pattern of pale and pink. This is very characteristic, and if you look exactly, it is well demarcated from the mucosa, it is not encapsulated, and usually we have some called Grant zone between the mucosa and the lesion, so it is not approaching the epithelium. Here, at higher magnification, again, two different classical patterns. One of them is microcystic-like, as you see here, myxoid with monotonous hyperchromatic ovoid cells, and then we have these hyalinized myoepithelioma-like posticellular areas, or maybe even chondrohyaline or chondromyxoid looking, as in pleomorphic adenomas. And this is the most frequent misdiagnosis for these tumors. If one is not aware, we'll call them pleomorphic adenomas. Usually, examples of the immunohistochemistry highlighting the heterogeneity, at the same time highlighting the very distinctive architectural pattern. Here you see GFAP showing the extensive sieve-like microcystic reticular growth pattern. S100 and keratin are positive as well. And of course, recently these have been studied by molecular testing here. Nice study by Justin Bishop and Brendan Dixon, and you see that indeed all cases have the same fusion RREB1 MRTFB or former MLK2 fusion. There are very few exceptions with other fusions, I think, that are not genuine cases in this spectrum. So this is just to these entities. And recently, we published a series, Cristina and me, and others as collaborators, on tumors showing exactly the same fusion, but occurring at extraglossal regions. These were also including previously reported single cases in the literature, so a total of 10 cases have been reported at non-glossal locations, and 60% of them are head and neck sited, so it is still remaining a head and neck entity, parapharyngeal mostly, and very rarely sinonasal, and they have very similar or comparable biology as well as comparable morphology and immunophenotype, but they tend to be much larger, more cellular in some areas. Here you see also microcystic degeneration in some of the cases, or the alternation of hyalinized and less hyalinized or myxoid areas. So they overlap morphologically with the cases we just have seen, but we don't know exactly how to call them. Now we put a descriptive name, as you have seen. B phenotypic sinonasal sarcoma is initially a morphologically and phenotypically defined entity reported from the Mayo Clinic many years ago, almost 20 years ago, in a large series of cases as myoneural low-grade spindle cell sarcoma, because it has S100, this is the neural component, which is not really neural, and myo because it has some myogenic features with SMA, desmin, and even occasionally rhabdomyoblastic features. And it is officially included in the previous WHO classification as an entity, or PSS. And you see that again, females are 3 times more frequently affected than males. The median age 52 years. Mostly they are multi-site involving neoplasm with sinonasal nasal cavity or sinuses, skull base, frontal sinus. Many of these, even some cases, may extend into the cranial cavity if they are growing for a long time. But again, no specific symptoms. Polyposis-like nasal obstruction and occasional bleeding are the main symptoms. They have a recurrence rate that is comparable to glomangiobarycytoma, so half of cases may recur. No metastasizing cases have been reported, except for very rare occasion when such a low-grade sarcoma transforms into a high-grade rhabdomyosarcoma, which has been reported in one case by Dr. Michal and others, and historically has been always misclassified as low-grade MPNST. Bland-looking spindle cell proliferations with variable cellularity. They range from very posticellular and to reactive looking to highly cellular fibrosarcoma-like or MPNST-like sarcomas. They have a very distinctive feature, which is the entrapment of prominent hamartoma-like hyperblastic epithelial glands and invagination of the surface epithelium into the lesion. And the immunophenotype is, again, very heterogeneous with myogenic-like, neurogenic-like, or myoepithelial-like, and mitotic activity usually is very low, and no necrosis is seen. This is one of the classical examples. Indeed, you can make diagnosis as this magnification. Really, you see a moderately cellular spindle cell neoplasm surrounded by papilloma-like hyperplastic invaginated glands. This is very prototypical appearance. However, we have sometimes variant histologies, and especially in smaller biopsies, it depends on the extent of biopsy. You may see something like this with dark stained, very cellular fibrosarcoma-like areas alternating with hypocellular myxoid-looking areas, which is one of the causes why these tumors in the past were called low-grade MPNSTs, because this alternation and zonation is well known in MPNST. We have also sometimes fibrosarcoma-like very cellular fascicular growth pattern with increased mitosis, but always looking like something blunt, despite the high cellularity. And this is the most challenging variant, which is very paucicellular, and it looks like either inflammatory polyp or respiratory epithelial adenomatoid hamartoma. So you have always to look exactly at the stromal component. The immune phenotype is heterogeneous as well. You see expression of S100, not in all cells, not block type, SMA and Desmin variable, and sometimes in well-oriented specimen you see it is an oriental zonation, so those neurogenic-like areas lack myogenic features, and the reverse is true. Beta-catenin may be positive in the nuclei of some of the cases, but it is not a reliable diagnostic marker. Of course, the differential is mostly defined by the cellularity, by the pattern you see in a specific case. However, genuine neurogenic neoplasm and melanocytic neoplasm are the two main considerations. Melanoma is usually very high grade looking, you see on the left, and usually very diffusely positive for SOX10. So it is always advisable when you see something unusual looking, S100 positive, always go for SOX10. If it is negative, this is mostly a fusion-associated neoplasm and not a melanoma and not a neurogenic entity. And you see here classical sinonasal schwannoma on the right with diffuse block type S100 expression, bizarre-looking hyperchromatic Schwannian cells as well, which is very rare occurrence at this site, but you see occasional cases. This is an example of SFT in the sinonasal tract that presented as a very unusual polyp you see here, composed of intimately admixed cystic glands, just like a hamartoma, and in between we have a monotonous spindle cell proliferation that is uniformly STAT6 positive. So this is what we call hamartomatous SFT, or SFT with hamartomatous associated glandular proliferation. This is not that rare in the head and neck if you see a lot of head and neck cases, especially in the sinonasal and nasopharyngeal area. The genotype is not very complicated. Most cases have mammil3 fusions, but they may be fused to PAC3 or sometimes to NCOA1 or FOX1, but really most cases are mammil3 fusion positive. The next topic or entity I like just to touch, we spoke about today in the slide seminar in the morning, is FUS and EWSR1 POU2AF3 or Colca2 fusion sarcomas. This was a very aggressive entity that we recently described and then followed by two different series. So it has been confirmed in a total number of now reported 19 cases. Very strong predilection to the head and neck, and among the head and neck sites, very high association with the sinonasal tract. Also disease of adult, and half of cases developed recurrence or metastases, so it is not benign, but more aggressive entity. Again, very heterogeneous morphology. We have some prototypical pattern, but we have really highly varying morphology. This is the most classical pattern you see here. We have undifferentiated looking, sometimes Baumhoer-like, primitive looking round cell sarcoma, variably myxoid, and in between you have these dark stained, clustered, pseudo-cohesive basaloid aggregates. This is a very classical and almost pathognomonic feature at this site, I would say, because in other organs you may see in carcinosarcomas, something like this. However, this is very variable. We see other areas that look like undifferentiated round cell sarcoma Again, here, even in this case, you see these blue stained, dark stained, small areas, and sometimes genuine epithelial differentiation with gland formation, pseudocrib reforming. We have seen cases that are up to 90% of their components are just gland forming. So I think there is some analogy to the epithelial type synovial sarcoma in which it can look like an adenocarcinoma. Still, we accept it as a synovial sarcoma, and I have seen 2 examples of this entity really looking like adenocarcinoma with very subtle mesenchymal component in the background. It is very, very heterogeneous. Sometimes we have some osteogenic foci or rhabdomyoblastic elements, again, which is a very frequent feature in these tumors. Another pattern that we have seen mostly in the series composed by Michal, you see here angiomyxoid or myxoid primitive looking areas alternating with completely different areas, sometimes even very pleomorphic cell population in the background, those high cellularity. So it is really very heterogeneous. So you cannot pick it up with all these patterns, but the most typical one is the first one I showed to you, is very suggestive of that entity. I will skip the adamantinoma-like Ewing sarcoma because it has been detailed and discussed today. The only thing is that you have to consider sometimes some cases have been initially called large cell neuroendocrine carcinoma. So if you see something is neuroendocrine-like and neuroendocrine marker positive and squamous immunophenotype positive, this is most likely going to be adamantinoma-like Ewing sarcoma. Again, we heard a lot about this anti-EWSR1 fast fusion associated sarcoma, rhabdomyosarcoma, which we call like that with TFCP2 fusion. Again, we have heard all of the details about that, and I fully agree with Carina. Some of them, many of them really are very bizarre looking pleomorphic. This is a sinonasal polypoid lesion that came just like a nasal polyp here in a young female. It looks very monotonous, not fitting really any entity. And rhabdomyoblastic features are morphologically very subtle or absent, but sometimes they can be very clear, as in the series published by Cristina. You see here even some of the strap cells here are seen in this example, a rhabdomyoblastic epithelioid or round cells as well. Cytokeratin ALK, very, very positive as a good clue for diagnosis, of course. Again, we have seen this paper and detailed information about the VGLL3 fusion spindle cell low-grade myogenic neoplasm that we are pushed to call it rhabdomyosarcoma, as I told. And very interesting to see that half of the case, now this entity has been only described in the head and neck. I think the first case was published by Dr. Rosenberg and the group, and 50% of cases are lingual, and very interestingly to see that all 4 cases with EP300 as a fusion partner were in the tongue. So this is a very interesting association. You see here the table, you have seen this before. So until now, we don't have any information or evidence that this can behave aggressively, so we have to await more cases. And again, we have to await the most appropriate terminology, how to call them. You have seen this image as well from the tongue. And you see here again how desmin is very positive and the lesion in the tongue is invading between the skeletal muscle, separating it apart, sometimes as a lobule or a checkerboard pattern, and very blunt cytology, ovoid, monotonous cells, no mitosis, no pleomorphism, no necrosis at all. This case had really no evidence of rhabdomyoblastic transcription factor expression. Gli1 fusion neoplasm and amplification neoplasm, I will skip them because they have been touched today, and I think Dr. Papke will also expand on that. I just like to show you something that is important because this is really a head and neck entity, and I'm speaking about mostly the amplified cases, and I put this table to show you this very striking and interesting anatomical association. We see the amplified cases mostly in head and neck and acral sites, almost equal frequency, almost never in the abdominal cavity. Last week I have seen the first intra-abdominal case of a Gli1 amplified neoplasm, and it seems that indeed, as we have seen also in the plaque-1 associated myoepithelioma, again predilection for head and neck and acral sites, so the head and neck seems to be acral, or the acral sites are head and neck sites. I don't know what is the relationship, but this is interesting. And you see here this illustration from Christina's papers in the tongue. The tongue is the most typical location for amplified cases. This is a low power diagnosis. You see a well-demarcated, not encapsulated, extensively multinodular, plexiform, growing lesion. So this is in the head and neck, not compatible with any other entity even. We don't see this in glomus tumors, which we see in other sites maybe, but not in the head and neck. So this is a low power differential diagnosis that you can recognize really immediately. This is an example of our own cases. A pediatric patient came initially with convulsion, and they found multiple cystic bleeding foci in the brain, and then they found the primary tumor in the head and neck or in the neck area, and they indeed took a biopsy, and it was GLI1 amplified. So the amplified cases really are much more aggressive behaving. This is the same case. You see brisk mitotic activity, even maybe possibly some atypical mitosis, as you see here, and this very vascularized stroma in the background and epithelioid cells. Again, the immunophenotype is very impressive. You see that STAT6 and CDK4 are very positive with nucleocytoplasmic pattern. MDM2 is more wide or far away from GLI1 locus than this gene, so it is usually or infrequently co-amplified, and even if it is, you see sometimes single cell amplification or expression and not the same as for CDK4. This is an image from Cristina from that case, confirmation of the amplification by fish. The differential is very limited. Glomus tumor is very rare in the head and neck. We see very few examples in the oral cavity or in the salivary glands. They can be, of course, multinodular, plexiform, but you see the very distinctive glomoid morphology. Collagen 4, SMA, caldesmon are positive. But, of course, we know that most cases of early GLI1 fusion cases, they have been miscalled glomus tumor. So when I read in the cover letter recurrent glomus tumor 7 or 10 years later, it is very likely to be a GLI1 fusion neoplasm. Pseudoendocrine sarcoma will be also detailed, one of the differential diagnoses, of course, here. And then to give you very few short notes about phosphaturic mesenchymal tumors, and it is very interesting to see that we have a couple of FN1 fusion associated mesenchymal neoplasm. Most of them are associated with this distinctive or peculiar granular or grungy matrix formation, irrespective of the histologic subtype. And this is a very important diagnosis because patients frequently are handicapped or they are immobile for years until diagnosis is rendered and the tumor, which is usually not very big, has been removed. So this is one of these important points to emphasize. Up to 20% of all PMTs are head and neck sited, which is an important information, and 80% of them in the hard tissue. This means in the craniofacial bones, 20% in soft tissue, and 76% are extraoral. The remaining are intraoral. The paranasal sinuses are the most common extraoral sites involved, and female are slightly more affected than males. The mean age is 46 years, and we know that these tumors have a distinctive local recurrence rate up to 20%. Metastases are uncommon or rare. They may metastasize to the lung, to the soft tissue, to the bone, of course. The only problem with head and neck PMTs is that they tend to show variant morphology. So you don't see the classical grungy matrix, etc., as you see in soft tissue and bone in other peripheral locations. So it usually looks like glomeangioperycytoma or hemangioperycytoma or SFT with some GAN cells. It looks sometimes like neuroendocrine. As you see here, this is a sinonasal mass. Looked really very much like glomoid neoplasm. And of course, one of the pitfalls, and indeed that case came initially with the suspicion of osteosarcoma clinically. I don't know why. And they said it is growing very rapidly. I said I can't understand that rapid growth because this is a very low proliferating neoplasm. And I stained SAT-B2 at that time because of the clinical question about osteosarcoma, and it was very positive. Then I have no idea if this is acceptable. Then at that time I had, I think, some 10, 15 cases from Michal on my table, and I stained them. All of them are SAT-B2 positive. So we published that at that time, and we know they are SAT-B2 positive. This can be confusing, but it is usually a helpful marker if we have problems. This is another example from our neuropathology department in Erlangen. This case came to me with the suggestion of neuroendocrine-like composite hemangioendothelioma because it looked very vascular or pseudovascular and indeed expressed diffusely but weak ERG and podoplanine. So they said both markers are vascular markers, and we know that, of course, both these markers are frequently expressed in PMTs. The only clue to the non-vascular origin is this intensity of ERG. ERG in PMTs equals the intensity of normal cartilage, which is very weak nuclear. We don't see the very strong endothelial type expression. And indeed, you see here in other areas this classical bluish bone formation or matrix, and the case was confirmed by serology then and by molecular testing. So this is an example of pseudovascular pattern in phosphaturic mesenchymal tumor in the scalp or in the head and neck area. Calcifying chondromyxoid mesenchymal neoplasm will be touched, I think, by John Gross, if I were not wrong, and this is again a predilection for head and neck. If you look at the initial series, 6 cases were acral, 6 were temporomandibular joint. Again, the foot and hands and the head and neck are the same in many, many entities. I will not go into details of that. So take-home message, we know that mesenchymal head and neck neoplasm are a special group of rare to very rare entities. Most of them have defining molecular features, but we do not need always to look for molecular testing. Most are low-grade to intermediate, with the exception of TFCP, rhabdomyosarcoma, the most aggressive type. Other entities are mostly low-grade or indolent. Many of them are locally recurring, non-metastasizing. And we have an odd immune phenotype in most of them, so there is no way to just to stand for a specific marker to tell you the entity we have seen with rhabdomyosarcomas, TFCP fused. We have to look for keratin, ALK, and desmin, and so on. And so familiarity with them is the key for diagnosis. And if we consider a high suspicion index, demographic features, and all other clinical factors, the differential list is really very, very low. Like we see a monomorphic spindle cell sinonasal neoplasm. Usually we don't have more than spindle cell rhabdomyosarcoma or P-phenotypic sinonasal sarcoma or another entity. It's not really more than 2-3 differential diagnoses. And if we look at these entities, we see that many of them have variable aberrant expression of keratin as well as rhabdomyoblastic markers. So we have to agree or to accept the current terminologies, but they are not really always well understandable, but these are what we have. I think this is the last slide. So I recall what Dr. Azobardi has said. You don't call any tumor benign or malignant if you don't know exactly what it is. We have seen some example of bland-looking TFCP-associated rhabdomyosarcomas that are very aggressive but look very bland histologically, so we have to be very careful. Thank you for your attention.
Thank you very much. We have time for a handful of questions. About 2 minutes worth of questions.
Thank you very much. It was excellent. What are your thoughts of biphenotypic being analogous to the VGLL gene fusion skeletal muscle tumor? In other words, you think that could be a low-grade rhabdo or, a locally aggressive skeletal muscle neoplasm?
I think the VGLL3, I would call the VGLL3 fusion neoplasm, I would call it low-grade. And as said, I really am not convinced these are uniformly rhabdomyosarcomas. Maybe we have to seek the help of Daniel to see really where they are clustering. So
what about the biphenotypic being an analogous or, not the same, but related?
Yeah, the biphenotypic, they differ in terms of frequent S100 expression compared to these VGLL3 myogenics, and they they are defined mostly by mammal3 fusion. So they overlap, of course, even genetically in rare cases. Exactly.
I'm just saying it as an entity being low-grade skeletal muscle tumor.
I think this is very possible, but we don't
Okay.
have a good name. But
Yeah.
they
Okay.
have rhabdomyoplastic features as well.
And PAX3 and the
Yeah.
fusion protein
PAX3,
is similar to that
FOX1,
in alveolar.
Yeah. So all these genes are rhabdo genes, of course,
Yeah.
but they have very subtle rhabdomyoplastic elements. Of course, they are PAX7 and many other PAX family proteins positive. So it looks like rhabdomyoplastic neoplasm.
Okay,
Yeah,
thank you.
Thank you.
Abbas, I have a question for you. On the GLI1 tumor that you showed, the MRI looked like it had a fluid level. Is that something that's relatively common specifically with GLI1 tumors? Because there's not a lot of soft tissue things that show that.
This is a very good point. We don't know exactly. These were metastases that were bleeding. So the time point, they have a solid component and a larger, much larger fluid-filled bloody component on MRI. And indeed, that patient was 14. Now I think she is 17 or 18 already, and is being presented until very recently regularly in our pediatric oncology tumor board. She is doing still well. She had resection of the primary chemotherapy. The CNS metastases disappeared completely, but still she had the lung metastases, and she's alive with disease under some type of chemotherapy or maintenance chemotherapy. And I think I don't know why specifically these CNS metastases were bleeding. I have no idea or experience with other site of metastases if they usually tend to bleed, but we know that they are very vascularized. They have this very capillary-rich stroma in the background, may be one of the causes. And I think the symptoms even were related to the bleeding more than to the metastases themselves because they are relatively small. But the cyst was very, very big. And after chemotherapy, even the cystic component disappeared. So that was very interesting to see.
Thank you very much. Okay, so I think we'll move on.
Okay, so the next talk is thoracic mesenchymal tumors and their mimics, and this will be given by Dr. David Schuster, who's from Rutgers University in New Jersey in the United States.
All right, thank you. All right, thank you very much. I will try to get through this on time so I'm not thrown out a window, as was explained to us last night. So I'll be presenting on thoracic mesenchymal tumors from Rutgers. I'd like to thank Michael as well as the course organizers for putting this amazing event together, and to all the attendings and all the expert faculty that's here. This is quite incredible. So we'll get started. Mesenchymal neoplasms of the thorax are relatively rare. They comprise about 5% of mediastinal tumors and 1% of lung tumors overall. So these are infrequently encountered. Thoracic mesenchymal tumors also cover a very wide spectrum of histology, and you can see this figure over here. It's the classic picture drawing from Netter's anatomy, and it shows the thoracic compartment. You can see how many different organs there are in there. So you have multiple different tissue types, muscle, bone, cartilage, nerve, fat, fibrous tissue, vascular tissue, and multiple different organs that can all give rise to different tumor types. So trying to cover thoracic mesenchymal tumors is almost essentially like covering all soft tissue tumors. However, there are some, you can see the list on the far right. I kind of just threw this together. I realized it was an incomplete list. I even had to add a little box on the bottom left with additional things that were embarrassingly left off when I made the first version of the lecture. A lot of these tumors have, they may not be entirely restricted to the thorax, but some of them have either special histologic presentations or a predilection or were first described and or are associated with the thorax. So I've highlighted some of those here. Now, given that I can't go over 30 plus entities, I'm gonna give just some general thoughts on what I think of when I'm encountering a soft tissue tumor in the thorax, whether it be bone or or a soft tissue location. And then deep dive into just two sort of thoracic specific entities. So, I title these common mesenchymal tumors, but common is a relative term, right? All of these are pretty rare overall, so you don't see them all that commonly. But within the scope of this particular talk, they're common, okay? Compared to other tumor types. So one of the first things is solitary fibrous tumor. I'm not going to spend too much time in here because people are so familiar with this, but this is a fibrous tumor of variable malignant potential characterized by this NAB2 STAT6 fusion, and you can use STAT6 IHC as shown here to usually relatively easily make the diagnosis. In the soft tissues, when you're dealing with mass in the thorax, another thing you should always consider is synovial sarcoma. Shown here is a diaphragmatic synovial sarcoma that was sort of growing out of the pleura. You can see it kind of has this, excuse me, right in here. Well, we don't have the little hand, but you can see that sort of like relatively well circumscribed brownish tumor. It's kind of an expansile lesion. And we have, new markers for this, the so-called next-gen IHC with SS18 and SSX that can be very helpful for these tumors where you don't have to go too crazy with the molecular genetic testing to diagnose them if you have the sort of appropriate histopathologic features. Other soft tissue tumors that are relatively commonly spring up in the thorax are peripheral nerve sheath tumors. Almost overwhelmingly, the benign versions of these are shown on the left panel from the right figure, which is a conventional schwannoma. These tumors are characterized by strong S100 SOX10 positivity, bland appearing spindle cell growth, and they tend to retain H3K27Me3. There is, of course, also the malignant counterpart, and these can arise off, the nerve sort of chains that run through the thorax, and that is malignant peripheral nerve sheath tumor. Some other people have mentioned those a little bit here today already. These commonly lose S100 and SOX10 positivity, and will also commonly have loss of H3K27Me3. And if you do take these two molecular testing, they're characterized by NF1 TP53 and SUS12 EED mutations. So those are the sort of the things that first spring to my mind for soft tissue tumors in the thorax. Obviously, there's many other things that were listed on that list. Now, the thorax contains a whole bunch of bony and cartilaginous structures, including the ribs and the spine. So there are some sort of bone tumors that are also will pop up in this location. Although relative to bone tumors in the rest of the body, these are relatively rare. But one of the things that always pops in my mind is fibrous dysplasia. This is a benign fibroosseous lesion. It tends to have a predilection for ribs in the thorax. So you can see it over here on the left side. This grows right here as an expansile region. So it's a little bit hard to see for me, but there is still sort of like a peripheral thin rim of bone, indicating that this thing has been growing slowly. It shows the classic histology, and these have GNAS mutations and are, in some cases associated with McCune-Albright syndrome. Chondrosarcoma and osteosarcoma are, benign malignant cartilaginous tumor and malignant bone-forming tumors. Both of them can arise in the ribs. You can see on the radiologic images here, they tend to have more destructive growth pattern with, this sort of, you can see a little bit of the residual rib over here. Chondrosarcomas have internal mineralization or matrix formation. So do osteosarcomas, but it tends to be a little bit more overwhelming. And these, they have aggressive radiologic features, so they're a little bit easier to distinguish from fibrous dysplasia. Chondrosarcoma is characterized by IDH mutations. Osteosarcomas have a relatively complex genetic background, frequent P53 mutations. And one other thing is Ewing sarcoma. So that's another thing that I think of when I'm dealing with any sort of round cell tumor, and it's involving the pleura, the mediastinum, or the thorax, or the lung itself. And these are pretty classic. We don't have to spend too much time on them, but they're often very large lesions. They can replace entire lobes of the lung, as seen here. Dr. Antonescu gave us a beautiful sort of review of these earlier today, characterized by EWSR1 fly fusions. And of course, the differential in here is all the other round cell, like fusion-driven round cell sarcomas that we have discussed today. Those can occur in the thorax as primary tumors as well. So the differential continuously is expanding. So that's a brief overview of, like, sort of in my mind what I conceptualize as like common things that pop up from the mesenchymal side. Now, I do want to spend a little bit of time on two sort of evolving, relatively recent entities over the last 10 years. There is a little bit of controversy perhaps related to these. The first is primary pulmonary myxoid sarcoma, or PPMS, and the second is the SMARCA4 family of tumors. Okay, so PPMS. This is a rare low-grade myxoid sarcoma of the lung that harbors EWSR1 CREB1 or ATF1 gene fusions. It was first described by Nicholson and his group in 1999, and then the term PPMS showed up in 2011, a few years later, by Thuy et al. So this is a myxoid sarcoma. It's primary in the lung. There's a lot in the differential for this. That includes the myxoid variant of angiomatoid fibrous histiocytoma, metastatic EMC or extraskeletal myxoid chondrosarcoma, a spectrum of EWSR1 rearranged tumors, including myoepithelial tumors / myoepithelial carcinomas, and so-called pulmonary tumors with notochordal differentiation. And these are very rare tumors. There's less than 50 of them reported in the literature right now. So I'm going to show a couple examples of this. This is the first case, so this is low power magnification. You can see this is an endobronchial lesion. We have a little bit of bronchial cartilage here, and you can see that epithelial lining around the outside, and then you have this sort of polypoid tumor growing in here and growing down in here. And from this power, you can see it's got this sort of, it's relatively cellular, but it's got a myxoid character to the stroma. When you look at this on slightly higher power, you see that you have this bland population of small spindle to sort of ovoid cells. Sometimes they almost look like they're lining up end to end, similar to what you see in extraskeletal myxoid chondrosarcoma. So you could imagine how those things are on the differential with each other. Now, this is another example. And again, you can see it's an endobronchial location. This is probably closer to the main stem bronchus, given the size of this piece of cartilage here. And you can see that there's a relatively well-circumscribed tumor. There's maybe a small peripheral cuff of lymphoplasmacytic inflammation, and then a vaguely nodular tumor. When you look at this on slightly higher power, again, you see sort of those vague nodules of these almost histiocytic-looking cells and the lymphoplasmacytic inflammation. If you look on very high power, it almost looks like an inflammatory myofibroblastic tumor. This is a more solid area. These things tend to have less of the angiomatoid areas, but this tumor here looks pretty good for what is some people call like the sort of visceral angiomatoid fibrous histiocytoma, or visceral AFH. Now, this is another tumor, and this is a courtesy. This was a case sent to me by Dr. John Gross, so thank you to him for letting me use this slide. This was another AFH type lesion in the lung. You can see again, there's a little bit of peripheral lung up here. It's very edematous and hemorrhagic, but you have that peripheral cuff of lymphoid inflammation. And then again, this kind of vaguely nodular tumor over here. And when you look at this thing on higher power, a lot of it looked like just conventional AFH, but there were some areas where it really did have a myxoid background. Again, you get those small little cells. They kind of like line up end to end. So you wonder, so when you're looking at something like this, you wonder, like, are these overlap tumors? Like, are these all on the same spectrum? Are they the same entity? This has kind of been looked at a little bit, and this study shown down here was pretty good by Yi et al. So PPMS, and there's some slight differences between so-called visceral AFH of the lung and primary pulmonary myxoid sarcoma. Still may represent the ends of one spectrum, but PPMS tends to be more myxoid and less inflammatory overall. All of the lesions in the lung tend to be like pretty low-key on the angiomatoid areas. The CREB1 is more common fusion partner in PPMS, while ATF1 is more common in the myxoid AFH variants. And AFH more commonly Desmond positive, whereas the things that have been diagnosed as PPMS are almost universally negative. And the PPMS tumors are allegedly slightly more aggressive with a slightly higher rate of metastasis, but there's been very few studied overall, so we don't have great data there. And the whole thing is complicated by the fact that there's been other things, myxoid sarcomas or PPMS-like myxoid sarcomas that have no EWSR1 gene rearrangements and have like loss of INI1 and other molecular alterations. That was described and reported by Abbas. So this picture gets a little complicated. So what do you do with these tumors? They're relatively low-grade / indolent lesions. They usually tend not to metastasize. And I'd love to hear the thoughts from the other people who signed these cases out, even with consideration to how rare they are. But I tend to the few that I've had across my desk, I've signed out as primary pulmonary myxoid sarcoma, either in parentheses, myxoid AFH, if it has those features, or in the comment I will mention all of this that I've just gone over, that they may represent the same entity. All right, so moving on to the next sort of deep dive is SMARCA4 deficient thoracic tumors, undifferentiated thoracic tumors. So these are essentially these high-grade tumors that were initially characterized as or reported as sarcomas. They have a predilection for the thorax, although some SMARCA4 deficient mesenchymal tumors have now been described outside the thorax as well. But this seems to be a relatively discrete thoracic entity with some discrete clinical pathologic features. And they're characterized by alterations and loss of function in the SWI-SNF complex, which is shown here in this little graphic from one of these papers. And you can see this was like before we started calling them tumors or possibly carcinomas. But you can see that there's multiple different protein subunits in this complex, including things that we are very familiar with, such as SMARCB1, SS18, and SMARCA4A2. So these commonly show SMARCA4 loss, usually with SMARCA2 loss as well, but not in every single case. So this is what the histology for these look like. They're very poorly differentiated or undifferentiated tumors. You couldn't really pin this down as anything. High mitotic activity, kind of eosinophilic, voluminous cytoplasm. If you look hard enough, in some of these cases, you can actually find like vague nested-like areas. If you're lucky, you'll have a frank transition from a non-small cell component, like an adenocarcinoma that goes into a SMARCA4, a sort of undifferentiated morphology. And that can be very helpful for the diagnosis. But sometimes the carcinomatous-like areas are just these sort of nested, like little, vaguely epithelial spots. They can have, and then, the easiest way to diagnose them is with the use of, BRM or BRG1 immunohistochemistry that'll show loss of absence. And you can see here there's nice internal controls. Make sure to always check those. But, all of the tumor cells are displaying loss of this because you have loss of that SMARCA4 gene. These tumors commonly will show areas or be entirely rhabdoid, and that's one of the first tip-offs that should jump to your head. If you're dealing with a thoracic tumor that is entirely rhabdoid, you have to have these SMARCA4 tumors on your differential, in addition to other rhabdoid tumors, but you don't want to miss that. They're frequently very high grade, high mitotic activity, areas of necrosis are clearly visible down here. So anything that looks plasmacytoid or rhabdoid, you have to check those, okay, for SMARCA4. Now, one other thing that's actually quite interesting is this was a recent case we had that was sent to us as, from the outside, as metastatic hepatoid adenocarcinoma. So you can see here there's these large epithelioid cells, voluminous eosinophilic cytoplasm, maybe a hint of, sort of rhabdoid morphology right there. And it was diagnosed carcinoma appropriately. There's MOC31 positivity. There's a little bit of cytokeratin. This was from the lung. TTF1 was then negative. And then interestingly enough, they had sent it with a hepatocyte-specific antigen. That was strong diffuse positivity. And then it ended up on my desk. And because I had read Abbas's paper where they described this phenomenon, other liver markers will be negative, but for some reason these SMARCA4 undifferentiated tumors tend to have positivity for HepR1. So keep that in the back of your mind. And there's some literature out there, with overlap between SMARCA4 and hepatoid carcinomas. So the question becomes, are these sarcomas or are these carcinomas? Now, as I mentioned, they were originally described over here as sarcomas, but recent work from Dr. Reckman and the group at Memorial has produced a lot of evidence that says that these are actually just very poorly differentiated or undifferentiated carcinomas. And that's based on a group of patients that had UV-related or smoking-related molecular signatures. Sorry, not UV, smoking histories and cases that had obvious non-small cell lung carcinoma components, transitioning into the SMARCA4 deficient tumor. also focal expression of markers that you see in lung cancer like TTF1. However, it should be noted that there is a small subset of cases that occur in never smokers. They do not have that smoking signature, and they do not involve the lung. They sort of just grow within the thorax as a giant mass, and they have a slightly different pattern of metastasis as compared to the group that looks like it's coming from carcinoma. So you wonder, is there a split here? Is there some that are true sarcomas and some that are just like really poorly differentiated carcinomas, or is it just like the ones that look like sarcomas and behave a little bit differently? It's just kind of another pattern in how they grow biologically. So the differential is very broad for these. Melanoma, nut carcinomas, rhabdoid tumors. There's all sorts of things, and you basically have to sort of systematically work through these when you have these tumors. Okay, so covering the last part of the talk, and I have like a minute, so this is going to be rough. Mimics. In the thorax, you have to consider metastasis, right? Because the lungs, pleura, those areas are very common sites of metastasis. So shown in the top left is an extraskeletal myxoid chondrosarcoma, INSM1 positive. That's not necessarily the diagnostic stain you need, but it's just cute to have. On the top right is this lung nodule, well circumscribed, punched out. This was from a D. diff liposarcoma that had metastasized to the lung. And then bottom left, you can see this tooth like sticking out of the lung, right? It's like this solid mass of bone. So this is just an osteosarcoma. And obviously, when you have the clinical history and you correlate all that, it all makes sense, and they're relatively easy to diagnose. But always rule out metastasis first. And then other things that need to be considered as mimics are other things that are not mesenchymal, but that have spindle cell architecture or mesenchymal features. So spindle cell thymomas, sarcomatoid thymic carcinomas, sarcomatoid lung carcinomas, and sarcomatoid mesotheliomas are all things that need to be considered on the differential, particularly when you're dealing with sort of poorly diff tumors. So these are the sarcomatoid carcinomas can almost have any kind of histologic pattern, anaplastic. They can make bone, osteosarcomatous. The spindle cell thymomas are quite interesting because they're one of the few epithelial tumors that actually grow with this super prominent hemangioparasitic pattern and can almost be confused for GLIDE1 tumors or for solitary fibrous tumors. So those are things to keep in mind. And finally, I'll go over by just a minute, but I wanted to show two cases that I had that came in sort of just at the perfect time that show like, why this is kind of difficult with this differential. So the first was this 48-year-old male presented with cough and chest pain, and you can see here the actual CT scan, and he has a very large sort of, basically anterior mediastinal mass. And they did a core needle biopsy of this thing, and this is the core, right? So you have this spindle cell neoplasm. It has a, almost, maybe very short fascicles, but a very irregular pattern to it. It almost looks like a DFSP or something like that. When we looked at it on a slightly higher power, it had a vaguely neural appearance to it, maybe even a hint of, I don't know, something trying to form a Verroque body. So we immediately pushed a peripheral nerve sheath tumor up to the top of the differential, and then did an S100, and it was dead negative, and then did a P63, and this is just a type A thymoma that happens to have like super neural-looking histology. And then the last case, 30 more seconds, I promise, 55-year-old male. We got a case from the outside that came with a very vague clinical history, but spindle cell carcinoma of the chest wall. And you can see that thing right in here. This was a recurrence. So they sent it to us as recurrent spindle cell carcinoma or sarcomatoid carcinoma of the chest wall. This is the tumor, in the mediastinal fat. Myxoid cut surfaces, pushing border. This doesn't look anything like a carcinoma to me, grossly. And this is what it looked like under the scope. CD34 positive, STAT6 strong diffuse positive. I don't know what led to this getting misdiagnosed, but this is an SFT, in the same location you would expect to see a thymoma or something like that. So keep that stuff in mind, and I'll wrap up. Primary mesenchymal tumors of the thorax are relatively rare. They're actually exceptionally rare, but for people who do only bone and soft tissue, I guess relatively rare compared to extrathoracic sites. They require careful exclusion of like multiple different types of mimics, including thymomas, thymic carcinomas, mesothelioma, and sarcomatoid lung carcinomas. And IHC and molecular testing may be necessary and is usually necessary to separate mimics and to identify specific subtypes. And finally, the clinical history is one of the most important things. when excluding metastasis. So thank you very much. I'm sorry I went over by 2 minutes.
Do we have time for questions?
Maybe one question if there is one. If not, I'm happy to not answer questions. No.
Hey, that was great. Thank you so much. I also practice lung, as you know. And so I think we think mostly that the SMARC A4s are carcinoma, like when they're intraparenchymal in the lung, right? But then maybe, as you mentioned, in the thorax, that's really interesting. Maybe they behave differently.
Yeah, maybe those are mesenchymal.
Yeah, and the B2s are going to be are going to be more sarcoma-like.
Yeah.
But interestingly, in the lung, we do get PD-L1, and it does tend to help, right? Sometimes, and that I wanted to talk to you about that.
We've only had a few of those. The SMARC A4 and like the ones that look like sarcomas, basically, they do tend to have PD-L1, and there is no sort of standardized treatment guidelines for them. But I think what our oncologists are doing are treating with PD-L1 if they have the appropriate, TPS score, CPS score, and if not, they go to chemotherapy. But they tend to respond pretty poorly to both of them. And in the literature, there's some that have responded okay to, Keytruda and pembrolizumab and things like that. But they're aggressive tumors once they look like these undifferentiated sarcomas. Okay, and since I'm up here, I will introduce our next speaker, which is Dr. Karen Fritchie from the Cleveland Clinic, and she's going to give our next 2 talks and close out our day. So here you go. You have.
Okay, hopefully my mic works. Is it on? Sounds good? Okay. So first of all, thank you, Michael, for this amazing course, and especially for inviting me to talk about undifferentiated melanomas, because this is a topic that's kind of close to my heart. And whether you're specialized in soft tissue pathology, it's kind of a hobby and you like seeing the cases, or you're just a general surgical pathologist, I think this topic is actually really practical. And if you sign out with me, like Josephine knows, that when I see a pleomorphic neoplasm, pleomorphic malignancy in an adult, I tell my trainees, melanoma and sarcomatoid carcinoma have to be on your differential. You have to think about them, or else you're going to miss them. So that's kind of the background to the talk. Let's see. And I think Abbas said this earlier. Melanoma has always been known as the great mimicker, and I think that's true now more than ever, especially with more advanced molecular techniques, next generation immunostains like NRAS and BRAF. We're really starting to appreciate the morphologic spectrum of melanoma. So what we're going to talk about today is first talk about the concepts of undifferentiated, dedifferentiated, and transdifferentiated melanoma. And then I'm going to go through some cases and show you the clinical, morphologic, and immunophenotypic spectrum of melanoma. And I think knowing is half the battle. Once you see some of these cases and how sneaky they can be, I think it'll kind of open your eyes to start thinking about these in your own practice. And then we'll talk about some tools that can help you correctly identify these tricky melanomas. So undifferentiated, dedifferentiated, and transdifferentiated melanoma, this is rare and a poorly understood phenomenon in cutaneous melanoma. And not only do they show loss of HMB45 and melan A, but these can be completely negative for S100 and SOX10. And I think that's really important to know about. Not only that, to make things even worse, these can have heterologous differentiation. So they can start to look and stain like things like rhabdos and even osteosarcoma. We think these phenomena are more common in metastasis than primary tumors, but I think that's because it's easier to recognize these when we know the patient has a history of melanoma. Diagnosing a de novo primary transdifferentiated or undifferentiated melanoma can be very, very tricky. So I think that's why they're less common. They're just harder for us to detect. And the biologic mechanisms are still unclear. So in terms of how I think about these tumors, this is an example of dedifferentiated melanoma. You can see that part of the tumor is retaining its conventional immunophenotype, staining for SOX10, but there are other areas of the tumor which are completely negative. So this is what I would consider a dedifferentiated melanoma. This is an example of undifferentiated melanoma. So in these tumors, they lose all immunochemical evidence of melanocytic differentiation. So again, not only they negative for HMB45 and melan A, but they're negative for SOX10 and S100. So as you can imagine, these can be really treacherous to pick up, really hard to pick up. And I think transdifferentiation in melanoma is probably the most fascinating of all these, subtypes. And when I started to dig back into the literature, I found that this Finnish physician, Lori Saxon, actually recognized transdifferentiated melanoma back in 1960, which I think is pretty amazing. He wrote this interesting report in Cancer, and he tried to understand and try to hypothesize how these stem cells can give rise to both melanocytic and heterologous differentiation. And he went on to put together a series of 10 transdifferentiated melanoma, which he published in 1976, which again I think is absolutely amazing. And if you look, I know it's kind of small and hard to read, but a lot of these tumors that he described had heterologous cartilaginous differentiation. So again, he was recognizing these like basically 50 years ago. Now, as Daniel said, we all kind of remember the first case of methylation that opened our eyes and helped us make the diagnosis. And this is the first case that I had, which methylation really shed light on the right diagnosis. And it also, this case that I'll tell you about, opened my eyes to how deceptive melanoma can be. So I think some of you have seen this case before, but I think it really kind of gives you a good take-home message. So this was a young adult female in her 30s, and she had a history of BRAF mutated melanoma on her thigh. And that was a few years ago, and now she presented with a new solitary but enlarging lung nodule. And this was actually the third biopsy because the first two we couldn't reach a definitive diagnosis, so they gave us a lot of tissue. And as you can see here, we have this kind of, these cells with kind of areas with small pycnotic nuclei and lacunar spaces in this kind of blue-gray cartilaginous matrix. And as we look around a little bit more, we see that some of the nuclei are enlarged. And importantly, we can see that there's condensation of the tumor cells at the periphery of the lobules. And if you do bone and soft tissue pathology, you know that this is a really, this feature is better. Okay, so this feature is something we see in chondroblastic osteosarcoma. So when I saw this case, I thought, the morphology, really is reminiscent of chondroblastic osteosarcoma. Some other areas just showed up, high-grade malignant spindle cell neoplasm. There was even some areas that showed some pink early osteoid or areas with some bone matrix. So to me, this really looked like chondroblastic osteosarcoma. But it made no sense for a young patient to have this, extraskeletal osteosarcoma growing in her lung. I thought, this has to be coming from a bony structure. It's either coming from the spine or the ribs. So I went to my radiologist and I asked those questions, and he's like, nope, this is like sitting right in the middle of the lobe. There's no connection to any bony structure. So then I kind of went back to her history, and she has had the history of melanoma. So I thought, is there any way this could be metastatic transdifferentiated melanoma? I did some stains, and you can see that here's a battery of melanoma markers, essentially. And the tumor cells are completely negative for SOX10, HMB45, and MART1. There's focal staining for S100, but if you do bone pathology, you know that normal hyaline cartilage stains for S100. So this tumor was actually staining exactly like I would expect a chondroblastic osteosarcoma to stain, and definitely not staining like a melanoma. Since the patient had a BRAF mutated melanoma, we went and did a BRAF V600E immunostain, and you can see that it's diffusely positive. And to me, this really cinched the diagnosis, especially with her history. And if there was ever any doubt that could this be a second primary with osteosarcoma with a BRAF mutation, we went ahead and did methylation studies, DNA methylation, and on unsupervised clustering, this also clustered with melanoma, and we'll see that a little bit later. So the final diagnosis in this case was metastatic transdifferentiated melanoma. So again, this case really opened my eyes to how sneaky these tumors can be. We're going to go through some other examples just to give you, again, a kind of a big picture of the various morphologies and immunophenotypes that melanoma can harbor. So this was a transdifferentiated melanoma with rhabdomyoblastic differentiation. This was an older patient, sun-damaged skin, and when he presented, he had lymph node involvement. And you can see these malignant epithelioid cells that are basically going all the way to the epidermis. And I know it's a little bit hard to see these stains, but you can see that there's areas of the tumor that are SOX10 positive. NRAS Q61R is diffusely positive. So for me, in sun-damaged skin and lymph node metastasis, this is a NRAS mutated melanoma. But you can also see that some of the tumor cells are completely negative for SOX10 and S100, and there's MyoD1 staining. So this is, again, transdifferentiated melanoma with looking and starting to staining like a rhabdomyosarcoma. And you can see that, how I think it would be very easy to call this cutaneous rhabdo if you're not thinking about melanoma. So, or if you got an area where the SOX10 was dead negative. So again, just illustrating how tricky these can be. So I've also seen angiosarcomatous differentiation in melanoma. This is another BRAF mutated melanoma, which has these primitive vascular structures, and those vascular areas are highlighted with ERG nuclear staining. And, so again, this is really the spectrum, and, I think this shows that these transdifferentiated and undifferentiated melanomas are hiding out in our sarcoma practices. And both Abbas and Mira Hamid put out 2 papers which I think nicely illustrated this. In Abbas's paper, he included 85 dedifferentiated and undifferentiated melanomas and found that over a third were initially diagnosed as undifferentiated pleomorphic sarcoma, and a not insignificant amount were diagnosed as specific sarcomas. Mira Hamid looked at a series of undifferentiated malignancies and undifferentiated sarcomas over an 8-year time period and found that there were 19 melanomas hiding in that group. So again, I think all of this put together shows us that these undifferentiated and dedifferentiated melanomas are hiding in our sarcoma practice. So that's, again, the first step is just realizing they exist. So how can we, start to make these diagnoses? So in Abbas's paper, he kind of gives us some clues. If the patient has a history of melanoma and they have a new undifferentiated malignancy, metastatic melanoma should be on your differential. In his paper, he showed that, most patients presented with metastasis in about 2.5-year mark, but patients had up to a 42-year latency between their primary melanoma and metastasis. So basically, if you have melanoma, you're always at risk. Sites that are unusual for primary sarcomas, like the axilla and groin, if you have an undifferentiated malignancy at those sites, you need to be thinking about melanoma. When we have an undifferentiated malignancy in our practice at those sites, we routinely stain those for BRAF and NRAS. Obviously, sun-damaged skin, you want to look for melanoma in situ. And if you have a nodal pattern of metastasis, again, that's another clue that it could be melanoma, because typically sarcomas don't go to lymph nodes. So I know we've been talking about a lot of, advanced molecular techniques, but, not all of us have access to those tools. So what are some cost-effective ways we can make this diagnosis? Thorough sampling and looking for an in situ component. I think a lot of us, especially our trainees, have a tendency to jump right to the malignant areas, but don't ignore or neglect the surface. The clue might actually be in that component. So sample that well and make sure you're looking for any kind of in situ dysplasia. You might need to perform S100 and SOX10 on multiple blocks. This is painful, but I've had cases where one block is stained and is completely negative, but you go on to stain additional blocks and you find an S100 SOX10 positive focus. And then in terms of morphology, to me, melanoma, especially the undifferentiated variety, likes to have a nested or packeted growth pattern. So when I have an undifferentiated malignancy, especially in the axilla, which is nested or packeted, to me that's melanoma till proven otherwise. In the past, we haven't really had a good way to make this diagnosis. Molecularly, we'd have to do comparative genomic studies, which are not, practical. But in recent years, we've had this kind of next-gen IHC emerge, and we know that about 60 to 70% of cutaneous melanomas have NRAS and BRAF mutations. So we can exploit that with immunohistochemistry. And if you have access to these stains, I think they become very helpful with undifferentiated malignancies in older patients. In terms of other molecular features in cutaneous melanomas, if you do have access to more advanced molecular studies, things you can look for are a UV radiation signature. There are certain DNA changes which are indicative of UV damage, and these can be identified by NGS techniques. And that contrasts with undifferentiated sarcomas, which usually have a dominant aging signature. You can also look at tumor mutation burden, as Josephine mentioned earlier today. 10 is kind of a rough cutoff. Sarcomas usually have very low tumor mutation burdens. Melanoma is usually greater than 10 and usually much higher than that. So if you have an undifferentiated malignancy, even if you don't know what it is, if it has a high TMB and a UV signature, your thought should be something like sarcomatoid carcinoma or potentially melanoma. And finally, we've heard a lot about DNA methylation profiling this morning and this afternoon. And with Daniel's help, we showed that methylation signature of undifferentiated, dedifferentiated, and transdifferentiated melanomas seem to be kind of hardwired into the cell. So DNA methylation appears to be a useful technique for identifying these tumors when they no longer look or express melanocytic markers. And this is, I'm kind of scared to use this, but down here, this is where we have the cutaneous melanomas, we have desmoplastic melanomas, and this is unsupervised clustering. And you can see that this is where our transdifferentiated melanoma with osteosarcomatous differentiation clustered. So again, a very helpful technique. Okay, so why does it matter? Why is it clinically important? And if I were giving this talk 20 years ago, I would say it probably doesn't matter. Sarcomas, melanomas, they both had dismal prognoses, and there were really no good treatments for either. But fortunately, things have changed for melanoma. And the Checkmate study just put out some 10-year results, and it's really incredible that these patients, I think the median 10-year survival for patients treated up front with immunotherapy is about 10 years right now. So that's really, I think, a great advance for melanoma. And Georgina Long, who's done a lot of work in this space, this quote is from one of her papers, and she said, with the advent of targeted therapy and immunotherapy, it's dramatically improved outcomes, and patients now have a chance at durable disease control, if not a cure. So it's really important that we pick these up in our sarcoma practice, because the therapy is vastly different, and we basically can give these patients a chance at long-term survival. So just to summarize, hopefully I've showed you how deceptive and tricky melanomas can be, but hopefully I've also showed you some tools that you can use to identify these in your own practice. If you have access to NRAS and BRAF immunostains, these are fast, quick, relatively cheap ways to pick up a subset of these transdifferentiated and undifferentiated melanomas. And if you do have access to more advanced molecular techniques, I think exploiting UV signature and TMB could be another way to make this diagnosis. And with that, I'll conclude.
Thank you very much for that wonderful talk. We have a couple minutes for questions.
Karen, that was great. I do have a couple questions. The DermPath people use all these new immunostains like PRAME, and I don't even know the name of it, but it's something like PPL2 or something like that. Do you have any experience with staining of these tumors with that?
I don't want to get yelled at up here. PRAME, I think PRAME has its utility, but I think it's most useful in identifying benign versus malignant melanocytic lesions. I do not find it useful in determining lineage of a high-grade malignancy, because rhabdos, other things can have PRAME staining. So to me, it's more useful in the derm world, and I personally do not use it in my practice, my soft tissue practice. And the other one, I'm not even sure what it is.
Be staining everything. I forget what it's called, but yeah. Thanks.
And plus PRAME is hard to interpret, I think. Yeah. So personally, I don't use it. But again, to each his own.
Yeah, thank you. I think BRAM really is a very non-specific marker. So all entities like SMARCA4 deficient, undifferentiated, those are genuine differentials in undifferentiated melanoma are very positive. I have seen cases of anaplastic large cell lymphoma from the inguinal area coming as possible melanoma. They are very BRAM positive, so we have to be careful. I think mostly it is the reverse. If it is negative, the probability of undifferentiated melanoma is less, but it is still, I have seen cases what I call de-differentiated BRAM. So they have lost BRAM, except for a very minor focus really in GI metastasis. So it is not that reliable. But for acute cases, very ill patients, sometimes we stain it and we say BRAM is very positive. This is very likely undifferentiated melanoma, and then we go for molecular. But it is not reliable. Thank you.
Thanks, Abbas. Okay, so I realize I'm the only thing standing between us and dinner, so this should be, won't be a long talk. So my next task from Michael was talking about these PRRX1 rearranged mesenchymal neoplasms. And you know, all my life I think I've been a lumper rather than a splitter, so it takes a lot for me to really believe that something is a new entity. And as was discussed this morning, you know, I guess, Cristina, maybe you asked, you know, what is a new entity? You know, for me, I want to see reproducible morphologic features. I need to see a few cases, and, you know, I think it helps if there's a recurrent genetic alteration. And I've seen enough of these PRX1 rearranged neoplasms now that I think they actually are a distinct entity, and I'm going to teach you how to recognize them in the next 10 minutes or so. So these PRX NCOA1-2 neoplasms were first introduced by Brendan Dixon and colleagues in a series of 4 cases. And this was about 5 or 6 years ago. And from there, more cases have kind of popped up in the literature. And I kind of combed through the literature and took cases from our archive as well. And to date, to the best of my knowledge, there's about 26 cases out there. And it seems that there's a slight female predilection. And in terms of the age distribution, you can see that it's pretty broad. But I think there are some take-home points from this age distribution chart. You know, one, they don't seem to really present in childhood to date. And they seem to be most common in the middle decades of life. So I think those are kind of the take-home points. In terms of site distribution, these have these can occur head and neck, extremities, trunk, so kind of all over the place. In terms of depth, most of these are subcutaneous, although they have been reported in the skin and at intramuscular locations. This is kind of a classic example of one of these PRRX1 rearranged tumors at low power. They're circumscribed, but kind of multinodular, and they seem to look pink at low power because they're usually pretty paucicellular. This was an example that occurred in subcutaneous tissue. You can see a little bit of skin at the top. And again, circumscribed, you can draw a line around it, but they do seem to be multinodular. And I can't remember who said it this morning, but you definitely get a lot of clues from low power. And I think with these PRX tumors, it's the same. At low power, I think, to me, one of the most helpful features of these tumors are these kind of large, gaping, ectatic spaces. They seem to be relatively unique to this entity. So if we take a closer look at these areas, again, you can see these large, gaping, almost staghorn-shaped spaces. They're really not lined by anything, so I don't think they're really true vascular spaces, but again, they're one of the most, to me, the most dominant histologic features and a clue to the diagnosis. Here's another example again. They might make you think of a solitary fibrous tumor, but they're even larger than the staghorn vasculature you see with that entity. I was a math major, so I kind of think of things in formulas. You know, I think these tumors have been hidden in our practices for a while because they have overlapping features with a few other fibroblastic tumors. So when I'm looking at a tumor, and initially I think, you know, this entity, this lesion has features that are kind of reminiscent of solitary fibrous tumor, and I look around a little bit more, and I'm thinking, oh no, maybe this is a low-grade fibromyxoid sarcoma, or potentially an SEF. And then I find another area, and I'm like, oh my goodness, this is like a fat, poor spindle cell lipoma. When I find myself thinking about those three things, I look for gaping spaces, and then I kind of end up thinking this is probably a PRRX1 rearranged neoplasm. So that's kind of my approach. I know it's not very scientific, but that's really how I do it. So let's kind of go through these patterns in detail. These are all from PRRX1 tumors. And you can see that this field really does, my first thought if I saw something like this would be a solitary fibrous tumor. We had these branching staghorn-shaped spaces. We have these bland ovoid to spindle-shaped cells and a fibrotic background. Here's another field and another tumor that again is reminiscent of SFT with this kind of pink stromal hyalinization between the tumor cells. But in other areas, there's almost this alternating hyalinized myxoid or pink, pale pink zonation. And when I see that, I think about low-grade fibromyxoid sarcoma. These can actually have structures that are reminiscent of hyalinizing rosettes. So again, if I saw this, I'd be thinking about low-grade fibromyxoid sarcoma. More solid areas, you know, these ovoid cells are almost kind of arranged in chains and cords that might make you think this is a hybrid low-grade fibromyxoid sarcoma, sclerosing epithelioid fibrosarcoma. And finally, if you look at the paucicellular areas, you have these, again, very bland cells, ropey collagen, myxoid background, almost cells with these wavy nuclei, that if I saw this field, I would be thinking about maybe a fat, poor spindle cell lipoma, or a genital stromal tumor like a cellular angiofibroma or a mammary type myofibroblastoma. So something in the RB1 deficient category. Other features that you can see, in dermal lesions, they can entrap adnexal structures, so that's something you can see with these tumors. Alex Lazar and Jeff Cloutier reported a dermal lesion with admixed pigmented melanocytes, so this can also be seen in these tumors, although very low numbers to date. But importantly, in terms of histologic finding, these are universally very benign appearing. They lack any significant cytologic atypia, low mitotic rates, essentially zero. I don't think I've seen a mitotic figure in these tumors, and they lack necrosis. So very bland features. And as far as I know, we haven't seen any of these that has transformed to anything to a higher grade lesion. With the immunoprofile, I think there's good news and bad news. Bad news is there's not a good marker for this entity. But the good news is that I think the fact that they have a relatively null immunoprofile can be helpful because they lack staining for things like CD34 and STAT6 that help you eliminate solitary fibrous tumor, which is in the morphologic differential. They're negative for MUC4, again, which helps you to exclude low-grade fibromyxoid sarcoma and sclerosing epithelioid fibrosarcoma. ER is negative, so if you were thinking about cellular angiofibroma, mammary type myofibroblastoma, so things in the RB1 deficient family, that helps to exclude that. David Creighton's actually described a small cohort of cases where a subset had partial RB1 loss, and he suggested that maybe these are part of the RB1 deficient family. I'm not really sold yet. I mean, these are CD34 negative, and I think the fact that these are only partially RB1 loss really doesn't support that, but that was a hypothesis for a while. SMA and Desmond are almost universally negative, so I think that's, you know, the original classification was that this was, or thought was that this was a fibroblastic neoplasm, which I think is very fair given the cytology. The immunoprofile, again, is kind of null, except for recent work by John Gross and Laura Warmke, who showed that a small number of these can have focal expression of S100 and SOX10. Honestly, I have no idea what this means. They seem to be in the category of these polyphenotypic tumors. I do not think they're neural, but I think this really questions whether they're truly fibroblastic and maybe they come from a less differentiated stem cell. In terms of S100 and SOX10, these are some pictures from their paper. And you can see that there's some, I think, dendritic cells that are staining for S100, but there are some lesional cells which are also S100 and SOX10 positive. So, you know, these, even though this wasn't described in the initial series, you know, I think there is true staining for some of these neural markers in this entity. In terms of molecular genetics, almost all cases have had PRRX1 fused to NCOA1. The remaining case, the partner was NCOA2. The NCOA family is well known to us in BST pathology. Fusions involving NCOA1 and 2 have been talked about today. They're present in rhabdos, soft tissue angiofibroma, mesenchymal chondrosarc. But this specific fusion seems to be specific to so far in the mesenchymal tumor world. And in terms of behavior, again, these have behaved indolently, which is not a surprise given their morphology. There's no reports of local recurrence or distant metastasis. The one caveat is that, data is limited because this is such a new entity. So I think, this is to be continued, but so far there's no reason to think that these are anything but benign. Two last things I want to talk about. There are 2 cases reported that have a PRRX1 KMT2D fusion, and these one of these was reported in a large series of the PRRX1 NCOA1-2 fusion tumors. It seems that these KMT2D tumors have this distinct perivascular hyalinization, so I'm not sure that we can lump these together with the NCOA1-2 tumors yet. I think we need to see, I have not seen one of these yet, so I think we need to examine more of these and see, really where they belong, if they're part of a spectrum or they're distinct entities. And then finally, the last entity I want to touch upon are these KMT2A rearranged sarcomas, with YAP1 being the partner. These started to appear in the literature in 2019, and originally, they were thought to be a MUC4 negative variant of sclerosing epithelioid fibrosarcoma, but through gene expression profiling from Frederick Mertens, as well as DNA methylation profiling from Jessica Davis and Daniel and Laura Warmke, this seems to actually be a distinct entity. But it does have a lot of morphologic overlap with sclerosing epithelioid fibrosarcoma. And since that's in the differential of these PRX1 tumors, I think this entity, the KMT2A rearranged sarcomas, start to come into play in terms of the differential as well. These also have a essentially null immunophenotype. So if your differential is a PRX1 rearranged mesenchymal neoplasm and one of these KMT2A rearranged sarcomas, you probably need to do molecular to sort it out, although usually the YAP KMT2A are higher grade by morphology. But again, there is some overlap, and a biopsy I think would be very hard. So just to summarize these tumors, these are mesenchymal neoplasms with a polyphenotypic features. I think the cell of origin is still unclear, which is true for a lot of these fusion-associated sarcomas. I find myself thinking about these when I find a tumor that has overlapping features with solitary fibrous tumor, low-grade fibromyxoid sarcoma, and the RB1 deficient tumors. The diagnosis, I think is suspected by morphology, the gaping vessels, and the null immunophenotype. But if, this is a new diagnosis for you, I think you can, confirming the fusion is a good idea. These are, indolent behavior to date. And again, I think that the relationship to the KMT2D tumors is really to be determined once we see more of them. And with that, I'll conclude.
Thank you very much, Karen. I think we have time for one question. If there's somebody with a question, just hang on. I just would have one comment. I think the co-expression of S100 and SOX10 can be very useful, and actually I would guess it might be more common than was indicated there, because maybe in the papers before the publication of this feature, it might have been missed, because it's really focal sometimes. I had a case which was like a punch biopsy. It was completely negative for everything. When we got the resection, the tumor was SOX10 S100 positive, but in some really focal areas. And out of 4 or 5 cases I've seen, only one was really negative after repeated staining. So if you have like this morphology, S100 SOX10 focal expression and RB1 loss, I think it's very helpful combination of features to think about these tumors, or maybe even diagnose these tumors, I don't know if without molecular, but definitely think about them with high probability. So any questions? If not, I would like to thank all the speakers for their wonderful job. I mean, I did the program. I knew it's going to be very good, but this was just beyond my imagination. It was fantastic. It was also, everybody was very disciplined. I don't think we went more than 1 minute over time. So thanks, everyone. Also, thank the attendees. And yeah, I think we can call it a day. I have some information for the attendees here, so please remain seated for 1 more minute. And for those that are online, thanks for watching. I hope everything worked okay. And see everyone tomorrow at 8 a.m. Thank you.